I'm Dr. Leslie Sokol. For those of you that don't know me, I will be telling you more about myself as we move through the material this morning rather than inundating you with it right from the get-go. I've been asked to show this slide, which I've never had to show before, but I know that they asked me to show this, so I've put this up here. Okay, before we get started, how many of you have done CBT training? How many have had formal CBT training? So over there, okay. And how many of you are really a little bit new to the model? Anybody new to the model? Okay, so I'm going to ask you, regardless of how much experience you have had or how little experience you've had, to just hang in with me to look at the model through the particular case conceptualization-driven lens that I'm going to be talking to you through. Now, before we do that, if you think about your confidence in your ability to deliver CBT, 0 is you have absolutely no confidence in your ability to deliver CBT, and 10 is you consider yourself an expert. You understand the model, you know how to apply the model to a diversity of problems, and by the way, a 10 is obtainable because a 10 does not mandate perfectionism. A 10 does not mean that sometimes you don't need a consultation on a case, or you might need to read something or get some more experience with a particular topic. But a 10 says, I feel confident that I really know this model and I know how to apply it. And then we have all the numbers in between. So right now, somewhere on a piece of paper, give yourself that rating from 0 all the way up to 10. And in the context of the empirical process, we're going to see if we can't raise that number. Because my goal for you over the course of these 4 days of training is really, number one, to build clinical knowledge. And when we do a workshop like this, that's really what we're doing, is that we're building clinical knowledge. But it's also my desire that I can help you build clinical skill. So hopefully through the experience of talking and discussing cases and doing role plays and watching some videos, that skill will really grow over these next 4 days. It's also my hope that you really not only embrace this model, but that you really feel that this is something that could be an asset to your own practice. Now, it's not my goal to make everybody true disciples of the model, like honestly I am. But I do ask you that rather than thinking, how can I take this information and blend it with what I already do, for the next 4 days, I'd like you to not be thinking through that perspective. I'd like you to just come here with sort of a blank slate and say, you know what, I'm just going to put 100% of my attention into listening to this information, thinking about how to use this information directly as it's being presented. And by day 4, we can start to talk about how I might incorporate some of the skills already in my repertoire with the material that we've been talking about over these 4 days. It's harder to blend than to be a purist. Because when you see the world through one lens, your path is always crystal clear. When you have multiple lenses that you can consider information through, then you've got a multiple choice situation, and we all know how stressful multiple choice tests are. In terms of the slides, there are lots of slides. However, I do not talk slide by slide. I pretty much just talk. The slides are there more for you to be able to refer back to reiterate what I'm saying, so that you don't have to take copious notes. And I really have provided you with many more slides than even we may necessarily get to. We have a very large agenda, and I'm going to do my best to cover everything in that agenda. However, we may cover more topics more thoroughly than others. And honestly, we could take any topic and do a 4-day course on any of the topics that we're talking about. So regardless of all of our time, we still have a lot of material to cover. I also want to ask you in terms of what your goals are in terms of being here, what is it that you were hoping to get out of this 4-day training? Anything that you were specifically hoping to get out of this 4-day training?
I'm somewhat familiar with CBT, but I just wanted like an overview and a refresher for it, and to learn anything new that's come up since I've had my trainings.
Perfect. An overview of CBT, a refresher of the skills already in my repertoire, and if there's any hot new things going on, to hear what that is. Sounds very in line with what we're going to cover.
Yes, I would like to be able to apply this to clients that I see just one time, as well as clients that I'm seeing for months on end.
And I'm glad that you say something about that because, you know, often when we look at research trials in CBT, we look at trials that go on for extended periods of time. In practical purposes, we don't always have an opportunity to see people for extended periods of times for all sorts of extraneous variables that complicate the course of therapy. And so I think it is reasonable that we say, even if we get one and done, what can we accomplish in a one-time consultation or a one-time crisis intervention? And interestingly, CBT in the treatment of panic disorder, which personally I would say is the most potent place for CBT, David Clark and Paul Sikoska's work has shown that in one extended therapy session using CBT in the treatment of panic disorder, we can put panic in remission. So there's even some data to support that one session can go a long way. And, you know, and part of that I would hypothesize is that CBT is not just about helping people feel better. It's about helping people help themselves feel better. So although we may not be able to get them to their goal, we might be able to give them tools that they can use independent of us as providers to continue to work towards that goal, which would argue as well for why a limited course of treatment may still make sense. Anybody else?
I worked in a school and I saw a little boy who had severe panic disorder, was hospitalized, and was able to return because of CBT. So I was so impressed by that because he was almost rigid, frozen.
Yeah.
That I wanted to learn how that worked.
Yeah. And, you know, it's really interesting that you point that out as well, because for me, what made me a believer is when I started to apply these principles myself and people got better. And, you know, the reality is, as we talk about it, as we practice it, you know, despite the fact that you might read hundreds of studies, randomly controlled trials that support the efficacy of CBT, and still you experience firsthand the power of CBT, it's unlikely that you're going to be a true believer.
I've been to a zillion CBT trainings and a lot of testing stuff, and most of the ones I've been to are very heavy in theory, but pretty superficial, pretty light on application. You mentioned panic attacks. I mean, I was in a 3-day workshop where literally we probably spent the last 45 minutes going over all the anxiety disorders where, you know, you need more time. So what I'm hoping to get out of this is, I know we have to obviously, first part is theory, but really spending more time looking at this specific, you know, CBT, and I know CBT is a special kind of carve out anyway, but you know, just looking at things a little bit more in depth and how we can use some of the clinical setting rather than just, you know, 80% theory and let's just throw in a little data like this and that. Because I think that's unfortunately, that's how most of the, whether you do it 1 day or 3 days, how those workshops, I've done some back-schedule online training now too, which is really good. I've done a couple of those as well. That's a little different, but as far as workshops you go to, whether it's PESTI or any of the others, they're very light on actually being able to use things in a practical way.
Yeah.
So I'm hoping it will
So I assure you that we will have some clinical skill building taking place, but I invite all of you to be comfortable asking questions, bringing cases to the table, asking me what I would do in a specific situation, because the more you bring to the table, the more you're going to get what you personally are looking for. So we're going to try and make that happen. Now you'll notice it's a certificate course. PESI is not a credentialing organization. I come here as a representative not only of PESI, but of the Academy of Cognitive Therapy. The Academy of Cognitive Therapy is an international, multidisciplinary credentialing organization of CBT experts. How many of you are personally interested in becoming credentialed as a diplomat of the Academy of Cognitive Therapy? Is anybody in the room interested in that? Okay, so knowing that you're interested in that, I will make sure that over the course of this training that we also talk about what that entails and how you can make that happen. All right, let's get to it. So first of all, when we think about who we treat, and I guess I just want to take one step backwards, talking about who we treat, that for the purposes of this training, we are going to talk about adolescents, young adults, and adults through the continuum. We're not going to be talking about children, although I would suggest that the model is the same regardless of the age, but the delivery has to be modified. And the delivery of CBT to children is a sort of unique set of strategies that, first of all, is beyond my area of expertise. I'm not a child psychologist. I do work with plenty of adolescents all the way through the age continuum. So we're going to focus this training on adolescents, young adults, and older adults. Now, who do we treat? It's a very different client that comes to our office saying that this anxiety is interfering with my life, I can't stand it, what can I do? Do you think you need to see me more often? Is there anything else I can do this week that you think would make a difference? Right? Very motivated consumers banging down our door trying to get an appointment, maybe want to have an extended appointment. Very different than a hopelessly depressed client. A hopelessly depressed client thinks what? Nothing's going to work. This is pointless. Why bother? So they're not coming in. If they're coming in, they're coming in under protest. They're probably showing up late for the session. So do they come in voluntarily? Has some grown-up decided? Has some court mandated it? Has a partner in their life said you either get treatment or I'm out the door? Now, a person that doesn't come in voluntarily is going to be a different kind of consumer. Our job, though, is to make every client, regardless of they're there voluntarily, regardless of if they're there with enthusiasm or without it, is to get them to have buy-in, that it makes sense for them to be there. Doesn't matter what brought them in the door. But after a couple of conversations with them, it is our goal to make sure that they acknowledge that even though I didn't want to come, even though I didn't think it was going to help, I now recognize that it makes sense for me to be here. Which means that we can't do that until we have identified a problem and established that there's something that makes sense for us to be working on. So clients that come in the door already with discrete problems are ahead of the game. I recognize I have a problem, and if there's a way that we can address it, let's do it. Is there community support for the well-being of these individuals? We know that social support is a very powerful ingredient in wellness, and without it, your rates of morbidity and mortality increase. So what are the outside resources in the equation? Are they lacking? Is that something we actually have to work on building in the context of therapy? Are the problems new? Is it a new acute situation? The more acute the symptomatology, the more powerful our tools are going to be. The more chronic the symptomatology, the less powerful our tools are likely to be. Because when problems are chronic, then we have allowed our perspectives to shape the way we behave for long periods of time. And those behaviors of avoidance and withdrawal and isolation have provided data to fuel an idea that may not have been true to begin with. Or imagine the person that thinks they're not capable, and for 20 years, because they think they're not capable, they haven't tried. So all the data is very unattractive. And so it builds the case. And it's harder to modify it. How successful are we going to be? In terms of, is the end of treatment the end of us seeing them? I would suggest that the end of treatment in CBT doesn't stop when we physically stop seeing our client. The treatment continues forever because hopefully we have given them the tools to help themselves. Now let's think about goals for therapy. So somebody comes into therapy and we think, how clear are these goals on a scale of 0 to 5? It's not clear at all. It's very vague. I have no idea what we're working on. And a 5, it's crystal clear. What are we working on? So a client comes in and says, I want to work on increasing my self-esteem. How many think that that's a very clear goal? Give it a 5. Anybody? How many of you think that's a 4? A 3? A 2? A 1? Okay, no zeros. So clearly it's not a 0, it's a definition of something, and boy, we got a rough crowd here because you're beating it up pretty bad. I would say that increasing self-esteem is not an unreasonable goal, and I'd probably put it in the 3 zone. Okay, there's some sense of direction. But we all agree that it's not really very clear what does that mean. So we need to ask, what would it look like if your self-esteem was improved? Well, maybe I would be able to make decisions independently instead of always having to consult with a zillion other people. Maybe I wouldn't always be second-guessing myself. Maybe I wouldn't be preoccupied with having to make the right decision. Maybe when something didn't go my way, I wouldn't let it plummet how I feel about myself. Or maybe I wouldn't be so reactive to the opinions of others or so preoccupied and concerned about what other people think about me. Everybody's idea of how their self-confidence is negatively impacted is different. So if we're going to be able to address improving their self-confidence, the first step is actually going to be figuring out how is your lack of self-confidence a problem. Before we can establish a goal, the first step is always identifying the problem. In what way does your self-confidence get in your way? In what way is your self-confidence a problem for you so that we know what we need to be working on? How about the goal, I want to get along better with others? Would you say that's another one of those middle-of-the-road goals? I'd say it's one of those middle of the road. Okay, I want to get along better with others. That's not an unclear goal. It's just not an exceptionally clear goal. Again, in what way are you not getting along with others? Define the problem first, and then the goal becomes very easy. Okay, well, we want to find alternative strategies that help you get along better. What would it look like if you got along better? Well, if we know what it looks like when you're not getting along, it's going to be easy to figure out what the corollary is. How to get my family or my peers to stop trying to make me come down a notch or two. What do you think about that goal? Anybody see any problem with that goal? Exactly. We are powerless to control other people. We have no way of making anybody stop doing anything. Now, the reality is there might be an opportunity for some assertiveness training and at least ask for what we might want. But even if we ask politely and even if we ask assertively, it's very likely that what we want other people to deliver still isn't going to happen. So we have to help them see to get the family to do anything is not a reasonable goal for us, even though sometimes we can talk about strategies that maximize getting the cooperation or what you're looking for. Now the question is, what could we work on alternatively? Well, instead of working on what they deliver, we could work on not letting what they deliver impact you in the negative way it's impacting you. You know, whether or not your self-esteem plummets, you come down a notch or two, is something that you have power over. So we may not be able to stop what's coming at you, but we are going to be able to impact how you process it, how you let it affect you, what you make it mean. I want to get my parents, the courts, the teachers, the boss, the friends, the coworkers off my back. Again, same problem. You know, we do not have control of other people. On the other hand, are there things that you are doing that have problematic consequences? Are you aware of the role that you might be playing that's getting a reaction from others that's a problem for you? Would you like to get a different reaction from other people? Are there other strategies that you're not using that you might be interested in trying out in order to see if it's possible to get a different reaction from other people than the reaction that you're getting? I want to apply to sainthood because of how I have suffered through my life. I want vindication. Again. A pretty unrealistic goal. But on the other hand, what is the person really looking for? What do you mean that you want vindication? What do you really want? Do you want acknowledgement? Do you want validation? Exactly. And the question is, do we really need validation from others to be validated? You know, what is it that you've delivered that you think is valuable or special and deserves some credit? Well, maybe what we need to be working on is you giving yourself that validation, you giving yourself that credit, you patting yourself on the back for the achievements or the efforts that you have put forth. I want to feel better. Well, I think that that's actually a reasonable goal, because what is our goal as therapists? Our goal as therapists is to reduce distress and improve functionality. So reducing distress means you get to feel better. So absolutely reasonable goal, but is it a clear goal? No. In what way are you not feeling okay? Again, we define the problem and then the goal becomes very easy. And then all of the above, well, all of the above might apply once we modify all of the above into more reasonable goals. So, the first thing we do with every client is establish a problem list and a goal list. Because without that, we have directionless therapy. This is evidence-based, which means everything is sort of a scientific process. We're here to get work done. We're here to help you, yes, feel better, but we can't help you feel better if we don't know what's causing you to not feel okay. So the first step with every client, obviously after we've done a diagnostic evaluation and we've assessed them, we've gotten a little bit of their background, is establish a problem list. Now, I'm going to bring this a little bit forward. Is there anybody in the room who has a fairly new client that they have just working with that presents with some problems? Anybody want to volunteer to share with me? Do you want to share with me that client? And do we have a microphone for the attendees to use? this.
population, I can talk pretty loud.
Okay, great. Okay, so I need a one sentence demographic on this client and their diagnosis.
My client's diagnosis is early stage dementia. She is having difficulty living safely alone at home and doesn't want to change.
Okay, so problem one on her list then would be,
She's not taking her medication as prescribed.
okay,
She's skipping meals.
she's in an unsafe living situation.
She lives alone. And has very limited support.
She has early signs of dementia. And she doesn't have any mood disturbance. She's not bothered in any way by that.
No, she is less worried than everybody else.
So interesting. But the world around her is worried about her. Is that a problem for her that everybody else is worried about her? I suspect so, if they're asking her to do things she doesn't want to do.
Yeah, she's very pleasant about it, but she just doesn't understand the problem.
So would she say that it's a problem that she's not taking her meds?
Yes.
So she agrees that that's a problem. Would she say it's a problem that she's skipping meals?
No.
Would she say it's a problem that she lives alone? No. Would she say that it's a problem that she's showing signs of early dementia?
Yes.
Okay. And is it a problem for her that the world is concerned about her? So, what a little. So interestingly, here we have a case where there's problems on her problem list that she doesn't recognize are a problem. Well, let's start with the ones that she does. So why does she think not taking the meds is a problem?
Because she might take them more than once, because she didn't remember taking them.
Uh-huh.
She did her herself.
Uh-huh. So she has a little bit of a fear of hurting herself. That's awesome. So we know she's invested in her well-being. And I say, that's great that she's invested in her well-being. And I don't want to accidentally make a mistake. So then one of her goals is what? What's one of her goals? To take her medication appropriately, right? So take the meds as prescribed. And one of the obstacles is forgetting. So if we could come up with ways that would make sure that you didn't forget, strategies or outside help to maximize that, would that be something that she might be receptive to?
Yes.
Okay, so we're going to try to work on strategies to not forget or outside help to make sure it doesn't happen. And notice that already knowing on her problem list that living alone with limited support is not something she thinks is a problem, but it's something we think is a problem. As we already are establishing that first goal, notice where I'm going with that. I want to get her on board to recognize that this is a problem. So now we have a goal that says, oh, I don't want to accidentally do harm. And, maybe getting outside help might be a good thing to prevent that from accidentally happening. I'm skipping meals, and why is it a problem that she's skipping meals to other people? She's underweight. And she's not concerned about her weight?
No, she figured you can never be too thin.
Yeah, right. So, but interestingly, she doesn't want to accidentally take too many pills. She doesn't want to accidentally make herself sicker. She doesn't want to accidentally die, right? So is your goal then to be well? Is it your goal to be physically healthy? Would she say that's her goal?
Yes.
Okay, so my goal is physical health. And physical health would look like what? Would it mean that you had some strength?
Yes.
Would it mean that you would be physically mobile? You would be able to, so you would be mobile. Would you not be tired all the time? Yeah, so not too tired. And if I told you that your weight, being underweight, was compromising your ability to be strong and mobile, and it's causing you to have extra fatigue, would it then make sense that we might want to stay on top of that weight issue so it doesn't get in your way of your wellness that you're really trying to achieve? Okay. So now we had a problem that wasn't a problem for her, that we've got her engaged in being to work on a goal that we all know makes sense for her to be working on. Again, lives alone is not a problem for her, right? She says that's not a problem for me. And yet living alone, interestingly, that as we're talking, your weight, your lack of nutrition, your not being able to take the meds in the way that make the most sense for you, do you think that living alone maybe contributes to some of those other problems?
She doesn't care.
But the thing is that we don't necessarily have to make her not live alone. Do they want her to move into a different residence? Is there something that's going to be imposed?
She needs part-time private duty caregivers.
Exactly. So we're not saying you have to leave your home. But again, so do you like living alone? She'd say yes. Do you want to continue living alone? But if living alone the way you're living is going to compromise these goals that you've already talked about are important to you, would you be willing to consider a goal to bring resources into your house that allow you to continue to live alone without compromising your wellness, without compromising your safety, without compromising your health?
Yeah, we
Oh, awesome. So meet with outside help and maybe consider how to let it sort of happen. So we can look at the pros and cons of different options and see what makes sense in the equation so you can have what you want, because your goal is to be independent and to live in my home, but safely and not accidentally do any harm. Is that right? I think we're on the same page. Early signs of dementia, is that a problem for her?
If she recognizes that she doesn't remember things and she gets confused.
Yeah. So, it'd be great if our goal would be to not be confused, remember everything. And I would be right on board with you, because I struggle with that too. But the point is that, again, we don't want that to get in the way of your goal. So it's interesting that we could say that this is really more fuel. It's really just more fuel to work on these other goals that we've been talking about. Now, it's interesting, the world is concerned about you. And in what way does that create some problems for you, that the world is concerned?
Well, it's lovely that everybody's coming in. I really enjoy the company.
Oh, so that's actually a positive thing, that the world is concerned. It's not a problem. And if everybody's coming in, do you think that's going to, help you stay healthy and mobile and independent?
Oh, yeah, I'm using the cues.
Uh-huh,
And I have my medicine for the coffee pot now.
uh-huh.
So I don't have to take it in the morning.
So maybe then a goal is to continue to embrace the help that I'm getting and be receptive to it and to be open-minded to it, because actually they've gotten me to try some things and they've worked. That's awesome. Now that we've been talking about what we're going to be doing in here in our conversations together, how do you feel about where we're headed?
I feel good.
And hopefully that's what your client's going to say. So, any feedback on that little dialogue?
It's really like you're almost using motivational interviewing to help provide them to the point where they recognize that, oh, yeah, there's some value in maybe looking at making some changes.
And that's really is exactly what we're doing. The first step in CBT is buy-in. Look, I haven't even talked to you about the model or anything else because the first step is buy-in. Buy-in is motivational interviewing. And motivational interviewing is a very powerful therapeutic tool and has efficacy in and of itself. And I would say that we all can benefit from motivational interviewing skills because buy-in is the essential first step. And what I hope you get from this is one, that a problem needs to be defined. How is the problem a problem for that person? And even if it's a problem that they don't think it's a problem, we can help them recognize why it might actually be a problem. And most importantly, when we get them to recognize that the goals are what they want, they're actually going to start to be receptive and engaged in the treatment. Also, imagine the client that comes to you hopeless. And now you've demonstrated that you understand their problem and that you have a plan to do something about it. You've just increased hope.
I don't want to sound like he what I'm going to. That would be setting up for being careful, setting up for failure. Some of these might not be realistic.
Okay, right.
Then we get into homelessness and ex-convicts, veterans, PTSD.
Yeah.
Other stuff. Might not be available. But I'm just looking forward to going forward with this.
Yeah. No, but you raise an important point that the goals that we are establishing do need to be realistic goals. So if this was a woman that was going to be forced out of her home, these goals wouldn't make any sense. They're not realistic. They're not possible. So absolutely, we need to make sure that the goals that we are working towards make sense. Now, listen, the reality is a goal that makes sense right now, today, may not make sense a month from now, let alone 2 months from now. And that's the beauty of therapy, is that it's flexible and that change is possible. This is not a rigid instrument. This is a fluid thing. Goals can change over time. It also may be that in the context of therapy, we may not be able to achieve all of the goals that we were hoping that we could achieve, but maybe we could make some movement on them, even if we can't get all the way to the point where we wanted to get to. And then what do we have to do? Then the goal has to be modified. And maybe the goal becomes accepting what I have. Let's say the goal was, I would really like to be gainfully employed again and, have money to do some of the things that I have been unable to do. And maybe in their struggle with bipolar illness, sustaining employment is not something that's really going to be obtainable for that person. On the other hand, maybe they get a Social Security check every month. And maybe, despite how small that check is, by cutting coupons, by going out to McDonald's with her neighbor and sharing one Coca-Cola, maybe by in the mall, every time they ask you to fill out a survey, she fills out that survey and makes that $1 for filling out that survey, she can supplement her income. And I'll say, you know, it's really interesting. You take that check you get every month and you make an effort to, you look at all the sales, you stock your freezer, you buy as many fresh products as you can, and then you cook up lots of things and you freeze smaller portions to have. You always allocate a percentage of your money to take care of your most important things in the world, your kitty babies, and you make sure that they get actually better quality of food than you do and get all of their treatment. I'd say, is that a full-time job? Yeah. You get a paycheck, and why do you get that paycheck? Why did you qualify for this paycheck? In her case, she had worked for many years. I said, you put in your dues, you know, you get this paycheck, and what do you do with this paycheck? You budget it, you run a household, you take care of your kitty babies, you take care of yourself, you stretch things miraculously. I'd say you're full-time employed and you're doing a darn good job of it. Wow. Gainful employment is no longer needs to be on our agenda. It wasn't a realistic goal. It's never going to happen. So, as cognitive behavioral therapists, regardless of the etiology of a problem, trauma, biology, hormones, childbirth, a trauma event, loss, doesn't matter. Regardless of the etiology, once a person is clinically impaired, a problem in thinking is occurring. And our job as CBT providers is to be able to identify the problems in thinking and correct it. If there's not a problem in thinking, then we're not correcting something that isn't a problem. But sometimes our thinking is unhelpful, even though it's not distorted or erroneous. So our job is to correct the problems in thinking and reframe the ways that we're thinking that are problematic for us. So all psychological problems involve problems in thinking is a necessary premise for us to move forward in talking about all the diagnoses that we're going to be talking about over these next bunch of days. I also want to say that in a comprehensive package of treatment, we can't just understand the problem. We have to also understand the person. And we're going to spend a lot of time today really looking at individuals directly through the lens of the cognitive model. Now, if we think about the history of CBT, I come here as a disciple of Aaron T. Beck. But Aaron T. Beck is not the only one right from the onset that was writing about the principles of the cognitive model. There were plenty of other people at the time, and these ideas didn't start with Beck. You know, they started pre-Beck, and if we think about it as sort of waves, as some people do, we might say the early wave of therapy are people like Freud and Adler and Horney and Sullivan and Erickson. And that as we moved from the early wave of the precursor to CBT, we moved into Beck and Ellis. Ellis and Beck were saying the same things. And by the way, the biggest difference between Beck and Ellis is that Beck was a scientist, that Beck was a researcher. And that's why every idea he had was validated by science. and is why the cognitive model, as espoused by Beck, became a more powerful path than Ellis's path. And I'd say the other really big distinguishing variable between Ellisonian therapy, REBT, and Beckian therapy, CBT, is guided discovery. And guided discovery was linked to Beck's idea that each person had, as an individual, had a different set of situation-specific thoughts versus a generic idea that we all shared. And so this process of guiding a specific individual to look at their specific ideations was a direct Beckian concept. And then we have Bandura and Seligman and Linehan. And so I've just made a list for you of each big player and what they brought to the table. You know, Marshall Linehan's work on dialectic behavioral therapy, Stephen Hayes' work on acceptance and commitment therapy, Wells' work on metacognitive therapy, Jeff Young's work on schema therapy. So if we think about that first wave, you know, the work of the early players, Wolpe's work, who was also trained as a psychoanalyst, just like Beck was, looked at the role in the impact of interfering behaviors. He really was the one that got us thinking about sudden subjective units of distress, which is what we talk about when we're going to talk later about anxiety and exposure work and facing our fears. So the precursor for all that exposure that we know is critical in addressing PTSD symptoms and critical in addressing anxiety symptoms, specific phobia, where cognitive restructuring alone is not efficacious. We need to expose ourselves to the thing that we're afraid of. And then we come along, and again, we have Beck, and we have Ellis, and Meichenbaum, and Lazareff, and Mahoney. And then when we think about third wave, this is still people that are looking at the world through the cognitive model. How we think influences how we behave. That's the basic model. Still looking at the world through that lens, but elaborating on it, focusing on different pieces of it. If we think about Stephen Hayes, acceptance and commitment therapy. But the truth is, and you will see it woven into lots of the examples that I present, that we're going to see that acceptance and commitment is not a new idea. This is not modern CBT. That right from the inception of CBT, acknowledging one's symptoms, accepting them without judgment, and choosing to act appropriately is in every book that was written pre-Stephen Hayes. If we think about Marshall Linehan and DBT, dialectic behavioral therapy, it's still based on the basic principles of CBT. But what she brings to the equation is added resources, skill building, awesome skill building resources that actually those skills brought into the classroom of our youth have been shown to diminish suicide rates. So very powerful tools brought to the equation, especially with our more challenging personality impaired populations. If we think about Zindel-Siegel on mindfulness-based cognitive therapy, and the work that he has done, especially in the treatment of chronic, severe, unrelenting depression, and the use of mindfulness, where there has been shown to be more powerful efficacy than in other area. That's really where mindfulness can bring a unique asset to the table. But not that mindfulness is not another tool to be used in a package of treatment. As a treatment in and of itself in isolation, there's not a lot of data to support that. Doesn't mean there won't be data. You know, Zindel, who is the expert in mindfulness-based CBT, will tell you that unless you practice mindfulness on a daily basis, 7 days a week, 20 minutes a day, that the research says that you will be ineffective in bringing mindfulness to your therapy itself. So if you want to use mindfulness with your clients, you must practice mindfulness yourself. That doesn't mean the rest of us, for instance, myself, that doesn't practice mindfulness on a daily basis, can't bring some of the principles of mindfulness into some of the work that we do. And then we might think, how has CBT evolved? Well, the model hasn't evolved. It's the application of the model that has evolved. You know, why did Beck start talking about depression? Well, it wasn't because they were only thinking this was suitable to depression. It was because Beck at the time was a scientist in a lab, and it was a depression lab. And what he was trying to do was he was trying to find support for Freud's ideas of depression. And really interestingly, while he was working in this lab, seeing clients, he started to recognize that people had thoughts and were sharing their thoughts with him. And he started to see that the content of one's thought was directly relevant to the affect that they were experiencing. And the content of their thought could be manipulated by the situation changing. So he started to show up early, or he noticed in showing up early, he would get a different response. So he then purposely started to show up early. So he would take someone 15 minutes early, bring them back, and he would ask them what they were thinking. And the clients would respond with things like, wow, I must be really not doing so well that you feel that we need to get started early. Or I feel like you really care about me because you always give me this extra time and we get started early. I must be really important that you always take me right back, you know, the minute I'm there in the waiting room. And then he would start to show up precisely by the minute on time and finish by the minute on time. And he would ask people what they think. And they would say, well, this seems very non-personal. This seems like I'm just another number in the line. I don't know how I feel about this whole experience. In fact, I'm feeling a little angry about this experience. And then he would be 15 minutes late, 20 minutes late for people. And he would ask them, what are you thinking? And they would say, well, I guess I don't matter, you know. I guess I think that's pretty disrespectful. You don't respect me. You don't care about me. I'm feeling really sad. In fact, I'm also a little anxious because I'm not going to have enough time to be able to be helped. So what he realized is this is really how his early writing about CBT really started. That the manipulation of variables had an impact on thought because it was our perception of what was going on. He wasn't purposely doing any of those things that people were perceiving. He was just running an experiment. But that perception of the event directly influenced and shaped the affect that they were experiencing. And so what happened over time is that this basic model, how we think influences how we feel, was put into practice across problems. You know, so every diagnosis in the DSM. And then in Beck's latter years, as he continues to this day in his mid-90s, you know, his focus has been on CBT-R, CBT recovery in the treatment of psychosis. And interesting, again, it wasn't like they just said, oh, let's try CBT with schizophrenic individuals. What happens is that we had a lot of individuals with psychosis that did not respond to medications. You know, medications didn't work, even if they were compliant. Of course, we also had the problem that nobody was compliant, and there was these horrific side effects, and we were having all kinds of complications. Plus, when there is psychosis in the equation, there are lots of negative symptoms as well, depression and anxiety. And that they found that in the attempt to get better medication compliance, they started to use the principles of CBT. They used CBT because nothing else was working. They used CBT because they knew it was effective in depression and anxiety. Maybe it'll be effective in depression and anxiety with individuals with psychosis. And sure enough, Neil Stoller's research, really showed the power of CBT in treating the negative symptoms of schizophrenia. And then what happened? Trial after trial started to show the power of CBT in treating psychosis. John Rush's work, again, in serious mental illness, in bipolar disorder. And then we started to apply CBT across medical problems, fibromyalgia, chronic fatigue, pain management, irritable bowel syndrome, migraines. And so, again, it grew in its diverse use, not necessarily in the model itself. And then we started to look at neurological factors, which is really where a lot of the state-of-the-art research right now is looking at biochemistry and how can we enhance emotional learning. Now, people do have, and I also want to go back to this just for 1 minute and say that at the Academy of Cognitive Therapy, we are a large, inclusive organization, meaning that we are a pool of people that support evidence-based treatments. And evidence-based treatments are based on the same thing. They're based on the cognitive model. The delivery changes. So under the same model, CBT model, we would say DBT falls under the CBT model. Prolonged exposure, cognitive processing therapy, acceptance and commitment in some ways might fall under that model, though probably not exactly, maybe as a little side link over there. But if we think about any intervention, any protocol, any system of thought that's based on the cognitive model falls under our very large inclusive model, evidence-based treatments. And that's why at the Academy of Cognitive Therapy, Marsha Linehan herself sits on our board as a distinguished founding fellow of the Academy, alongside of Dr. Aaron Beck, his daughter Judy Beck, myself, Jess Wright, and I point that out because Jess Wright is a psychiatrist, I am a psychologist. We are also an organization inclusive across disciplines. You don't have to be a psychologist to provide CBT. Psychiatrists, social workers, counselors, physician assistants, any provider that is licensed to be able to provide mental health services is under the umbrella of the Academy, capable of certification. If you provide mental health services somewhere where a license is not required for you to provide those services, then we can certify you at the Academy as a provider of CBT. If you live somewhere where your discipline requires you to carry a license, then we're going to require you to carry a license. Also, there's a misperception that CBT and CT are different things. It's semantics. It's all the same thing. The B was always in the equation. There was never not a B. And Dr. Beck says it was arbitrary that when he started writing about his ideas, he called it cognitive therapy. He was having dinner with his wife, Phyllis, who's a judge, and really it was arbitrary. What am I going to call this? Yes, the power was in the cognition, but it wasn't at the exclusion that B wasn't in the equation. And interestingly, the Center for Cognitive Therapy at Penn was where Dr. Beck housed his research throughout the course of his life. And his daughter opened a facility independent of the university, the Beck Institute for Cognitive Therapy and Research. And as the cognitive therapy was being applied across the world, and across the continents, the language came a little bit confusing. Is CT different than CBT? And to unify us globally, you know, the lingo now is to say CBT, so that we're all speaking the same language. And in fact, the Beck Institute has changed its name to the Beck Institute for Cognitive Behavioral Therapy. Those of us that call ourselves cognitive therapists, I still call myself a cognitive therapist, are typically those individuals that were directly trained at the Center for Cognitive Therapy by Dr. Aaron Beck directly. Now, BT, behavioral therapists, pure behavioral therapists, are not CBT or CT providers because the C is not in the equation. The learning is not made explicit. In the CT, CBT, the learning is explicit. The focus is on cognition. In BT, the focus is on exposure. Question?
Yeah, what about the E?
But-
What is that non?
You know, that's a very interesting question. Why is the E not in the name? And in fact, there is some data now that we can intervene at the E. So I don't know, maybe the E will be in the name eventually, maybe the N will be in the name eventually as we move into neurology and we move into biochemistry. So that's an interesting point.
Because our EBT has a,
Yes.
so are you going to differentiate between those two at some point? I mean, I know you did real briefly.
No, we're not really going to talk about, we're really going to focus on the CBT model. So let's look at some of those myths. Is CBT supervisual? You're going to be very convinced before we get to the end of today that clearly that is not the case, because we cannot understand a person without understanding their past, without understanding how they think about situations and how they think about themselves. That is the opposite of superficial work. Does it get to the real problem? Well, I would suggest, just by our little demonstration this morning, that clearly the goal is exactly that, to get to the real problem. Is it quick and dirty? It's goal-directed. It's goal-directed. That means it's efficient. It means that we're not necessarily going to be having a conversation indefinitely. My goal is to reduce your distress, improve your functionality. Once we achieve our goals, or I've given you the tools to achieve your goals, it may not make sense for us to continue to work together. So it can be quick and dirty in the sense is that sometimes it's very, very efficient. Sometimes a couple of conversations is all it takes to put somebody on the path that they want to get on. Sometimes one dramatic conversation can make a profound difference in where a person is headed. Now, the research, the randomly controlled trials, show that acute symptoms of Axis 1 problems remit typically in 2 to 3 months of treatment. So that's why, you know, often you say 12 to 20 sessions. It's only because in 12 to 20 sessions we put Axis 1 into remission. It doesn't mean that everybody's ready to be discharged in that period of time. And there's plenty of people that need a lot less than 12 to 20 sessions. And I would say partly, you know, the research has sort of biased this perspective because, listen, research is funded. There's not funding to run trials indefinitely. So they run trials until they see results. And we do know that we get acute symptomatology, we see results within 2 to 3 months. But that's not to say that every client is done. We know that when we treat personality disorder, that the course of treatment is often 1 to 2 years before somebody really has been able to modify their belief and modify their behavioral strategies to increase functionality. It may be in the course of treatment that in order for that person to sustain stability, to keep them from attempting suicide, to keep them from being in a partial day program or continually hospitalized or having their medications constantly modified, that a dose of therapy is a better option. And we might say that in some more seriously mentally ill individuals, that ongoing regular therapy may be warranted for an indefinite period of time for them to sustain stability. But you might actually find, even in our most impaired individuals, that over a period of time, which might be years, that the dose of therapy can shrink. So see you once a month, see you every other month, see you twice a year, till maybe we really don't need to be in a regular course of therapy. But when they start to unravel, the door reopens. And I would say that for most of us in the field, that once that door has opened, that door will always be available. To my clients, once the door is open, the door is always open for you to come back in. Because sometimes life circumstances get the best of us, or we get rusty, or we stop using the things that we know are in our best interest, and it's an opportunity to get that tune-up and get back on track. And we know that often when you come back for round 2 or round 3, the round is quicker, and we can get right on top of it and put those principles back into use. Does it require much training? Well, I would say to be proficient in the delivery of CBT, it actually requires some rather intense training. And again, clinical knowledge is not enough. The only way that you know that you're delivering the principles appropriately is to do it in a supervised fashion. So I would argue that nobody really can, that it would be really unlikely, I should never make an overgeneralization, but it'd be very unlikely that anybody would become proficient in the delivery of CBT without having a CBT supervisor making sure what you're practicing is the appropriate thing. So I would then say, but does it require, years of training? No. I am currently involved in the largest dissemination project in the United States ever to be taken. The Academy of Cognitive Therapy, in partnership with Harbor UCLA and LA Department of Mental Health, is training over 2,000 mental health providers in LA County in CBT for depression, anxiety, and trauma. We give a 3-day training, like I'm doing with you, and then they have 16 weeks of supervised group phone calls where they submit audio and written work samples of their cases, which are supervised, and then they come in for a booster training. What we are showing, and this is our 5th year into this trial, is that in that period of time, we're able to bring everybody, every single person, I shouldn't say every, but 90-some% are able to deliver the principles of CBT. And the majority of those individuals are able to deliver proficiency of CBT at an expert enough level to become accredited by the Academy of Cognitive Therapy. And honestly, before we started that trial, a lot of us had expectations that it takes a year of intensive training. We proved it doesn't take a year of intensive training, but it does take some intensive supervision to bring your skills up to proficiency. Culturally sensitive. So as we talk further about conceptualization, you're going to see how important cultural variables play a part. And because we don't prescribe or interpret, we elicit the raw data from the individual, that helps it be culturally sensitive. I've never stood in your shoes. No, I'm not from a world that you're a world of, but help me understand your world. Tell me about it. What was the message that your grandmother gave you and your mother reinforced? So we are sensitive to really understanding the individual, not just through how they think themselves, but through the world that they were a part of, through the culture that they participate in, through the geography that they lived in, or the marginalized experiences that they had. Debate, we're not here to debate, though I must say, there is a grain of truth requires debate of argument with the patient, I would say there's a grain of truth. When you have an actively suicidal or homicidal patient and you're fighting for their life, I would say I get pretty aggressive in trying to help them consider an alternative viewpoint.
Is the debate, though, part of the intervention?
Well, that's the whole point, is that we would say it's not a debate. It's really not a debate. It's a guided process. It's a process of looking at data and making meaning of it. And we're going to focus a lot of the work in here that we're going to be doing over these days at developing that specific skill, because that's the art of CBT, that it's not intended to be a debate. It's really intended to be a conversation that leads us to new conclusions. Though sometimes it might look a little like a debate. Avoids or derides pharmacotherapy, the opposite is true. CBT providers are pragmatic. Look, the truth is, if an intervention works, it's probably a good intervention regardless. But we're pragmatic. And often there are problems where pharmacotherapy is a necessary ingredient in the equation. When we look at substance abuse, we might say that pharmacotherapy is an important part of the trilogy, which is CBT, social support, and pharmacotherapy. Clearly in the treatment of depression, we know that some people have a CBT brain and some people have a medication brain. That is the work being done at Emory University. They randomly assign, and this is Professor Craighead and his colleagues, they randomly assign people to an SSRI and to CBT. These are clinically depressed individuals. And they do PET scans of their brains every week from start to finish. And what they find out is that the brain chemistry of individuals that respond to CBT is different than the brain chemistry of individuals that only respond to medication, because there are some individuals that don't respond to CBT. And there are some individuals, no matter what SSR you try, don't respond to medication, and their brains look different. Wow. This is state-of-the-art stuff. Imagine scanning our clients' brains and saying, you're a medication candidate, you're a CBT candidate, and guess what? You might be benefited by the combo treatment. And in the treatment of depression, one might argue that combo treatment might be an advantageous strategy. But for the individual that doesn't respond to medication, then we know that regardless of whether you tried meds first or CBT first, CBT is going to be equally powerful. That's the good news. And if you don't respond to CBT, so you're delayed in getting your medication, doesn't matter. The medication is still going to be just as powerful for you if you're a responder to medication. And so we're absolutely open-minded. If we think about the new directions in neurology, in the treatment, particularly in the treatment of depression, where we have TMS, we have the magnet works, we have brain stimulation, so listen, sometimes ECT, which is an efficacious treatment in severe depression, is a reasonable adjunct to what you're doing in therapy. Now, on the other hand, when we think about anxiety disorders, the research, and Stefan Hoffman just did a meta-analysis on this, the research on this is very interesting, that says that CBT or pharmacotherapy alone is more effective in treating anxiety disorders than the combination treatment. So we might be doing a disservice by putting meds in the equation. And if you think about some anxiety disorders specifically, like panic disorder, you might argue that pharmacotherapy, especially fast-acting anxiolytics like benzodiazepines, are contraindicated in the treatment of anxiety because they prevent learning, because they avoid the problem that you're trying to examine. If you think about trauma and stress-related disorders like PTSD, we know that there is no pharmacological intervention that has been approved in the treatment of post-traumatic stress disorder. Doesn't mean that we don't use meds to address symptoms, but the only effective treatment to date in the treatment of PTSD is CBT. Now, and all CBT treatments for PTSD have the same components, even though we have different deliveries of the model. Prolonged exposure, cognitive processing therapy, CBT, EMDR, and we will talk more in detail about all of those later in the week when we move on to talk more deeply about PTSD. The focus on empirical support is not a distraction. There is a reason why we do mood measures. There is a reason why we check in with people, because we want to know, is this working? Are you gaining something from this conversation? If you're not gaining anything from this conversation, then maybe I need to make some changes. Maybe we need to bring in some of those adjunctive things to help this process along. Does not attend to the therapeutic relationship. Well, that is the most false misconception, because CBT, what did I tell you? It's making meaning of data. Data is the essential ingredient to therapy being able to take place, which means that you need to tell me your secrets. You need to tell me the most personal, intimate, uncomfortable information about yourself and your life. Are you going to tell your secrets to somebody that is judging you, patronizing you, making fun of you, sharing your secrets with everybody else, using your secrets against you? That's dangerous. So if you think about it, the relationship is an essential part of all therapy, but I would say even more essential in CBT, because if you can't be honest with me, I can't do this therapy. Which means that typically in therapy, we start from the first minute working on that relationship, but we're problem focused right from the beginning. So hopefully as we're working on problems, we're working on that relationship, and the reality is, if you help somebody feel better, what happens? They like you a lot, regardless. But there are going to be clients where you're not going to be able to get right to business. There are clients where you're going to have to take longer to work on that relationship. If I'm working with a paranoid schizophrenic, they're not going to tell me what they're thinking. So that relationship could take a very long period of time. If you're an avoidant personality and you don't want to feel distress, that might take a long. If I have a mistrust schema, why am I going to tell you anything that's going to get me connected to you, because you're going to abandon me, so I don't want to invest anything. So the pace of therapy is going to be contingent on how much energy we have to put in developing that relationship and gaining that trust and being able to move forward. And I would say it has to do with how acute the symptoms are as well. When the symptoms are acute enough, the individual is more invested in doing anything to feel some sense of relief. And then avoids the discussion of the past. I've already said, and we're going to focus a lot on exactly how untrue that is. Now, I probably should say something a little bit about myself, because I haven't talked that much about myself. I come to you as an expert in CBT. So that's why if you ask me, let's talk about REBT and CBT, the problem is that I can't, because I know a lot about CBT and not a lot about anything else. And part of that is because I was a graduate student at the University of Pennsylvania, where actually I actually started out getting a PhD in sociobiology. But I was living on an island where a boat would bring me supplies. I had my clipboard and my Jeep. I was studying feral burrows. I was about to start my PhD in sociobiology, and I had an outhouse. And honestly, I really decided that outhouses and I were not compatible. I needed a career with indoor plumbing. So what happened is I called a professor and I said, I need to go into psychology instead of animal behavior because I really need a bathroom. I'm sorry. And actually, that's how I wound up in psych graduate school. And I started out getting a degree in quantitative psychology, a PhD in quantitative psychology, because I was all about independent and dependent variables. I didn't really care if they were bacteria, animals, people. It didn't matter to me. I came at it from a scientific perspective. And while I was at Penn getting my PhD in quantitative psychology, a professor of mine and I was crunching all the professors' data. That was my thing. I was back in the days when we wrote Fortran. We didn't have laptops. We punched key cards and we went into the mainframe in a large building and did our statistical analysis. It was a very different life back then. So I got to make a lot of money crunching a lot of professors' data, and a lot of professors were doing research in CBT. And one of my professors said, you know, while you're here, why not get a degree in counseling psych as well as a degree in quantitative? It will shape your research. And interestingly, Dr. Beck himself strongly believes that every researcher in the field of CBT has to be proficient as a clinician, that your research is not going to be as good if you haven't been in the trenches yourself. And that is why Dr. Beck at the Beck Institute had a scholar program where all the heavy hitters in the research world of CBT got a year of free clinical supervision to sharpen their clinical skills with the belief that it would absolutely impact and shape the research trials that they were running. And I was fortunate enough to be that trainer of all those heavy hitters, providing them supervision and clinical skill. So here I was at Penn getting my 2 PhDs, and Dr. Beck got word of me. And, you know, as a scientist, he thought, oh, how great it would be to have an intern that was going to crunch numbers for him as well as see clients. So I actually turned down an internship at Friends Hospital, much to their chagrin, and sort of blackballed me temporarily, and went and took my clinical internship with Dr. Beck at the Center for Cognitive Therapy. And what do you think happened as a clinical internship? You know, they handed me 25 cases. I wasn't just going to be doing research. I had clinical work to do. And Merv Schmucker actually taught us a 5-day course like I'm teaching you on CBT. And Dr. Beck himself was my supervisor, and Art Friedman, who is a huge heavy hitter in the field, was my mentor. And Ira Herman, actually, who was a psychiatrist, was my psychiatric supervisor. So, and what do you think happened? Well, what happened is that already coming from a sociobiological perspective on things, Beck's model and my scientific mind, this made total sense. Plus, the truth is that I am one of these people that is the eternal optimist, that makes the best of every single situation, sees the positive in everything, which, by the way, if that is your tenacity, you're going to have an easier time delivering this therapy, because that's really what we're trying to do. If you're a little bit of a Debbie Downer and you tend to see, if you're more critical or you see the glass half empty, it's going to be harder for you to stretch people to see the other side of the equation if it doesn't come natural to you. But it really came natural to me. This just totally made sense. And this is how I looked at the world. And so I started treating clients. And we would treat a client, and then we would talk to Dr. Beck about what we did, and he would tell us theoretically what we were doing, and we would substantiate it. And I started working with people, and guess what? They got better. People would say, my God, this changed my life. I can't believe that I'm not suffering anymore. Or I can't believe how long I struggled with this. I'm not struggling anymore. And that was a turn on for me. And I was like, wow, you know, first of all, you know, I'm the oldest of 3, so I was the boss of the family. I'm still the boss of my family. So I really liked that power that I had. But that's what really made me a believer. And interestingly, I started with Beck in 1983, and I'm still affiliated. I eventually became the education director for the Beck Institute, of which I retired from a number of years ago. But it really shaped the path of my life, that I still adjunctively try to get connected to research, but research is not my priority, that I do still treat clients, but dissemination, training became really the majority of the work that I do, training and supervising others. And in case you're interested, part of the reason why I became such an international trainer is because back in the day, I was the only one that was willing to go anywhere in the world at any time, for any amount of days that they wanted me.
As long as there's plumbing.
As long as there was plumbing, absolutely. That was my requirement for sure. And that's really how it happened, No one else wanted to go to Saudi Arabia. I'm in. So, that's really how I wound up having this be such a majority of what I do. But it does mean, also I should say, Dr. Beck was a generalist. It wasn't like I specialized in the treatment of depression, I only study depressed cases, and that is what we talk about. He was a generalist. He was the disciple of the model. He was the founding father of the delivery of CBT in the way that Beckian delivery. And as a result, all of us that worked under his tutelage treated every diagnosis out there. And if we hadn't treated it yet, which in those days we hadn't, we're like, well, let's figure out how to apply the model to this new problem that has shown up. And let's talk about it and see what works and what doesn't work. So we just use the model across diagnoses, which is why till this day I'm a generalist in that I talk about every diagnosis, I treat every diagnosis, I supervise every diagnosis. And then along the way, I was asked to be the chairman of the behavioral science component of the family practice residency program at a local hospital. For 20 some years, I taught the house staff, all the attendings in the hospital, essentially CBT, as well as some psychosocial interviewing skills. And as a result of that role, first of all, I shaped the way that doctors, especially family practitioners, thought about treating anxiety, but I became the house psychologist for the physical rehab department, for the oncology. I worked in cardiac rehab. I would be in the nursing homes, in the hospice care programs. I worked in the family practice clinic, which gave me also a diversity, an array of people that I treated. And in the family practice clinic, we were able to get a grant that allowed us to provide free psychological services to all the HIV positive clients in our treatment area, which meant that I was really serving the underserved. Here I was working at Penn, seeing the VIP clients there and the research study clients there, and then in the trenches in community health, really serving the underserved. So it really allowed me to have quite a diversity of clinical experience myself. And then you can imagine in the population that I was working when, your viral loads were plummeting and you thought that you were on death's door, there was a lot of substance abuse and maladaptive behaviors that we were working on because what the heck, I'm not going to be around anyway. Of course, lo and behold, many of my early clients, 20 some years later are still around and sober because we worked on that substance abuse, even though they didn't necessarily want to, even though they didn't think they were going to live. But guess what? Good thing we worked on it because now you're around to be able to talk about it. And until this day, I still see some of those clients, though now they have to pay for me. The good thing is if you've ever come in my door, as long as you're willing to pay something, the door will be open. And I just ask those clients, they pay what they can, and they usually say, well, if you were submitting Medicare, what would you get as the copay? We put that out there. And I have to tell you, those clients really appreciate what they got and are willing to still participate in it. And then till this day, I have a private practice in a family physician office where I see not just the clients of that practice, though I get a lot of referrals, but again, I have all the docs in the community that I've trained, especially like to send me their anxiety cases. And so I stay clinically connected. So I still, yesterday before I drove here, I saw 7 clients. And then I drove here from Pennsylvania, where I live, in the dark, to this hotel in the middle of nowhere, and to be here this morning. Okay, one more slide, and then we'll take our break this morning. So when we think about CBT, we've been talking about that there's no question it's structured because it's goal-directed. It is about being psychoeducational. If I understand you, you're going to understand you. If I understand your problem, you're going to understand your problem. It's dynamic, it's interactive, it's problem-oriented, it's culturally aware. It's time limited in that when we have achieved what we set out to achieve, we're not just going to indefinitely sit around and shoot the breeze with each other. It is about reducing the immediate distress in your life and then, if necessary, addressing your history. It's not always necessary. Clearly, we've been talking about how motivational it actually is. It's collaborative. We're a team, as you saw me demonstrate this morning. It is sometimes a single session. It is a comprehensive view of the individual and their problem using all the tools that we might have in our toolbox, empirically supported and an active process. So just to reiterate, we have found, clearly CBT is an international model used across the globe and is delivered in many, many languages. It's a broad-based intervention found in every treatment setting, applied to every treatment need, applied to every treatment modality, with every clinical group, and used as a preventive treatment. And I think that's where, a lot of the work has not been done. Of course, Seligman's work in The Optimistic Child, but we really want to think about this model not just as a recovery model, but also as a prevention model. And I would even suggest that CBT might be considered a resource to build psychological resiliency in everybody. Of course, it's my personal sort of agenda that we would bring yoga and CBT, as well as athletics and art and math and science and literature, into every school curriculum. It is different from traditional psychotherapy, and it's very different than the medical model. The medical model is how to cure someone. The psychological model is what can we do to cure. And instead of asking questions like why, we typically focus on what. What can we do about it? What can we do to make it different? It does emphasize the here and now, but that's not in ignorance of the past. It is about building self-efficacy. It's about building skill. It is an information processing model, and certainly the most important principle is guided discovery. We use a Socratic dialogue, which I'm going to spend lots of time really building. SES assessments are used, and we're going to talk more about those in detail as well. I want to really highlight that this is a supportive model, not a rigid model. It's not meant to be a manualized treatment. That's not to say that treatment isn't sometimes manualized. And honestly, when research trials are taking place to make sure that everyone in the trial is doing the same thing, often it's a manualized course of treatment. But even in the most robust manualized courses of treatment, there is flexibility, there is exercises tailored specifically to the individual. But in a pure Beckian sense, it was really never intended to be a manualized delivery, but a individualized case conceptualization driven model. And certainly we're going to talk about homework, identifying distortions, and underlying beliefs. Certainly we assess individuals for CBT like we would assess individuals in any course of treatment, recognizing their strengths and weaknesses and their limitations. CBT is based on an observation that the automatic thoughts are situation-specific perceptions, and our more pervasive beliefs, which we're going to be talking about, are exaggerated, distorted, mistaken, or unrealistic, and play a major role in how one responds to extreme circumstances and the development and the maintenance of both effective coping and psychopathology. And as we know, everybody that faces a trauma doesn't wind up with PTSD. Now, what data are we talking about to draw our conclusions? I think it's really important to recognize, where did this data come from? When you have a depressed client, they're negatively biased, which means that their data is going to be biased. So often, if there is an opportunity to get corroborating data from outside sources, you may want to get that. When you have an adolescent that has gotten into trouble, they might not be forthcoming with the whole picture. It might be a good idea to get the whole picture of the equation. We also need to think about, is there enough data for us to make a conclusion? When you have a nonverbal individual that's not willing to talk with you, the reality is, until those lines of communication are open, it's very unlikely that you're going to be able to do any good therapy. Now, when we do thought restructuring, the question is, what kind of information do we need to be able to make a compelling case for an alternative viewpoint? Well, let's look at where that data might come from. Ladies and gentlemen of the jury, Art is a pretty nice guy and is probably innocent. How reliable and valid do you think that piece of information is? Not. One person's opinion. Opinion is subjective. It's unreliable. We don't know if it can be replicated. So probably we would not consider that a very helpful source of information. On the other hand, ladies and gentlemen of the jury, we have 50 witnesses, and this should take about 5 days. The data becomes more compelling. The more data, the more evidence that you have to dispute an erroneous idea, the more powerful that new conclusion is going to be. Ladies and gentlemen of the jury, we have a single witness for the defense. Pope Francis, could you please take the stand? Now, the truth is, no matter how important, reliable that one piece of information is, it has to be backed up. It has to be reliable. We need other sources of information that substantiate it. That's not to deny that sometimes one piece of information is so powerful that it might be able to use to be made a case. Maybe somebody who has struggled throughout their life, has had many situations where they have failed, where they have floundered, and yet they were able to finish their GED. Well, I would say that GED now negates forever forward that you can't obtain something that you want, because you made that happen. No matter what happens tomorrow, next month, next year, it will never negate that one solid piece of data we have. Forever your life now will be different. You succeeded. So I would say there are times when information can be very, very powerful. Now, bias. What do we mean by bias? What we really mean by bias is if I was holding up a lemon, and it's a yellow lemon, and I asked you all, what color is the lemon I am holding up? Probably most of you or all of you would say it's yellow. And then I put on dark blue sunglasses on all of you, and I said, what color is the lemon? You'd probably say green. And I would say, okay, gang, is the lemon a yellow lemon or is it a green lemon? And we would say, well, objectively, the lemon is still yellow. The blue lens just distorted my perception of what really is a yellow lemon. And that's really the goal of therapy, is to remove the distorted lens and just see the world as accurately as possible. That's not to say that we don't want to put a positive spin on that perception. It's not Pollyanna. It's not like we're just trying to gloss over, but we do want to try and see the most positive, accurate perception of what's going on. So let's look at that cognitive model. The basic model says it is not the situation that drives our distress. It is the perception of situations that drive our distress. And those perceptions, those situation-specific perceptions, are what we call automatic thoughts. The automatic thoughts that we tend to focus on in therapy are the thoughts connected to distress. But we can have thoughts that are positive, neutral, negative, all kinds of thoughts. And by the way, our thoughts might take the form of a thought, or they might actually take the form of an image. We see our car plummeting off the bridge, landing into the water below. Let's use this comic illustration that I think is a really nice illustration of the cognitive model. So here we have the external situation. The train is blocking their path. And Dad and his young son were on their way in the morning. The son was headed off to school. Dad was headed off to work. And the son, who was not particularly looking forward to school, was slumped down in the seat, probably half asleep, heading off to school. And all of a sudden, their path is blocked by the train. The son sits up in his seat, rolls down the window, puts his head out, and thinks, "Oh boy, we're in luck, Daddy. We get to watch a train go by." Okay, I would say that's probably a pretty positive cognition. And what's the affect? He's feeling pretty happy about this. And interestingly, although he was falling asleep, now the adrenaline is flowing. His sympathetic nervous system has been activated, and he's aroused, and he's mobilized towards action. He wants to get a better view. So what does he do? He squirms out of his seat, he undoes the seatbelt, and he pokes his head out the window because he wants to be able to see all the train cars going by. And then he thinks, I hope it's a really, really long train. If it's really long, I might be late for school. If I'm late for school, I'll miss first period. That's math. That works for me, right? All is good. Now, same situation, very different perception. Dad, on the other hand, thinks, oh no, we're going to be held up by that darn old train. Oh, there's always something getting in my way. What's the point? I give up. And what happens? Dad's parasympathetic nervous system has taken over. In fact, Dad feels so defeated, helpless, hopeless, that he just closes his eyes, and next thing you know, he's snoring away. So you see that how we think influences how we feel. Son is happy, Dad is sad. It influences how we behave. Son is rolling down the window, getting a better view. Dad is falling asleep, and influences our physiological system. The son is aroused. The dad is de-aroused. Now, Dad, I'll get to you in a minute. Dad, on the other hand, could have had a very different perception. Dad could have thought, oh no, we're going to be held up by this darn old train. I'm going to be late. I can't be late. I have such an important meeting. I need to make this deal go through. If this deal doesn't go through, I'm not going to meet my quota. And if I don't meet my quota, my job's on the line. If I lose this job, I lose my house, we're going to be homeless. Okay. Dad, what's the content of his thoughts? Fear. Which means what? He's feeling anxious, which means his adrenaline is activated, his sympathetic nervous system is on overdrive. And what's he doing? He's tapping his foot. He's banging the steering wheel. Come on, come on, come on, come on, hurry up, hurry up. He's squirming around, looking out the window. Oh my God, how much longer can this train be? Hurry up, get going. Now, interestingly, we not only have perceptions of the external world, the train, we can have perceptions of our internal experiences. We can have perceptions of our own thoughts. We can have perceptions of our feelings, of our bodily sensations. And sure enough, Dad, in his anxious states, starts to physiologically respond. He's sweating. His heart is beating. His fingers are tingling. And he says, oh my God, why am I sweating? Why is my heart is beating so loud? What's wrong with me? I think I'm having a heart attack. Oh my God, I'm dying. Okay, Now we have even more fear, which means what? Even more adrenaline, which means even more symptoms. And now dad changes his strategy. Now dad's trying to turn the car around so he can get to the nearest emergency room to address his catastrophic symptoms. So we see how powerful our thoughts are. Our thoughts directly shape how we feel, how we behave, and how we physiologically respond. And in treatment, we learn to identify these spontaneously arising thoughts that typically we blindly accept as 100% true, whether they are true or not. We typically don't even pay attention to those thoughts because we notice the feelings. We don't notice our thoughts. That's why we blindly accept them. They can go on even though other thoughts may be arising at the same time. And in therapy, we learn to identify those thoughts and images, and instead of blindly accepting them, we take a moment to examine them, to consider alternative perspectives, to look for the most accurate, positive perspective, and thus to have an impact on our mood, an impact on our physiological system, and an impact on our behavioral choices. There was a question?
I just wanted to, earlier when you were talking about a study where they separate two groups and one group is CBT and the other one is medication. So I was wondering, and then they do the CAT scan and see how the brains are actually different. So when you say perception, this is assuming that the people that we're talking about actually have that CBT brain where everything is normal. So will this perception also work with people who actually need medication to try and help them get things back in the right view?
I'm not quite sure what you're asking me. Yes, first of all, let me say that whether you have a brain that responds to med or therapy, regardless, there's going to be a problem in thinking. Now, you might say that in CBT, it works from the top down on the brain. And I am not a biochemist, and I don't understand brain chemistry in the sense I haven't had any real training in advanced brain chemistry. But it works from higher cortical processes down. In medication, it works from the limbic system up. But it doesn't mean that cognitive change can't happen, because if we intervene at one level, it affects all levels. And in fact, if you think about it, when you intervene at a physiological level, like pharmacotherapy, it does impact our thinking. You know, if all of a sudden you have more energy and you have an improved mood and you do more things, it's going to be impacting your behavior, which is going to be impacting your emotions, which is going to be impacting your thinking, because dissonance. There's going to be data that contradicts those negatively biased thoughts that you had. So modifying those biased thoughts, it may require medication to open up the link to do that work.
I could be getting ahead of things, but let's just take that child who saw the train as fun, but then dad's modeling a different behavior.
Yeah. So we're definitely gonna get to that. So let's not jump ahead to that yet, but know that dad and son have different perceptions. Dad might keep his perception to himself and not share that perception with the child. So they're each in their own head unless they go to the ER. On the other hand, you're absolutely right. Dad might share his thoughts out loud. He might be sharing his anxiety with his son and maybe socializing his son. Imagine if dad was saying everything I said out loud to the kid. The kid's heart might start palpitating because he's freaking out over the fact that his dad's freaking out, and absolutely may socialize him to the model. And when we talk about, especially anxiety, we're going to talk really in detail about the impact of how we are socialized on the development of our own perspectives.
I had one client who, for a long time, could not identify any thoughts when she had a panic attack. She didn't find me, but I was wondering, do you have a shortcut to get to that? If they're just saying, I don't have any thoughts,
Yeah. So that's way ahead of ourselves. We are going to get there. We're building our case. I promise we're going to build skill on eliciting and evaluating those thoughts. At this point, we're just understanding the connection.
One question. I have a patient who has a traumatic brain injury.
Yes.
He was a high-powered attorney. This injury has cost him his career, his
Yep.
family, finances. In his opinion, there's no way to see this in any way that's positive. It's just horrible, negative. He wants his old self back.
Yeah.
And I just have been struggling with how
Yeah.
there's no way he tried to reframe or to look at it as a challenge, an opportunity to grow, but
Yeah.
we're stuck with the automatic thoughts almost.
Yeah. So let me say two things about that. One is that if the traumatic brain injury is significant enough, it is a contraindication for therapy. In PTSD, and particularly in trials with prolonged exposure, if there is significant traumatic brain injury, they are not a candidate at all for the implementation of these tools. It depends how severe that brain injury is. But that's a very different question than the person who has had an event happen in their life that has done damage that is not repairable. His brain is changed, right? Isn't that true?
And the injury is mild. It's not, it's mild. The impairment that he suffered has been mild, but it has caused
Made things more challenging.
Yes.
So we might help this person recognize, first of all, you be the client for a minute here. Okay, try to be him. So I understand you've had this serious injury, and it has impacted your brain. Isn't that true?
Yes.
Yeah. So there is brain trauma and there is brain damage from what has happened.
Yes, and I have to live with it every day, and I can't get away from it.
Yeah. So I understand that you have to live with it, and it's true. You do have to live with it because no one has told you there's any kind of magic intervention to make it go away. Is that true?
That's true.
That's true. Now, as a result of this injury, though, you now say what? You can't do what?
I can't enjoy life like I used to. I've lost contact with my family. My kids don't understand what has happened to me. I've lost my income. I could never work as an attorney again.
So is that totally true that you can't work as an attorney again?
Well, I've tried to get a license to practice in Washington, D.C., and I can't even get through the application that's online. So I could probably never work here again.
So things have been tougher for you.
Extremely tough. It's every day is a struggle. I feel as though I'm bashing my head against the wall every day.
Yeah. So every single thing is a struggle, right? Everything is hard.
Well, most things are hard. There's just a few things, and I mean, that's just really easy stuff. I can get up, I can get dressed, but that's about it. That's easy.
So
every day is a struggle.
So already we know that most things are hard, but not everything is hard.
Yeah, but the things that I can do are just no-brainers. I could do them anyway.
Yeah. So what are the things that are hard?
Okay, so I've come to your office every day for the last 12 weeks, and I still get lost. I'm walking around the floor, and I can't remember where your office is.
Yeah.
It's simple things like that that I have to deal with every day.
Yeah. And yet, every time, do you make it here?
Yes, but it shouldn't take me going around this floor 3 or 4 times before I find your office.
Yeah. So if I have it right, life is really challenging for you right now. And despite the fact that it's really challenging, despite that it takes huge effort on your part even to navigate direction and show up at a place, isn't it interesting that you still manage to show up? And in fact, you've told me you managed to show up time after time after time.
Yes, that's true.
So what does that say about you? That despite the challenge, despite how hard it is, if you are determined to make it happen, you're still able to make it happen.
Sometimes.
Yeah. Well, I just want to throw it out there that although going back to the practice of law, may be excruciatingly painful, may be Herculean challenging. Is it possible, given that you navigate, face something really challenging, and get through it and reach the goal, is it possible that you might be able to persevere and make what you really want to happen happen?
It's possible, but it just that it's not like how I used to function. I used to be able to do these things without having to put forth so much effort.
Yeah, and I think that's right, that it isn't like you used to happen. Which means what? Which means that whatever you do now, do you deserve more credit?
No, it's simple stuff, and I shouldn't have to work so hard.
Right, I shouldn't. So a should says that it is an imperative, a demand, I shouldn't. You know, the reality is that, did you cause this to happen to you?
No,
Do you have any power to fix it?
no.
No. So you're pretty powerless. So demanding it be different, you're fighting a losing battle.
Yeah, that's true.
That's true. Now, do you wish it was different?
Every day.
Yeah. So guess what? Say that. I wish I didn't have this handicap. Say it right now. I wish I didn't.
I wish I didn't have this handicap.
But it's my choice to let this handicap stop me or to choose, even though this handicap makes it harder, to not let it stop me from getting what I want.
Yeah, I guess that's true.
And do you want to work with me to really try and work towards getting you what you want?
Sometimes.
Okay, so again, so you see that a big part of it is accepting what we can't change, but not letting it be an overgeneralized all or nothing perspective, and really moving them towards it. Yes, look, life is going to be harder for this guy, but that doesn't mean he can't do life. It doesn't mean he can't have the things in the life that he wants. And it may be that relationships have been damaged by the way that he has behaved, but it doesn't mean that damage can't be repaired, or it doesn't mean that new relationships can't be developed. Any comments about what you observed?
That was awesome. Yeah.
Thank you.
And so I had to talk myself down because it's, I'm thinking about some of my clients, and even though, we were able to have that back and forth so quickly, sometimes it just takes, several sessions, if not months, depending on how deeply embedded those cognitive distortions can be for a client to be able to even hear some of those pieces. So I find myself, I guess this is a question, sorry. So I find myself kind of doing a little dance of back and forth of like validation and just kind of fighting around how much of, this dialogue and this debate that's not a debate that we have going on can you handle today or this month, depending on what's happening.
Yeah. And my hope is that over the course of this training, as you recognize what you're trying to accomplish, that dialogue is going to get easier. Before I started talking to her, I already knew where I was hoping to take this case. So hopefully by me helping you define the problems, be clear in what you're working towards, that dialogue is going to happen at a faster pace than you may be accustomed to. But it can't happen unless you know what you're reaching for.
It seems more honest. It appears more honest that you put the cards on the table.
Yeah, right.
Which is more open
Yeah.
than sometimes we deal with things not trying to hurt. You're not hurting, you're putting the obvious.
And absolute, the theme, you're so on the money, because the theme is don't avoid. The theme is face it, call it out, put it out there. And because the only way we're going to get beyond it is to look at it, to face it, and to move beyond. Because also when we face it, we get to recognize our misperceptions. Without facing it, those misperceptions grow and blossom and then take over.
You just said to put it out there, and I'm putting it out here now, and actually it shouldn't be now, it should have been earlier. I'm only picking up about half of what the pupils are saying.
Yeah, so I'm going to have to do a better job reiterating what they're saying. That's why I said normally a lot of times we have a mic to pass around, but unfortunately we don't have a mic today, so I will thank you for reminding me. I will try to reiterate or ask everyone to speak really loudly so that everybody can hear the conversation that's taking place. And the room has pretty good acoustics, so I think if you speak a little bit, loudly, we should be okay with that. So again, it's not a linear model. Also, it's not a causal model. We're not constructionists, we're Beckians. So it says that there is no primacy. What comes first, affect or cognition? What comes first, physiology or affect? Doesn't matter. Doesn't matter, and the equation's different every time. What matters is that they are linked, and that intervening at one point will impact all the other variables. And there's no question that physiological interventions beyond pharmacotherapy, biofeedback, sensate focusing, mindfulness, right? There's plenty of physiological interventions that have an impact. Behavioral interventions. Behavioral interventions are absolutely essential to CBT, because how are we going to have cognitive change if we don't have any proof? The behavioral interventions are the opportunities to get the data for behavioral change to take place. The behavioral interventions are often the first steps in movements towards recovery. If you have a fully psychotic individual who is caught up in their own head with thought blocking because they're listening to that other dialogue while you think you're trying to have a conversation with them, or they're paralyzed by fear because the hallucination is coming to get them, your cognitive interventions aren't going to be accessible. On the other hand, they're afraid to exert one speck of energy because they only have a limited amount of energy, another one of their delusions. So just getting them out of bed, just getting them walking down the hall with you is therapeutic. Getting them tossing a ball back and forth to you as you walk down the hall might be the most effective intervention that person has had all week. So, behavioral interventions are essential to the process. The problem is, if you're bothered by something and you're temporarily distracted, it doesn't remove the problem. Behavioral interventions, physiological interventions, even interventions at an affective level tend to be short-lived in the sense that if you stop the intervention, the problem returns. When you look at benzodiazepines in the treatment of panic disorder, 90% of clients relapse when you stop the medication. So the power in cognitive restructuring, at intervening at a cognitive level, is for enduring change. But situation-specific cognitive restructuring produces temporary symptom relief. It doesn't necessarily keep the problem from reoccurring in another situation at another time. And that is why we believe that interventions at the level of belief, because beliefs shape those situation-specific perceptions, is a necessary ingredient for enduring change to be stable. So let's talk about those underlying beliefs. Those underlying beliefs are the pervasive views, typically over long periods of time, that we hold about ourselves. And we can have positive views about ourselves and negative views about ourselves. We can have views about the world. We can have views about other people. In the context of therapy, we are focusing on the most pervasive longitudinal negative view that the person holds about themselves. Because those negatively biased views that we hold about ourselves shape how we see a given situation. For instance, even in a simple example of this room, and let's disqualify those in the first row because we all know that typically in lectures that most people don't want to sit in that very first row. So we, brownie points that those that put themselves right in front of the teacher. And then we have a row here where we have lots of people sitting next to each other. Of course, we have an empty seat here, but you know, you are on an aisle, but you do have an empty seat next to you. Well, just take note of that. And then we have in a completely full row here, no empty seats, a completely full row there. And then we have, interestingly, we have, at least you have one person next to you. We have the two people on the aisle that have an empty chair. But, you know, you're on the aisle, so we'll give you the benefit of the doubt. We have the two of you next to each other, and then, of course, we have you on the aisle as well. And then, oh my goodness, we have you. The only one in the entire room, by the way, with two empty chairs, one on either side of you. Okay? Now, until I pointed that out, which I didn't even realize until I went around the room and actually got to this and realized it, probably most of you, including you, didn't even notice that. Is that true?
No.
Right? We didn't.
Noticed it.
Oh, you noticed it. You did notice it.
Yes.
Uh-huh. And did you have any thought about it?
Well, no, because I do like it. I always.
Yeah, so you actually had a positive thought about it. This is great. I have no one sitting next to me. I don't have any of those germs coming my way. I don't have to smell anything I might not want to smell. I don't know. On the other hand, I can spread out. In fact, if you'll notice, I sort of put my belongings in every direction to maximize that nobody sat on either side of me. So clearly there was not any kind of negative belief that was shaping your perspective of this situation, seen as a very positive thing. On the other hand, maybe a different individual exactly in this spot may have the automatic thought, no one wants to sit next to me. Right? Can you imagine someone might actually have that thought? And let's imagine every seat in this room was taken except for these two seats. You might be thinking, hey, what's wrong with me? How come nobody wants to sit next to me? Am I the only one in the entire room that doesn't have any friends? Is there something about me that people don't like and don't want to sit next to? So what might lead somebody to have negative perceptions about the fact that no one's sitting next to them? Well, it's that underlying belief that might actually lead to that perception, because maybe that person basically thinks, I'm an unlikable person. So I assume that no one wants to sit next to me. I assume everybody else came here with friends and I'm the only one that came here by myself. Could be what? The mood that they're in, yeah. So you're right. So those underlying beliefs that we have about ourselves sometimes mushroom and take over, and they're always there getting in our way. And sometimes those beliefs lay latent. And only in challenging situations, they rise up and speak to us. Typically, when a person is clinically impaired, they're clinically depressed, anxious, have an Axis 1 diagnosis, whatever belief was laying latent has risen to the surface, and now this pervasive negative view of themselves has taken over. When we have a personality disorder, what happens is these underlying beliefs that we hold about ourselves rise up at an early age, and instead of going back undercover, they hang around. And then we look for information to fuel that negative view, and we grow that negative view, and we start to ignore any information that contradicts it, or we distort it, or we minimize it. And then we wind up always looking at the world through that lens. Why are you looking at me? Are you looking at me because I'm so disgusting? Why aren't you looking at me? Do you think I'm not worth looking at? Are you disrespecting me? Do you think I sound like an idiot? Okay. Why did you say hi to me? Did you feel sorry for me? Why didn't you say hi to me? Are you rejecting me and ignoring me? Right? The person that walks around saying that I am, unliked and unloved, and I'm going to be rejected, and I'm incapable, is going to look at the world constantly through that lens. And that's why no matter what you do, It's going to be seen through a biased perspective, so you can't win. And if you think about some of our most emotionally labile individuals, our most overreactive individuals, clients that carry a diagnosis of a borderline personality disorder, that's exactly the case, right? Why are you looking at me? Why are you not looking at me? Why'd you say hi? Why didn't you say hi? Because they have many negative beliefs that they hold about themselves and about others that they're carrying around all the time. So every situation, as neutral as it is seen through that bias. And if you think about it, Tom Lynch's research, individuals with a diagnosis of borderline personality disorder actually are more accurate in perceiving nonverbal signals. So when you roll your eyes, they actually pick, what's on? What's going on? You made a weird expression. What's that about? So they notice all those little expressions that you're making, and those, you have your own automatic thought. They're picking up on that vibe. So be wary. This professor is going on and on. She lost me completely about 15 minutes ago. Everyone else seems to understand. I must be the only one here who's confused, which clearly is an automatic thought that clearly is not true, given the thought bubbles. I really want her to stop and go over some of this stuff again, which probably would be an adaptive strategy. But if I put up my hand, 175 people will think I'm a doofus. So you can see the belief, I'm a doofus, I'm stupid, is what led him to the automatic thought that I'm the only one confused. And if we were his cognitive behavioral therapist, what we might do is say, that's interesting that you assumed that you were the only one confused. And understandably, because you think you're a doofus, you always jump to that conclusion. But the reality is it possible that anybody else didn't understand? Did you ask anybody if they actually understood? And if you said to your neighbor, hey, are you getting this? Is it possible that your neighbor might say, I'm completely lost, I'm clueless? And is there a possible reason why you might be confused? Yes, I'm a doofus. Well, could there be another reason why you could be confused? Is it possible that your teacher is doing a really poor job explaining this material? Is it possible that this is really complicated, challenging stuff, and the first time you're hearing it, it's really hard to digest? Well, if you let your belief that you're the only one confused be in charge, and you let it be connected to the conclusion it's because you're such a doofus, and you choose not to ask, what's going to happen? You're going to do poorly on the exam, which is going to confirm that you're a doofus. On the other hand, if we gave them the courage to actually raise their hand, number one, everyone else in the class would clap. And in fact, if they raised their hand and said, I'm really lost, can you go over this again? And the professor might say, is anybody else having a difficult time? And then every hand in the room goes up. That would be really important information to the teacher to say, okay, let's go back and try this again. And in fact, if the teacher explained the material again, what might happen on the test? He might actually perform well, which would provide information to directly contradict this idea about himself. So the power of our beliefs and how they shape our underlying situation-specific thoughts. So let's spend some time trying to identify those beliefs. I want to say that all of us have beliefs, negative beliefs, lurking inside of us. For some of us, they're not too nasty, and they really only show up at very limited times of duress. And for some of us, even if we don't have psychopathology, our insecurity talks to us more often. So I find in the first step of trying to understand the labels of our insecurity, and by the way, labels of insecurity can be called doubt labels, as we call them in our books. They can be called core beliefs, as Judy Beck calls them in her books, or schemas, as Jeff Young calls them in his books. Beck used to say the schema was the structure, the core belief was the content, the mode was the behavior. But semantically, we use those words interchangeably. Schema, core belief, doubt label, insecurity label. Doesn't matter, we're just talking about that pervasive negative view. So let's look at personality as an avenue to understand our own beliefs and the beliefs of our clients. Now, our personalities are shaped at a very young age. I would argue that they're shaped in the womb itself, because you have people in the womb that are squirming around, doing somersaults, and you have babies in the womb that are hanging out, sucking their thumb, just being nice and chill. So, you know, who we are is already growing from a very young stage. And what we value shapes our personality. So the sociotropic personality, and again, the personality is on a continuum. We're not either or. We fall on a continuum of this sociotropic autonomous domain, is some of Beck's work. And I would say that during a lifetime, we get pulled in one direction or another. When you're in academia and you're taking tests, you're probably pulled in the more autonomous domain of achievement. When you're getting married or having children, or there are interpersonal things going on in your life, you're probably pulled more in the sociotropic direction. As we age, we tend to regress towards the middle, regardless, though there are some people that as they age, they become more extreme in who they are. But, you know, it's not a fixed state. It's a continuum that we move between. But from a very early age, what we value starts to show up. The sociotropic individual values interpersonal goals. What matters most is that they are liked, that they're a good person, that they have worth. And as a result, they place a high value on interpersonal relationships and will compromise performance-related goals to make interpersonal needs most important, which means if I have a work-related opportunity, even if it's to make a lot of money, but my friend wants me to be there at her birthday party, I'm going to the birthday party. What it means is even though my favorite yoga class or spin class or Pilates class is at 9 o'clock on Saturday morning, when my kid has a soccer game, I'm on the field at 9 o'clock watching that game, even though I'm missing my favorite class. And think about it. How many of you compromise what you want to do, what you personally want to do, or an achievement-oriented goal in order to be there for an interpersonal need? That's a more sociotropic personality. And if you think about that young child, think about that baby that likes to be held all the time. That's a sociotropic baby. Think about that baby that the minute you lay them down, they scream. So you got to carry them until you fall asleep, and they only want to sleep on you, or they want to sleep in the bed next to you. That is the more sociotropic kid right from the get-go. Versus the kid that you put down in their crib and they sleep 5 hours. Versus the kid you put in front of the fish tank and they're good to go, watching the fish. They don't need you. They put themselves to sleep. That's a more autonomous kid. I would say the kid doing somersaults in the womb is the more autonomous kid. The one sucking the thumb, content to be, you know, touching your insides, is more sociotropic in nature. And the more autonomous kid, the more autonomous person is the person that cares about independence, achievement, mobility, freedom of choice. It's the person that cares about getting things done, accomplishing it, which means we don't have to be in the workforce to be an accomplisher. We want to get things done and we want to have power. We want to be in control. We want to make the choices. The more autonomous personality is the person that makes a checklist, and nothing feels better than checking all those things off the list. It is the person that on a day off has an agenda and doesn't feel good until they accomplish, oh, we got so much done, this was an awesome day, right? That's what it's about. That's the more autonomous person. The autonomous kid. Think about a 4-year-old that we sign up for fall soccer, right? It's fall, it's soccer time, little boys and little girls all play soccer, and you sign them up and you say to the kid, you say to your first kid, oh, I signed you up for soccer. And the autonomous kid says, great, I love soccer, I can't wait to get out there. Put me in goal because nothing's getting by me. Yeah, bring it on. We don't have goalies on the 4-year-old team, but let me out there, right? They're good to go. Whereas the sociotropic kid says, well, who's on my team? Well, I don't know who's on your team. Well, I'm only playing if Jessica or Jack are on my team. What do you mean? Well, if no friends are on my team, I'm not doing it, right? I'm only doing it if my friend, but you love soccer. I'm only playing if my friends are playing. That's the more sociotropic kid.
Can't you be both?
Yep, we're getting to that. Absolutely. But do we have dominance of one? Do we value one more than another? And we know that in situations, you know, the day off campus, community service day, they have a sign-up list for activities you can do. Work in the soup kitchen, work in the watershed, chopping logs, arts and crafts with the toddlers, like, you know, all kinds of things. And you have this autonomous woman walk up to the list and sign up right away. And before anyone else signed up, hey, how come you were the first one on the board? Because I wanted to make sure that I could do exactly what I wanted to do before it filled up. Okay? It would be nice if my friends sign up there, but I want to do what I want to do more than I care about being with my friends. On the other hand, the kid comes up. He's, by the way, a football player and a wrestler who almost didn't graduate from kindergarten because he couldn't use the scissors very effectively. So arts and crafts and him are not very compatible. And he comes over and no one signed up yet. So he takes a look at it and he immediately walks away. And if I had asked him, I might have said, what would you want to sign up for? He clearly would have picked the watershed with some physical exertion activity. He's a he-man, he's all about his brawn. But he comes back later in the day and his friends have signed up for arts and crafts in the preschool program. And he immediately signs his names to arts and crafts. And if I was interviewing him, I would say, I thought you really dislike arts and crafts. I do. Then why did you sign up for arts and crafts? Well, because all my friends signed up for arts and crafts. It's that simple. I'd rather be with my friends than do what I would like to do. And you see this operating all the time. You say to your kid, you know, we're going to the beach or an amusement park or Chuck E. Cheese, you know, something they really like. This is a very young child. And you're about to walk out the door and the phone rings. And the kid says, hey, Mom, can I go to John's house? Well, what are you going to do at John's house? I don't know. John wants me to come over. Right, but you love the beach more than anything in the planet. I know, but John wants me to play. They're willing to compromise what they want to do to be with another person. Now, on the other hand, you have the kid that doesn't even take the phone call. Let's go. What are we waiting for? Or you have the kid that answers the phone and says, can Jack come with me? Or the autonomous kid that says, you know, I'm on the team, but it would be so much sweeter if some of my friends were on my team. It really sucks that I'm on the team without anybody else. So as we fall closer to that continuum. Now listen, if you're more extreme, life is much less challenging because when there is a conflict between interpersonal goals and achievement-oriented goals, the path is very clear. Let's imagine today at this lecture that special guest, Dr. Beck himself, was coming with me for first thing this morning to do the morning part of the lecture. And you really, really wanted to see the master at work. And it just so happens that this very morning of this course, somebody really important to you, maybe your child, maybe a nephew or a niece or somebody that's really important, has this really important event. They're in the state championships. This is like the most important thing. Or they're in a school play and they have the lead and there's not going to be multiple productions. Or it's a concert and they're sitting in the first chair. Something really important. What do you do? How many show up at the lecture? How many show up at the lecture? That is a clearly autonomous choice. Not that you don't feel bad that you can't be there and you beg someone to videotape it, but you're there at the lecture. That's at the end of the autonomous continuum. How many hands down are at that social event? Right? That's the sociotropic response. And, those that came to the lecture came and, don't feel that bad about themselves that they didn't go. They feel a little disappointed, but they really said, it made sense for me to be here. And those of you that hands down picked the event are not kicking yourselves for not going to the lecture. There was a more important priority. It would have been nice, but there was a more important priority. A lot of you didn't answer. And a lot of you didn't answer because why? Because you're torn. Because you value both autonomy and sociotropy. You want people to think that you're nice and a good person. And you also want people to think you're smart and you're capable. So you have both things operating. When we value both, our life is more stressful because you come to the lecture kicking yourself, I probably should have been at the social event, or you go to support your loved one thinking, I can't believe I missed out on that lecture. That was such a dumb idea. Why did I do that? And so life is a problem. Also, what stresses us out is connected to what we value. If we value those interpersonal goals and something thwarts those interpersonal goals, you're mad at me, you break up with me, you're cheating on me, it's going to have more of an impact if I value those social things above all else. It doesn't mean it's not going to bother the other person. On the other hand, if I'm more autonomous, what's likely to bother me are things that impede my mobility or my functionality. I lose my job, I don't get the promotion I wanted, I don't get the opportunity, somebody criticizes my work. But when we value both, those interpersonal stressors are going to bother me and those performance-related stressors are going to bother me, so more things are going to push my buttons.
So, I'm just going to throw something out there. So, the first one, for goals and attitudes. What happens if you don't really care what people think about you, but that you value just people and to help them in any way possible, as well as
Yeah, but you don't, right, so you don't have to value what people think about you to value what you value. I might value being a good person. I don't care whether you think I'm a good person or not, but I have my own criteria for what being a good person is, and I value being a good person, so I'm going to do everything to try and live according to my values. Yes. So can it change? Absolutely. Events can shift our beliefs in ourselves. They can reinforce beliefs in ourselves. Absolutely. But this is not, we're not quite at the beliefs. We're still looking at what we value.
Would you suggest that there's a normative balance between the two, or that it's more normative to be on one side or the other, or is it just one?
Yeah, this is really just a paradigm. There's not a right or a wrong. There's not, is it healthier to be one or the other? There is no question that cultural domains play a role in where we get pulled. If you grow up in a place, I've lectured in Hong Kong 14 times. When I supervise cases there, often everybody has the same underlying belief: I'm not good enough. That has to do with achievement. I'm not good enough to achieve. How can it be everyone has the same idea? Well, they're socialized in a culture where achievement is so highly valued that interpersonal goals are compromised, extracurricular activities are compromised unless they're working towards the goal of achievement. So as a community, they're pulled in the more autonomous direction in terms of what the culture says, this is what's most valuable. When you live on the island of Cyprus, which I have lectured on, where they have a very nice university, but it's not Harvard, and when Harvard professors have left their tenured positions to move back to Cyprus to be among their community, right? That's a more sociotropic choice. And people that live in Cyprus, or people that live in the middle of Canada, in Winnipeg, for instance, tend to want to care more about being connected to their family than achievement-oriented goals where they might be at more prestigious academic settings. So are you willing to move for love, or are you willing to move for achievement? And that's a big problem in our global world, where couples often live on different parts of the globe because you have two high-achieving people that want to have love in the equation, but no one's willing to compromise their achievement to make love the priority, right? Which is changing in our culture when, maybe 30 years ago, one partner, hands down, would have compromised their achievement-oriented goal to be with their love. Interestingly, we have done trials treating depression in post-bypass surgery clients. So people that have cardiac incidents and have surgery, there are a pool of those people that get depressed. Not everybody gets depressed. And when we did trials of intervention treating depression and low social support in these individuals, we found that there were people that got depressed right away and people that didn't get depressed till later down the road. And the domains of sociotropy and autonomy helped explain that somewhat. After you have surgery, what happens? Everyone comes to visit. They bring you cookies and candy and treats and send cards and call you and hang out with you. And the sociotropic person says, look how many people care about me. I'm so loved. This is so wonderful. It's so great having you all here. And you leave the hospital and they bring you food and they come to visit. And then what happens? A couple weeks later, it all stops. No one cares. I'm all alone. Now I'm starting to get depressed. On the other hand, the autonomous person says, what do you mean I can't go to the bathroom by myself? No way I'm leaving here in a wheelchair. Let me walk. What do you mean I can't even walk around the block? I'm not going to be able to mow the lawn. I can't go back to work. When am I going to be able to play golf? Right? I'm thwarted. I'm miserable. I'm clinically depressed. And why are all these people in my house? Exactly. I don't need your treats. And then what happens? They build back their strength, they do some cardiac rehab, they're mobile again, they're able to mow the lawn. I don't know, my client goes on the golf course and he gets a hole-in-one, which coincidentally seems to happen, and all is good. So you see that what we value does play a role in making us vulnerable. Because if we value achievement and something thwarts our achievement, it's likely to bring to the surface the self-doubt that has to do with achieving. And that self-doubt has to do with being helpless or incompetent. And here are some examples of the specific nasty name we might call ourselves when autonomous doubt is activated, when we question our competency, our capability. And it's not an exhaustive list. Here's just some examples. So when I can't do something, or I have failed at something, or I didn't deliver it in the way that I wanted, or I wasn't able to do it, I think I'm inadequate, I'm powerless, I'm trapped, inferior, I'm weak, or if I'm an adolescent, the label may be less pejorative, it may be less extreme. You know, adolescents, we're still growing those negative views. So you see that the label may be inferior or dumb, or it may be I'm boring, or absent-minded, or average. And similarly, when I value interpersonal goals, then I care about being desired. I care about being good, being valuable. And so when something thwarts my ability to have my interpersonal goals met, I may be thinking I'm unattractive, or I'm unlovable, or undesirable, or rejected, or unwanted, or I'm bad, or I'm worthless, or I'm not good enough to be loved, or I'm defective. And similarly, when I'm an adolescent, I may be thinking that I am uncool, or I'm ugly, or I'm uninteresting, or I'm boring. Now,
So a lot of my clients, and not only my clients, but they still have, when you start using the kind of stuff, growing with low fatigue, you're thinking, still have those kind of thoughts, they didn't grow up into these self-defeating thoughts. Does that make sense? So you say it's for adolescents, but I just did an assessment last night, and the guy felt that he's a failure, that
no, so what I'm saying is that,
self-hatred.
yeah. So we'll get to those questions, but the adolescent maybe hasn't developed this pervasive view. Maybe it's just softly growing, and maybe circumstances fuel it, and maybe circumstances don't fuel it. And what we're saying is that, but the label itself may not be as ugly as it might be later in life after years of accumulating information to support that idea. Or the label may be ugly from day one. But know that what matters is what's the label the individual calls themselves. We don't impose this label on them, it comes from them. And we may hold beliefs that fall in one domain, or we may hold beliefs across both domains. You know, look, if you take it for granted that you're a desirable person, then interpersonal situations are not very stressful. You know, I'm good, put me anywhere, I can get along with anybody, I can talk to anybody, I'm not worried about being judged or not knowing what to say. I take it for granted that I'm socially desirable. And similarly, if I'm autonomous, I take it for granted that I have plenty of brain cells, that I'm capable, that I'll be able to do whatever tasks they want me to do. I take it for granted. So the only thing that upsets me is when something thwarts my ability to do that, and the only thing that upsets the sociotropic is something that thwarts the social domain. When we value both, then we're likely to have self-doubt in both domains. So sometimes I think, you know, am I attractive enough? Or am I desirable? Am I fun? Or I might also be thinking sometimes, am I smart enough? Do I have what it takes to be able to do this? Or am I strong enough to handle the difficulties that I'm having to face right now? So the more closer to the middle, the more we value both goals, the more vulnerable we are to hold beliefs about ourselves that are derogatory in regard to both of those values, that when we're under duress, they're likely to show up and get in our way. And if you think about, again, the more impaired individuals that we work with, they tend to hold beliefs that cross domains, like the person with the borderline personality disorder, who does embrace many negative beliefs about themselves that cross over both categories, that make them vulnerable to seeing themselves in a derogatory way across situations. Now, let's talk about childhood and how this plays a role. Let's think about in that classroom. In that classroom, the bimodal age of depression shows up at about the age of 9. Because the age of 9, what happens? We get social comparisons. So before the age of 9, you can spell phonetically, you can color outside of the lines, and now all of a sudden you have to take spelling quizzes and reading tests. And you take a reading test, and what happens? They give you a grade. You get a 97. Nice job. We're going to put you in the Blue Jays. And you get an 87. Good work. We're going to put you in the Robins. And you get a 67. Ugh. We're going to put you in Crow. Okay? Now, come on. We don't call it Crow, but you know when you're in the lowest reading group. And you know what? Not only that, on Mondays and Wednesdays, instead of playing outside during lunchtime, you have to come in for extra work. Now, but you're not bothered by that in the slightest. How come? Not bothered. You got it. This works for me. All my friends are in Crow. Hey, why do I want to be outside playing when none of my friends are out there? I'd rather be inside with them. Not an issue. Is not affecting her self-esteem in the slightest. So just because an event happens, doesn't matter what it is, doesn't mean it's going to negatively affect you. You're not bothered in the slightest. You, on the other hand, are devastated. What do you mean I'm in the Robins? What, I'm not good enough to be in the Blue Jays? I thought I was smart. I guess I'm not as smart. Maybe I'm not smart. Maybe I'm actually dumb. Oh, maybe I should stop trying so hard. What's the point? I'm not going to achieve anyway. So something as simple, such a simple thing, can absolutely knock down your self-esteem. And something to another person going in Crow could be devastating. But it doesn't have to be. And same thing, then we go out at recess, and then you have those captains out there at recess. You know, who are those captains? Are they self-appointed? Are they popular? That's a whole nother presentation. But we have the captains, and the captains pick teams. And I am a captain, and I pick everybody in the row except for you. Okay, and you're my best friend. And remember, you're sociotropic. And you say, now we don't have this conversation. I don't pick you. Which makes you think, what? I guess I'm not such a good friend. And now you're mad at me because I didn't pick you. Which means that you stop talking to me and you disappear. Which, by the way, means what? Now you're on the outs. You're not in the in-group. Now you're feeling lonely and alone. Which activated, see, I guess I'm not a very likable person. And now your life is really a mess. On the other hand, if we had had this dialogue, you could have said to me, how could you not pick me? I'm your best friend. And I would say, you are my best friend. I like you more than any other person in the planet. Yeah, but right, but I want to win. And she's faster. So I picked the fastest one, you know, because I'm autonomous. You know, we're best friends, but we didn't have this dialogue. Because if we had, you wouldn't be devastated. You wouldn't start acting weird, and our friendship would be fine. On the other hand, imagine a different team captain that picks everybody in the row except for you, Miss Overachiever, with the attractive score. And, you know, again, you're thinking, well, I thought I was faster than everyone else. Why didn't they pick me? Well, because I had to pick my friend, even though she's the slowest one in the whole grade, right? Because I'm more sociotropic. So you can see, and then you think, well, my goodness, if I wasn't even good enough to be picked on the playground when they have tryouts for soccer on the fall for the travel team, why bother? I'm never going to make it. And bad news for you, everyone that tried out made it. And then you decide the next year you're going to try out because objectively you are superior to the people on the team. But guess what? You don't get a spot because the team is full. So what we value shapes the beliefs that potentially can grow, which shape how we interpret information, which then shapes the behavioral choices that we make down the road. The cognitive conceptualization diagram is the roadmap to understanding individuals. You can see that typically what we do is we start out eliciting their situation-specific thoughts as we try to understand their deeper beliefs, where they come from, and what strategies they utilize. So, who has a client that they're treating right now that has some negative pervasive beliefs about themselves that they're in touch with? Anybody? You do? Okay. So let's imagine you're this client and just give me the one sentence rundown on this client.
I'm anxious and I smoke weed.
You're anxious and you smoke weed.
Yeah, smoke marijuana.
Okay. So was there any specific situation this week where where anxiety was really getting the best of you?
Yeah, I'm a ballroom dancer and I practice, and when I went to practice this week, I felt like there were new ballroom dancers introduced and I felt like they were better than me, and so I felt like I wasn't good enough.
So interesting, you were at your ballroom dance activity, which you really enjoy, and there were new dancers, and you were observing the new dancers, and your first thought is, they're better than me.
Yes.
Did you have any other thought besides they're better than me?
I felt like I'm never going to be good enough.
I'm never going to be good enough. So when you had the thought they're better than you, did that make you anxious or make you sad?
It made me anxious.
It made you anxious. So what about them being better than you threatened you?
It made me feel like it made me think about when I was younger and how my parents homeschooled me and left me socially isolated. And so when I did get into high school, I felt very self-conscious about people being smarter than me and being better than me and being better performers in school than I was because I was homeschooled.
Yeah. So when you saw them and you thought that they were better than you, it scared you because once again it would be a situation where you weren't as good as other people.
Yeah.
And what about not being as good as other people was a problem?
It just makes me feel like if I'm not good as everybody else, then I'm not being productive in my life.
So if you're not as good as other people, then you're not productive.
Yeah.
So it would be a waste of time then being at this ballroom dancing.
Yes.
And is that really the concern, that it would wind up being a waste of time?
No, because I'm there.
Because you're there. So I'm still not really clear. What about not being able to be as good as other people is threatening to you? Is it just that it would make you feel bad about yourself? Is that what would be threatening?
Yes.
So that's really the fear, that they'll do better than me and that it will confirm that I'm not as good as them, which will lead me to not feel good about myself.
Yes.
And you said that one of the things that you do believe about yourself is that in general you're not as good as other people?
Yes.
And this idea of I'm not as good as other people, I'm not good enough, comes from the background that you had that contributed to that. And when you say you're not as good as other people, is it that you're not good enough to be liked or not good enough to perform and succeed?
It's because I'm not good enough to be liked.
Oh, it's about not being good enough to be liked. And if you're not liked, what does it mean about you?
That I'm bad and that I'm evil.
And is that something you think about yourself, that you're a bad person?
Yeah.
You do think of yourself as a bad person. So if you didn't perform in that dance room, would that make you bad?
It would make me feel like I was bad.
Make you feel like you were bad. So on the one idea, I'm not good enough. And is this something you've always thought about yourself? You're not good enough?
When I was younger and I had, well, my brother has Asperger's, And so we were playing one day, and my brother said that he didn't want to play with me anymore because I had dropped the ball, and he said, "You're just evil, you're just terrible. You're no good. You're no good to me."
And do you think of yourself as being no good?
Yeah.
I'm no good.
I'm no good.
I'm no bad. I'm bad.
I'm bad, yeah.
So if I don't perform as well as other people,
Then
I'm no good.
And I'm bad.
And I'm bad. Okay, so let's stop that there and say, this is a very complicated case, so it was not quite so completely straightforward, so we'll give it that, and which is good because in real life cases can be very complicated. So you can see it's not about the fear that I'm going to fail, which would be a more autonomous concern, or, it is this fear that I'm going to be uncomfortable. And so we have to say, what about being uncomfortable? It's going to make me feel bad. Is it something about me being weak or frail? And it's possible, again, that we said that we can have multiple negative views about ourselves, but what is coming out more loudly is I'm not good enough, and I'm particularly not good enough to be a good person. I've really failed as I'm a bad person. I'm an evil person. And you can see that the assumption then is if I don't perform, then it confirms that I'm bad, that I'm evil. And so what is his strategy? His strategy is not to avoid, right? Because he doesn't quit the class. His strategy is actually to stick it out, but does he do anything to make it more tolerable? He actually smokes weed, right? So weed is his compensatory strategy to stay in there so that he cannot leave the ballroom dancing, because if I smoke weed, then I won't feel bad. And I'll be able to tolerate staying there. Which makes sense then, that weed is a compensatory coping mechanism, right? There's a rationale from his perspective for why it makes sense.
Write a practice note on that, though, that we decided that weed is the best thing you should do, stick to weed and go. I mean, I couldn't write a note on that and have it stay,
Yeah. We're not saying that that's the most adaptive coping. We're saying that's the strategy they use. And, the question is, are these strategies the most effective strategies? Do the strategies really work? He thinks it works, but does it really work? We don't know. We'd have to evaluate that. Are there other strategies that we could use instead? Or is it a strategy that is a feasible one? We're going to have to evaluate that together. But when we understand individuals, this is what we do, is that we look at them through the lens of the case conceptualization diagram. And I'd say that every case you treat, you don't necessarily have to fill out this form per se, but this is the roadmap that says, I understand this case. So here is a school teacher that is a very effective school teacher. She is in the Philadelphia school system, tenured teacher, been teaching for years, gets really good reviews. There is no reason for her to doubt herself, but she does. And it turns out this woman grew up in a household with highly critical dad. You got a 99, why didn't you get 100? Why didn't you get extra credit? No matter what you did, it was never good enough. And then she had two older siblings that were particularly bright. They were both in the gifted tracks. One went on to be a surgeon, one went on to be a lawyer. They were high-powered professionals, and they were significantly older than her, which meant that the sister especially would carry her around and do everything for her. And as a result of that, she developed this idea, I'm helpless, not because she was actually helpless, but because she didn't have a lot of opportunities to do for herself, because her sister did a lot of the things for her. Then when she compared herself to her high-achieving siblings, she said, no way can I do it. So she developed this idea, I'm the incompetent one, I'm the helpless one. And she decided that in order to prove that she was capable, she had to be perfect. So because she had to be perfect, she didn't do anything that would stretch herself too much, which meant that instead of taking the more advanced classes, the honors, the AP classes, I'm going to take the regular classes because I'm more likely to be able to get a good grade. Because the assumption is, if I make a mistake, terrible things will happen. My dad will be critical. I won't succeed. And so I'm only going to put myself in situations where I maximize, I might be able to perfectly perform, which shaped the direction of where she went in life. She actually chose a profession that she didn't truly want, but she chose one where she thought that she could succeed in, more likely to succeed in without struggle, because she didn't believe in herself. And in fact, whenever the going got tough, she became helpless and relied on the help of others. If I have to rely on myself, I'll fail. If I rely on others, I'll be okay. So at the first sign of trouble, she leans on everybody else. If you think about perfectionism, perfectionism is a compensatory strategy to self-doubt. Those of us that are secure don't need to be perfect. We're like, we get it, because we recognize that perfect is an unrealistic goal. What is perfect? The most attractive color in clothing apparel today is pale pink. You're like, what? That's because that's not true. Because there is no such thing as what is the most beautiful color, what is the most beautiful flower. Perfection is something we cannot define. How can we achieve something that we cannot define? So recognize that we're setting ourselves up for defeat. But the sociotropic person who values being liked says that if I'm perfect, people will like me. The autonomous person says, if I never make a mistake and I'm perfect, I will succeed. If I make a mistake, then I prove what a failure I am. Sociotropically, if I'm not on my best behavior, people will reject me. So the person that is more sociotropic in nature will acquiesce, will not assert themselves, will put on a facade because they want to maximize their likability because they don't believe in their likability, so they have to compensate by making themselves more likable. And the most extreme version of this is my avoidant client that really believed that she was not an attractive person, even though objectively she was. So in the middle of the night when she stayed at her boyfriend's house, she would get up and go into the bathroom and blow dry her hair and put her makeup on so that if he rolled over in the middle of the night and saw her, she would be perfectly put together, because if he saw her blemished in any way, he would reject her. And then what happens is that this teacher, the principal says, I'm coming in to observe. Every year the principal comes in to observe, and she'll probably think I'm going to do a terrible job. It doesn't make any sense. You've been teaching for years. You've never done a terrible job. What would make you think you're going to do a terrible job? Well, because at her core, she still thinks of herself as an incompetent person, even though she's very competent. Which leads her to get anxious, which leads her to over-prepare, right? I got to do a perfect job, which, by the way, is going to get her a good but not perfect review because she tried to cover too much material. Then the reading specialist says you have to cover more material this year, and she takes it personally. She takes it personally because I'm going to get fired. That's going to show my incompetency, gets anxious and calls her mother in a crisis. What she fails to see is that just because she's been told to move faster isn't a reflection on her. It's a reflection on the state of Pennsylvania that wants better test scores and has mandated that every program try and cover more material, which is going to backfire, but that's what they're trying. And then she doesn't feel well. Well, she doesn't feel well, and she thinks there's too much to do, I have no energy, I'll never get it done, feels sad, goes to bed, gives up. Of course she doesn't feel well because she's not taking care of herself. She's too busy over-preparing for herself at school. Again, if we see ourselves as basically competent, nobody likes to feel sick. But we recognize even if I feel sick, I'm going to be able to do what I have to do. If I already doubt my capability and then something's thwarting me, like I don't feel well or I'm tired, then for sure I'm not going to be able to do it. And so we choose not to face the situation, which, by the way, does what? Proofs that we couldn't do it. Because if we showed up even though we were tired or even though we weren't feeling well, and we proved that we could still do it, it would change our perspective. Now, when we look at this childhood data, the childhood data may be significant childhood data. A child of poverty, adversity, neglect, abandonment, abuse. And you might say it's understandable, given that history, that you came to conclude things about yourself. Your father told you you were a piece of crap, and he beat the crap out of you. It's understandable that you think that you're a bad person. Why else would dad have treated you that way? On the other hand, not every kid of adversity comes out believing horrible, negative things about themselves. Why is that? Well, it's how we process that information. Did we personalize it? When we give it personal meaning, those things happen to me because of my character flaws. We use it to grow these negative beliefs about ourselves. When we externalize it, well, my dad was a raving alcoholic. You know, he treated everybody that way. It had nothing to do with me, which says that I can have adversity and still come out psychologically strong. Now, the reality is you take enough adversity, you make it chronic, you give a big enough dose of it, and eventually it's going to do a number. But it doesn't have to be adversity to have a profound impact on how you view yourself. A coach says to the kids that just won the tournament, don't you think that you're good enough? You're never going to be good enough. And don't think we're not having practice tomorrow morning at 8 a.m. I want to see everybody on the field. Because you won because you were lucky. Because that game was pathetic. You played awful. Right? And you've heard coaches talk like this. I've heard coaches talk like this. You know, and the kid, you know, most of the kids are rolling their eyes, bull, you know. But the kid that says, you're right. I'm not good enough. And even the coach tells us we're not good enough. And I only won because of luck, not because we played a nice game. You know, that's going to What about the kid that grows up in a family where everybody is musical, except you? They all play instruments, they can sing, and you have no musical talent. I'm defective. What's wrong with me? Or similarly, you grow up in a household where everyone is super jock. And you don't even like sports, let alone want to play them. You don't even know if you have skill or not because you're not interested. Again, I'm the defective one. Something's wrong with me. So you can see how ordinary life experiences can shape the way that we view ourselves. You know, we have learning disabilities, or we have struggle with certain subjects. You know, are we able to say, I have strengths and weaknesses, and some things I'm really, really good at, and some things just my brain doesn't like to process very well? Or do we make those struggles define our identity? I'm stupid. It's how we process it. Question?
Positive childhood experiences. They have parents who are very good role models. They learn values like, if I work hard and I give it my best effort, I'm going to be successful. And so that's the belief. If I do well and I give it my best effort and I build this incredible person, all is going to be well. And then I'm kind of referring back to the same patient. And then I have a life event that just totally...
Yes. So the question is, you know, that we grow up in a world that reinforces positive values, and then we have a traumatic event that changes that. So that happens. Think about rape victims that think that I'm strong and I'm capable, and then I get raped, and it blows away my view of myself. I now think of myself as a weak, fragile person, and I start to avoid going out in public places. Absolutely, that it's not just childhood experiences. Life experiences can absolutely play a role in shaping how we feel about ourselves. No question about it. But as parents, you bring up a really good point. We absolutely can play a role helping to shape positive views about ourselves. If we want kids to think that they are desirable and likable then we can't beat the crap out of them. Or we can't say, I love you, smack. Right? We have to act like we love them, which means even if we're autonomous, we have to compromise our favorite yoga class and be on the sideline cheering them on. And even though we have an opportunity to make money, we got to turn down those opportunities once in a while to be at those important interpersonal occasions, because you matter to me, and I'm going to show up for you because you matter. And I'm going to tell you that I love you, and I'm going to act like someone that loves you. And that's why it'd be really good if in our classroom they went around the room and everybody told everybody something that they liked about each other. And each person, told that they appreciated the light in each and every one of you, right? That's why I say a little yoga in the classroom would be a good thing. And if we want our kids to grow up thinking that they are capable, we have to give them opportunity. We can't thwart those opportunities and make it impossible. We have to give them opportunities, which means we might have to give them the skills for them to be able to succeed. And when they do put effort into something, we have to acknowledge it. And we have to applaud it. We have to be able to say, you did it. Good for you. You worked really hard. Good for you. And that needs to be acknowledged. And when the very young child wants to open the door and you're jiggling the groceries and you've handed them the key and you're impatiently waiting for them to open the door, and maybe you have to go to the bathroom as well, you have to have the patience to hang out and let them open the door. If you take the key away and say, let me do it, what do you say to them? You're not capable. On the other hand, you got to hang out and be patient and let them open the door and then say, yay for you, you opened the door, you got it. And same thing when you help with homework, you don't do homework. When you do homework, you prove that they're not capable. When you patiently help with homework and allow them to do the work, then they get to grow self-efficacy, they get to grow competency. And armed with the belief that I'm capable, and armed with the belief that I'm desirable, life is a lot less threatening. And by the way, if I believe that I'm capable, then I'm not afraid of making a mistake, and I'm willing to ask for directions, and I'm willing to get help if I need it, or recognize I need more training, or I need some supervision. That's not threatening. And if I recognize that I'm desirable and you don't like me, it doesn't ruin my life. Okay, I have to accept that there's going to be people out there that don't like me. And if you break up with me, even though I really hoped we were going to share our lives together, I'm going to know that if I want to share my life with someone, there's probably going to be somebody else out there. And that's why self-esteem is such an important ingredient in wellness, because it does protect us from anxiety. Let's just look at one more example. This is a 15-year-old boy who's been in special ed classes throughout most of his education life. His parents deny that he has a problem. He's made limited progress in school. His parents are unhappy, and they think they're bad parents. And he thinks I'm a failure. I'm not good enough. I'm inadequate. I'm defective. If I try, I'll fail. If I avoid the work, I won't fail. And by the way, negative, positive assumption, you don't need both. They're just the opposite. If I do something, it leads to a positive result, positive assumption. If I do something, it leads to a negative result, that's a negative assumption. It's just sort of you can express it either positively or negatively, or choose to express it both ways. If others are disappointed in me, then I'm not good enough and I'm inadequate. If I do everything right, maybe I'll be good enough. So when he avoids situations, because if I don't do it right, I won't be good enough, and I can't do it right, so of course I'm going to avoid it. Why would I put myself in a situation where it's just going to demonstrate failure? So he works slowly, he loses his assignment, he complains of stomach aches, he does everything in his power to avoid what he believes is an impossible task where 100% he cannot succeed. But the teacher encourages him to do the work, which he says, why are they lying to me? They want me to fail. They know I can't do the work. So he feels even more hopeless, and he avoids the work, constantly supporting his notion that he can't do it, which supports this idea that I am an inadequate failure. On the other hand, the dad becomes critical of his work performance, and he thinks I'm not good enough. He says, I'm a disappointment to dad, which makes me not good enough. Feels sad, gives up once again. Notice the go-to strategy is avoidance, no matter how it's expressed. And then mom volunteers to do his schoolwork. And because he believes if I try, I'll fail, he acquiesces and happily lets her do the work. And then what happens? Mom doing the work just absolutely reinforces that he can't do the work himself. And we're back in that reoccurring pattern. But the problem is that the school, the parents, nobody really understands him. So they think, do I need to be stricter? Do I need to be more encouraging? Nobody understands that at his very core, he thinks that he is an incompetent person. And until somebody addresses that idea of himself, he is never going to have the courage to participate in any of the learning. And so that's why for reducing immediate distress, we work at those situation-specific thoughts. But for enduring change, we got to go back and look at those core beliefs and work on evaluating and modifying them into more realistic perspectives that are going to help us move forward in life. Know that everybody has self-doubt lingering inside of them. And that, but as you were saying, a person that grows up in a world, they might absolutely have no doubt about their desirability because they grew up in a loving home where they say, my parents have my back. I know they love me. I never for one moment ever think of myself as an undesirable person. But on the other hand, everyone in my family was really high achieving. And I questioned my ability to achieve at the level that they did. So my anxiety, my distress comes from my self-doubt about my ability to perform. And my family really valued that, and I really value that. And that's where all my anxiety lies. And of course, the opposite can be true. But know that we all have self-doubt. Of course, the narcissist will tell you that they have no self-doubt. They're superior to the rest of the world. But we know that the narcissist is the most insecure person in the planet, even though they will deny it for sure. But even if we don't have psychopathology, we have self-doubt. It's our insecurity that sometimes talks to us. So yes, the person that was socialized in a way that comes up whole and solid, there are still going to be times when your buttons are pressed and things are going to get the best of you. And when a situation is getting the best of you, it is because you've become schema activated and you are seeing that situation in a way that is creating anxiety or depression or anger or some kind of negative sequelae. But we all have self-doubt. But it may not get in your way, and it may not hinder you. When self-doubt rises and gets in our way, then we're either axis 1 impaired or we're chronically impaired with a diagnosis of a personality disorder. But we don't have to have psychopathology in order to have some self-doubt. And I think it's really important, if we're going to understand others, that we also understand the doubt lurking inside of us. And we're going to do an exercise a little bit later on to see if we can uncover some of that doubt. What we're going to do now is we're going to watch a little bit of a video clip. And this video clip is a little bit old, a lot old. So don't get annoyed by a little bit of the behavior on the part of the client that we might find a little unacceptable in this day and age, and you'll see a little bit of the womanizing that comes up in the session. Don't let it push your buttons. It's a very old work sample. It's a sample where Dr. Beck has been asked to interview a real client as a demonstration of CBT. So he is trying to demonstrate CBT. But it is a very eloquent illustration of putting these principles into practice. You might say, gee, this doesn't look like a typical client, or it might. If you're in a private practice, you might say it looks like my client. If you're in community mental health, you might say this looks nothing like the client I teach. I still show it as a training example because it really does demonstrate a lot of the basic principles delivered in a really attractive way. And what I want you to do when you watch this, so keep in mind this is a one and done interview. He's not going to have ongoing conversations. And his goal was to address the client's problem and demonstrate the principles of CBT. You'll see very early on in the session that the client is a little bit anxious, and Dr. Beck is going to make an effort to socialize him to the model using his data. A lot of times people want to socialize people to the model using some abstract analogy, a baseball analogy, and then I say, you know, well, does your client play baseball? No. Well, don't ever use an analogy that somebody cannot relate to, and it's way better. And I'm not saying analogies and metaphors aren't helpful, they absolutely are, but early on in therapy, use the raw data that's available to you to make your case rather than using these abstract or examples of other individuals. So we're going to see him using the client's data. When you watch this, I also think it would be helpful if you keep that cognitive conceptualization, keep this cognitive conceptualization in front of you, because as Dr. Beck is talking in a conversational way, I want you to see if you can identify the automatic thoughts and the details of his conceptualization that Dr. Beck is eliciting from this client in just a very conversational way. Because when you're talking with your clients, you're not necessarily saying, you know, what is your core belief? You're having a conversation, and that data is coming out as you're having an ordinary conversation. But if you have that roadmap in your head of what you're trying to elicit, you're going to steer the conversation in a way to get the data that you need.
Is a kind of a blueprint which we use in order to organize the information that we obtain from the patient. This blueprint helps us to understand the patient better, and it also enables us to select those tactics and strategies that will enable us to treat the patient. The main objective in the therapy is to try to adjust the patient's biased thinking in such a way that it conforms in a more regular and accurate way to the actual external reality. Now, there are many techniques that we use in cognitive therapy. First and foremost, it is important to establish a good working relationship with the patient. This is something that we call collaborative empiricism. The patient and the therapist work hand in glove, testing out the patient's beliefs, evaluating them, seeing whether they're accurate or not, and modifying them according to the requirements of reality. Secondly, the therapist uses questioning in order to unravel the mystery of the patient's problems. This is something that we call guided discovery. The patient and the therapist try to work to ascertain just what the distorted thinking is, and then they attempt to evaluate the distorted thinking. There are many ways in which one can evaluate conclusions that a patient makes which do not seem to conform to reality. First, one can ask, what is the evidence for your conclusion? Are you leaving anything out? Are you omitting contradictory evidence? Does your conclusion follow logically from the observations that you have made? And finally, Are there alternative explanations that may be more accurate in explaining a particular episode? The ultimate goal, of course, is to correct the patient's misconceptions. Once they are corrected, the depressed patient becomes less depressed, the anxious patient becomes less anxious, and the paranoid patient becomes less paranoid. What do you feel about being here?
I'm very nervous.
Anything else?
My stomach is turning. I think my palms are starting to perspire a little bit. And I am concerned about how well I'll come across. If I can maintain my faculties to communicate, keep a good conversation going.
Now, do you remember having thoughts of that nature? Will I come across well? Will I be able to carry on a conversation? Will I be able to perform properly? Did you recall having had those thoughts?
The closer I got to your office, the more severe the thoughts got.
And as the thoughts got more severe, what happened to your symptoms? The anxiety, the stomach, the sweaty palms?
My stomach started to churn more and more. I felt a lump in my throat. I found it very difficult to breathe.
So in addition to the stomach, you had other physical symptoms, such as a lump in your throat and some problem in breathing.
Yes.
Now, can you see any connection between these very fearful thoughts that you had and the symptoms that you're experiencing?
They run together. I'm almost like jelly.
Yeah. So one of the things we want to look at is to see whether this type of thinking that you do produces the types of effects, both psychologically in terms of the anxiety that you feel, and also physically, the funny feelings in your stomach and the sweaty palms and the choking sensation that you get. We want to see if indeed the thinking produces the anxiety symptoms. Now, if the thinking isn't reasonable, if it's way out of line, you can correct the anxiety symptoms by correcting the thinking. For instance, it might very well be that it doesn't matter how you perform here. And if you could be convinced that it doesn't really matter, that it's my job rather than your job, then you wouldn't feel anxious anymore.
That would help, yes.
So let's look at it right now and see if it's true. Whose responsibility is it to carry on the interview, yours or mine?
Yours.
Right. And what's your role?
My role, I'm here to gain knowledge and help me with my anxiety. That's why I'm here.
Right. And so your role is simply to be able to answer questions, and performance or being nervous and so on doesn't at all interfere with giving us information, because your nervousness itself is a form of information, isn't it?
Yes.
So the responsibility isn't on you, is it?
No.
Right. And the question of evaluation isn't on you either.
No.
Right. Now, what do you think would be a more reasonable way to put your role in this particular interview?
I am to respond to what you ask me, but I also have to be honest with you, because if I'm not honest with you, then you won't be able to feed it back to me.
Right. Now, does the anxiety prevent you from being honest?
No.
So you can be honest whether you're anxious or
yes.
not. Honesty has got nothing to do with performing well, carrying on a good conversation, being a polished speaker, and so on.
Okay. Yes.
Right.
Yes.
Okay, now that we've gone through that and restructured your role, how are you feeling?
I feel better. I'm still anxious,
Right.
but I feel more comfortable now.
What you can see when a person changes his thinking from something that's kind of exaggerated, such as I have to perform well, to I just have to do whatever comes my way, you can see when the thinking gets modified, then the emotions do change. So let's see how this develops now in terms of your major problem.
So if you think about that roadmap, the cognitive conceptualization diagram, and we look at the bottom half of that, situation 1 is the interview with ADB. So what automatic thoughts did he elicit? I'm concerned about how I'm going to come across. I might not be able to maintain my faculties, carry on a conversation, concerned about how I'll perform. And as a result, he was feeling nervous. His stomach was churning. He had a lump in his throat. And how about his behavior? He's very formal. He's very reserved in his speech, almost affectless in the way that he's communicating, trying to be very appropriate and make sure that it sounds good. And then what does Dr. Beck do? Ask questions, right? He says, hey, if you were able to see that the burden was on me, not you, you might be able to feel better. He said, yes, but he didn't leave it at that. He used the principles of guided discovery by asking him questions that led the client to conclude that it was ATB's responsibility to carry on the interview and not the client. That his nervousness was information in itself, it was helpful, and that nervousness was not going to interfere with him being able to provide the information or being honest, which is the most important thing that he do, is simply be honest. And the responsibility is not on the client, but on Dr. Beck, and that the one being evaluated was Dr. Beck and not the client. So before they even could really get into the problem, what did he do? He reduced the anxiety, working on what? The relationship, in order for them now to begin getting to work in the interview. Okay, now as we move on, we're going to look at the top half. We're going to look at the bottom. Situation number 2 is we're going to look at this depression, and then we're going to find data to help us start to flesh out this individual's conceptualization.
Now, what is the reason why you're coming for therapy at this time?
I just went through a divorce, and I'm depressed, and I have a lot of anxiety.
Now, first, what I'd like to do is look at your depression itself. Is that okay?
Yes.
So let's examine the depression and see just what it's made up of. Now, on what basis do you think you can make the diagnosis that you're depressed?
I have that terrible feeling in my stomach that I am just very lonesome, and that I will be alone for the rest of my life. And at this point in my life, no one wants me.
Now, it seems that your depression then is made up of the fabric of several conclusions. One is that you're lonesome. Number 2 is that you're alone now. 3 is that you're going to be alone for the rest of your life. And 4, that nobody wants you. So this is the way you see your life situation, in a very negative way in terms of you and other people.
Yes.
Now, how do you view yourself? As you look at yourself, do you see yourself in glowing, positive terms?
Okay, so before we hear how he thinks about himself, situation 2, and we're going to hear more about that as we listen, is he's home alone feeling lonely, which is going to come out. And when he's home alone feeling lonely, notice he says, I'm divorced. Divorced is not the situation. Divorced is the context. He's a divorced man. But when he is alone and feeling lonely, he thinks, first of all, he feels depressed and hopeless. And he thinks what? I will be alone for the rest of my life. No one wants me. And then actually we're going to hear later what he does is he does nothing. So again, do you see how the data to understand their situation-specific thoughts is readily available if you're asking conversations that guide you to listening to that? So you can either let a client go on and talk endlessly, or you can guide the conversation in a way that you're getting the useful information that you're trying to elicit. Okay, so remember, as we continue to watch Dr. Beck having a conversation with this client, we're looking to fill in the pieces of the puzzle on the cognitive conceptualization diagram. So again, keep the cognitive conceptualization diagram out, and let's see if you're hearing the same information that I'm hearing as I'm collecting this information.
I feel good about myself. And I feel that after the divorce, with a new position, with a new company, that I'm ready to get started in life all over again at age 47.
Notice new position with a new company. I'm ready to get started in life. Notice that there's no angst about having to have a new job. So what does that say to you? That his self-doubt does not lurk in the domain of competency. You know, he's good. All of his distress seems to have to do with his interpersonal struggles, which speaks to a more sociotropic domain. So we're going to look for the label of his doubt having to do with something that has to do with not being desired.
But it still does not eliminate the loneliness of today.
So the major thing that seems to bother you is your loneliness.
Yes.
Now, as you look back on the past, how does your past history seem to you?
Stinks.
In what way do you feel your past history stinks?
Because I was very lonesome as a child. I had no brothers and sisters. My parents were alcoholics. I made very few friends as a youngster. And I felt that from as far back as I can remember, I have always had a shell around myself. I've always kept everyone at arm's length. I would never get close to anyone.
And in recent years, did you feel that you made a success out of life in, say, the last 5 or 10 years?
I made, when I got married 5 years ago, I felt it was a tremendous emotional experience for me, because it was my first marriage, and here was a woman, which I felt at the time was the most wonderful woman in the entire world, wanted me, and that made me feel very good about myself at that time. As far as, but now we're going back through the divorce again, I'm back having some doubts about myself again.
And now as you look back on your past, how do you view yourself?
I view myself as a product of my childhood, and it wasn't my fault that I was that way as a youngster.
And how do you feel then this childhood development has affected you, say, in recent years?
As a child, I spent practically my entire childhood by myself. I received virtually no love as a youngster. Being an only child and my parents drinking a lot, I had no one to communicate to, and there was a lot of fighting in our family with my mother and father, because I would just hide in the bedroom, and it made me a very, very sheltered person.
Yeah. Now, sometimes when people have a childhood like that, they reach certain conclusions about themselves and about other people. What conclusions do you think you have now that may have originated back there? How do you see yourself now in terms of the childhood experience?
After going through some counseling this last year, I feel good about myself now.
And prior to going through the counseling, how did you feel about yourself?
I was a goddamn jerk.
So you regarded yourself as a jerk, and in what ways were you, quote, a jerk at that time?
Hooray for me and screw the world. I had a lot of anger in me. I looked at, I didn't try to look at the positive side of people. I always looked at their bad side. And I was very negative. And I had an attitude of, I'm going to get them before they get me.
So up until you started the counseling, you had a lot of attitudes about other people, which was sounds kind of competitive, dog eat dog, is that right? And it was like who's superior and who's inferior.
Yes.
And I'm going to hold people at arm's length.
Yes.
And at that particular time, the loneliness did not bother you.
Yes, it did bother me.
Even so?
It bothered me then. I didn't know any better. I didn't know what to do. Where do I go to change into being a good human being? How do I get started? I've been very lonely all my life, but Either I was too stupid or I just didn't know what to do to get started on the right track.
Yeah. Now, do you think that this kind of standoffish attitude that you had, being aloof from other people, set you up for being a lonely person? Like, before you started the counseling, you say, I'm going to step on these people before they step on me. This idea of seeing people as in opposition to you, do you think that that might have affected you in terms of your relationships with other people?
Oh, yes, by all means. Yes, I can see, just in the last 6 months, I can see a different attitude of people towards me. When I go to someone and I'll put my hand out and I'll shake their hand, and I'll radiate warmth and love and kindness, whereas before it was who's got the strongest grip, and don't look me in the eyes, you son of a bitch, because I'll stare you down.
Now, how strongly do you feel this other notion? I don't want to hop on it too much, but it does seem to be the core of your depression, as you said, that you've always been lonely, you always will be lonely, nobody wants you, and you're never going to be able to find somebody who will want you. How strongly do you believe that?
I don't believe it at all.
So you don't really believe it?
No.
So on the one hand, you say it, but on the other hand, you don't really believe it.
It's when I'm laying around the house by myself, and I have absolutely nothing to do. I've got nobody to call, and it's Saturday afternoon, and I have no date, and I've got nothing to do, and what am I going to, nobody wants me. I start feeling sorry for myself.
I see. So when you're actually in an isolated condition, then these thoughts come up. But right now, when you look at these very same thoughts, you don't believe them.
No.
You don't. Now, let me play the devil's advocate. Why don't you believe them?
Because I feel now, at my age, I am maturing, and I am becoming a good person, and I have something to offer to society.
And since you are maturing, becoming a good person, and you have something to offer to society, what does this tell us about the probability of you finding somebody that you can be close to?
Excellent.
So right now, are you still feeling depressed?
No. I'm starting to feel better.
Okay. Now, what's going to happen when you're lying in bed?
So if we look at the cognitive conceptualization diagram, in how short a period of time? In a 10-minute conversation, Dr. Beck has developed a comprehensive view of this individual. We really have a sense of what pushes his buttons, what doesn't, where he's vulnerable, what led him to be vulnerable. So let's look at the data we collected. So what happens? So he says, I was an only child with very few friends. I had no one to talk to. My parents were alcoholics. Nobody showed me any love. My parents were always fighting with each other. So it gives us a sense of his background. And then he says that he used certain strategies to cope with the life that he was a part of. What did he do when his parents fought? He isolated. He hid. And in fact, what does he do when he's depressed and alone? He isolates and he hides. So that's his go-to strategy. He also did what? He put a shell around himself. He kept everybody at arm's length. How are you going to get connected to people if you keep them at arm's length? He would look at the bad side of people and be very negative. And then he was highly competitive, right? I'm going to shake you down. And Dr. Beck said, you know, how do you think that played a role in, you know, how you wound up being? And absolutely, if you keep people at arm's length and you're competitive with other people, you're not going to be embraced by them. And then what happens? If the most wonderful woman in the entire world wants me, I feel good. I feel loved. And then what happens? If the most wonderful woman in the entire world doesn't want me, now I feel bad. Now I feel unloved. And then look at his other ideas. Hooray for me, screw the world. So we can have assumptions, which are if-then statements that link the belief with the behavior, or we can have pervasive rules. If I don't get them, they'll get me. So always on the attack, always competitive in that way. And what did he think about himself? He thought he was an unloved jerk. And, and then what happens? She leaves him and confirms that I'm an unloved jerk. And then he's sitting alone on a Saturday with no plans, nothing's working out, which leads him to the automatic thoughts, I'll be alone forever because basically I'm an unloved jerk. But then what happens? Then he's getting some therapy. And notice, by the way, that Dr. Beck is taking notes. We don't typically do CBT without taking notes because when we paraphrase what's said, we change the nuance of meaning. And that's why it's really important to give people back their thoughts verbatim. So Dr. Beck looks at these automatic thoughts that I'll be alone for the rest of my life, that no one's going to want me, and alternatively, the client says, now I'm starting to radiate kindness. I am mature. I'm becoming a good person. I have something to offer society. And Dr. Beck says, well, now that those things are happening, what's the conclusion? Again, it's really important in doing CBT that when we collect data, that we make meaning of it. What's the point of collecting information if you don't use it to make some kind of meaning? Well, the meaning is that I have an increased probability that I actually could meet somebody, which makes me feel less depressed, which makes me feel less hopeless, which makes these upsetting thoughts less believable. Now, the truth is that just because I have an increased probability of meeting someone doesn't mean, number one, that I'm necessarily going to. And number two, the question is, do I really need a woman to be happy? And we're going to watch how Dr. Beck addresses both of those issues when we watch a little bit more of the video sample later in the day. Yeah.
I look at that as him healing his adult self, getting in touch with his small inner child self, recognizing what was going on there, and healing that inner child so that he can now be healed as an adult.
Yeah. And a lot of what we do as now that we are mature, now that we are wiser and more experienced as adults, a lot of what we do is heal the inner child. But we heal the inner child through a cognitive behavior perspective by re-looking at the misinterpretations we made in our childhood, by re-looking at those experiences and seeing if the conclusions we made are valid or maybe they weren't valid, so that we develop more healthier views of ourselves rather than holding on to long-term views that may not have been valid, but with acknowledging the ugliness of our histories, with acknowledging how it's understandable that you may have come to these conclusions given the kind of experiences we have. So it's really important not to negate those experiences, to recognize those experiences, to validate those experiences, but to help them see the meaning they gave those experiences doesn't necessarily mean what they let it mean. Now, what we're going to do right now is that we're going to do a little role play experience that hopefully you're going to find to be very enlightening. And so what we're going to do is that you're going to have a dialogue with somebody in this room. So you're going to have one person, and it's going to be a dialogue between two professionals. So it's not client and therapist, it's therapist and therapist having a dialogue. You're going to take that case and whatever works out, maybe like the two of you, maybe you'll work it out. If there's an odd number, then there might have to be a group of 3, but let's try to work in dyads. And what you're going to do is take out that case conceptualization, and each of you are going to try to fill out the case conceptualization for the other person. But rather than spending 10 minutes talking about you and then 10 minutes talking about you, you're going to have a dialogue back and forth where each of you are going to try to put the puzzle pieces together to develop a comprehensive view of the other individual. Now, where do you start getting the data? It doesn't matter. You want the big picture? Now, typically with clients, we start at the bottom. You know, was there a situation that happened recently that evoked strong emotion or that was particularly upsetting or bothered you in some way? You know, although I don't normally get angry, there was a time where my anger alarm was really ringing. So you could talk about a specific situation. What were you feeling? What were you thinking? What behavioral action did you take? And as you look across situations, you could start to say, what's the theme across the situations? Does it have to do with my desirability? So it's a more sociotropic theme, or does it have to do with my competency? It's a more autonomous theme. Or do the situations represent some of both? Once we know the theme, once we know its desirability, then it's easier to start to see, well, is it about being unlovable, being a bad person, being not good enough, being undesirable? So then we look for the specific label or labels. On the other hand, you might start with the coping strategy. You know, I like to take charge of the situation. Sure, we can go anywhere. What are my options? Let me Yelp it before we decide. Oh, you want to go to dinner? You pick. Where did you pick? Let me look at the menu, right? So think about it. What is your coping strategy? Is it to have a glass of wine? Is it to exercise? Is it to practice mindful meditation? Is it to cut yourself? Is it to attempt suicide? Is it to smoke crack cocaine? You know, what's your go-to strategy? Is it to delegate to somebody else, or is it to take control of the entire project and do it all yourself? Is it to watch TV? Escape, distract? What is your go-to strategy? So you could start there. Or you might actually know what your core belief or beliefs are. Or maybe there is a memory imprinted in your brain. You know all the details. You can name the players. That means that that memory is a significant event in your life and is playing a role in your character development, how you view yourself. So you can start with a very vivid memory and think back to the memory and say, as a result of the memory, what impact did it have? Did it have an impact on what strategies you use? Did it have an impact on your assumptions? Did it have an impact on your beliefs? And then remember, the assumptions are the link between the belief and the behavior. If I do this, then it protects me from my vulnerability. So if I think I'm a failure, if I'm perfect, then I can't fail. So then my coping strategy is perfectionism. So that's the link. So you're going to try to put all your puzzle pieces together. Those of you that are listening and not in the room, you can fill out a cognitive conceptualization diagram on yourself. Now, also, if you're at home and when you go home, you can practice this with all your relatives and friends and significant others. Because you know what? Once you understand the significant others in your life, the people in your life, you're going to know when they're exceptionally upset over something you think is nothing, why they're so upset. Because it activated an underlying belief that led them to see that situation in a very upsetting kind of way. All right, so let's try for about 15, 20 minutes. I'll check in 15 minutes and see if we need to push it a little bit further to do a comprehensive job on each other. No, okay, so ideally you are yourselves. So you are you and you are you. If it is too uncomfortable for you to be yourself, you can role play a client. But if you're role-playing a client, it can't be I'm making up this information. It has to be a client that you know well enough, that you know what their words would be. But even if this makes you uncomfortable, I would encourage you to make yourselves uncomfortable, because that's what you ask clients to do. And I would really try to have a conversation true to who you are. Try to get an understanding of yourself. Okay? Yep. No, they didn't give you a blank one, so, yeah, you can draw it out. Yeah, I think that there's another person that needs a partner. minutes. Okay, let's join back up. Are we good with time, or do we need another minute? How many need another minute or two? Okay, then 2-minute warning, all right? 2-minute warning. Let's back up. Okay, so my first question to you is, was this, get everyone's attention, if I could have everyone's attention? Okay, so my first question to you, was this a doable exercise? Okay, so what made it manageable? Yeah. Yes. So what you're saying is that once I knew the strategic plan, once I knew what I was going after, doing the work was easy, right? And even someone said it was fun. And therapy can be fun. Therapy doesn't have to be, it can be a very pleasant, fun experience. Sometimes more challenging than not, but it depends. But it can be fun. And the point is, when we have a strategic plan, when we know what we're trying to do, when we know what we're going after, the path is so much easier. Now, any particular points of this dialogue that presented from some challenges for any of you? Uh-huh.
In the beginning, my challenge was just trusting, but I think her voice was so calm and so peaceful, her eye contact, her body gesture, and before I know it, I was like, mesmerized, I was hypnotized, I was about to tell her.
You were ready to disclose all the details.
Everything.
Yeah.
And, she just made me feel safe and comfortable.
Yeah, but
I wasn't judgmental, and of course, before I saw her, I said, oh my God.
Yeah.
She gonna be judgmental. I'm probably gonna have to cuss her out and leave out of here.
No, but your little bit of resistance to share that personal information is exactly what many of our clients experience. You want me to put it out there? And a little bit of skepticism, is it safe to put it out there? And really sitting in your client's shoes, guess what? You found out that your therapist was not judgmental, that they were willing to give 100% undivided attention to you, and that engaged you to want to tell you all your secrets. In fact, even more than she was asking for.
And she did some good motivational interviewing skills here. I mean, she just motivated me to just blabber. I was about to tell her everything.
Yeah.
It was just good.
Which brings us to our own automatic thoughts. That we have automatic thoughts that activate some anxiety in us that think we're not going to get this cooperation out of people. Well, how do you know until you try? And that's why I have you sit in the shoes of the client so you can see, wait a minute, I wanted to resist at first, but actually the floodgates just opened, which is what's exactly going to happen with your clients. Anywhere else that you may have gotten stuck?
I had a hard time figuring out for mine what the trigger was as a child. And so I got to a point where I just don't know.
Yeah.
And I mean, because sometimes our clients just aren't going to know that either.
Yeah. But the question is, whatever the view you have about yourself, you need to say, where did this idea come from? And so it may not be that you remember a specific event, but you can say, what is the earliest memory you have of thinking about yourself this way? What was going on in your life? How old were you? And maybe you can go back and say, you know what? I had just switched from a school to a new school. I didn't know anybody in the classroom. It starts to put you in touch with what were the things going on in my life that made me start to think of myself in the way that when I'm down on myself, this is what I call myself. And we do all have that nasty name. When you do something, you want to kick yourself. I can't believe I said that or did that. Do you say to yourself, oh, you're so stupid? There is a word that pops into your brain that you call yourself, that it gets activated from, it's somewhere in your past. That was the name you called yourself. And we really want to find out what experiences, what messages are linked to that idea that you started to grow. Does that help you get in touch with what could have been going on?
Yeah.
Would you be willing to share what your belief is?
No.
Okay, you don't have to.
No, because I'd have to actually think back on it.
Okay, yep, no worry. I might be able to help pull it out of you. Yep.
One thing that I did that usually doesn't happen in a session, maybe, is that when he was giving his story, I was getting excited because we have a whole lot in common.
Yeah.
and there is some parallel stuff going on because when I deal with Vietnam veterans, I happen to be of
Yeah.
and I'm better.
Yeah.
And so there's some parallel stuff, but this was really, there was a lot of really similar things. And then it was my turn.
Yeah.
So I just spewed it out. I mean,
Yeah.
I think it's
And that is why a lot of times I do this exercise as a dialogue therapist to therapist, because so many people find out that we actually have a lot in common. I mean, you have actual physical experiences that you might have in common, but a lot of people find out, well, I have the same kinds of ideas, or I had similar background as you. It's interesting. And that background led me to a very different conclusion, even though we had the same backgrounds, we had the same experiences. Isn't it interesting how it impacted us so differently? Or maybe how it impacted us so similarly.
And they were different. They weren't opposed, but they were different.
But they were different. Yeah, so exactly. We're from the same world, but different impact. So that's really helpful to hear that. Mm-hmm.
As I was interviewing, she was really good to interview. As I was interviewing, I was trying to think about the diagram, and I was just trying to think, I'm here to gather information, and then I would ask, I'd ask a question, and I would try to parrot it back, but in a way that, would lead to a little bit of maybe her thinking about things differently, like, so you were successful at this, and you were accomplished at this, and you were able to do this, yet you're concerned about this. And so following, having the path and following the model,
Yeah.
I think, and I think that's why I came across as not judgmental, or
Yeah.
because I was focused on her.
Right, because you are just eliciting information. You're curious. I'm really genuinely curious to understand you. That's not very threatening, because I'm just getting to know you. And when you say to someone, I'm trying to get to know you, that's a positive thing. That's not usually perceived as a negative thing. Huh?
We had very similar backgrounds, and it's interesting because it's safe to say that we kind of saw our beliefs and stuff were almost parallel, and I was really interested.
Yeah.
Yeah.
And it really, and when we start to understand each other, we do realize globally how much alike we all are in the planet versus how different we all are in the planet. And it also reminds us that we all have, good and bad in our history. There'll be good and bad in our future, and that we all have vulnerability. And same thing, when a client shares something that you share as well, it might be appropriate to let them know, that's really interesting. I come from a really similar world. Or, you talk about, I can really relate to that. My mom was in some ways a lot like yours. So, and I think that that's valuable, that when you can connect in that kind of way. So now that you know what you're looking for, you're going to have an easier time getting that information from your clients directly.
I usually don't take notes because I feel like if I lose eye contact, I don't want them to think I'm not paying attention.
Yeah.
And because a lot of the clients
Right.
have been abandoned and nobody listens to them.
Yeah, so clearly losing eye contact is your automatic thought they're going to think I'm not paying attention. We don't know whether or not they think you're not paying attention. So that's our idea. And I would say that absolutely if you made no eye contact in a session, it would not be a good thing. On the other hand, if you stop to take a note, it depends what you do with that note. If you look back at that note and you share with them what you wrote on that piece of paper, then what are they hearing? I'm hearing that you're paying a lot of attention. I'm hearing that you're getting it exactly right. And often what I do with clients is I take the paper that I'm writing on and I turn it around and share it with them and say, look what I put in quotes right here on my piece of paper. Did you say this? And we talk about it directly. Or if a client says to me, can I have a copy of what you've written down? Like, no problem, because I haven't written down anything that is a judgment or an interpretation. I've only written down the raw data and the conclusions that we've drawn together. I'm happy to share that information with you.
Just my automatic thought.
Yep. So cognitive therapy is a focused form of psychotherapy based on the model psychological disorders involve dysfunctional thinking. Again, the etiology can be anything and everything. Regardless of the etiology, once you're psychologically impaired, a disorder of thinking, a bias is operating. But the bias is different depending on the diagnosis. In depression, it's negative bias. In anxiety, it's exaggerated perceptions of threat. In anger, it's unfulfilled demanding expectations. And as we talk about different diagnoses in more detail, we're going to talk about understanding that diagnosis through the perspective of the cognitive model and then how to intervene. The way an individual feels and behaves is influenced by their perceptions situation specifically, and those more global beliefs, and that although modifying dysfunctional thinking provides improvement in symptoms, modifying dysfunctional beliefs, which underlie the dysfunctional thinking, leads to more durable improvement. And Zindel Siegel did a nice little study really documenting this point. He had severely depressed patients, and he randomly assigned them to two groups. One group just worked at the automatic thoughts at the situation-specific level, and one also worked at the core beliefs. And what he found is those individuals that did the work at the belief level had lower rates of relapse. And then cognitive therapy involves the conceptualization of the disorder, what's the problem in thinking, and the particular patient, the cognitive conceptualization diagram that we've just done, and then the techniques that we use to move them towards recovery are unlimited. Whatever techniques are in your toolbox, of course we're going to do some cognitive restructuring, so we're going to use cognitive techniques, but we're also going to use behavioral techniques and experiential techniques and maybe Gestalt techniques. Maybe you have your perfect person standing on the chair talking to the non-perfect world. So whatever techniques are in your repertoire can be used as long as the rationale for why you're using it is based on the cognitive model. So it is not the technique that we deliver that defines us as CBT providers. It's the way we conceptualize people and their problems that defined us as CBT providers. And that's why the techniques can be very different depending on the protocol that you might be adhering to. And this just reiterates what we've been saying all along. All the same concepts that we've been talking about all morning: good client-therapist relationships, collaboration, it's problem-focused, and that we do start out focusing on the here and the now. It is an educational model. It is goal-directed, and that's why it's time-limited. The sessions are structured, and people do have to be taught how to pay attention to their own thoughts. And then we use a variety of techniques to change thinking, mood, and behavior. So the key components of treatment, obviously we don't do any treatment until we do a thorough diagnostic eval. We do that to make sure we're speaking the right language. We do that to make sure that we are aware of all the major psychological problems that may need attention. We start, of course, most importantly, with that problem list. We develop the conceptualization, we work on the relationship, we are agenda-focused and that we are work-focused. We are problem-solving in orientation. And again, when we think about problem-solving in orientation, it's with the mindset that there is no one right solution. That there are going to be lots of options. And each option is going to have a different set of pluses and a different set of minuses. So the point is to guide them towards making a decision that is in their best interest. Sometimes there are multiple decisions that all would be in their best interest. And it really is a flip of a coin which one to pick. The point is, who does the picking? Well, ideally, the client does the picking. They make the decision of which course, which path they want to take. And we have to prepare them that, again, that the path that they choose based on the data available is might make sense. And when it doesn't make sense a month from now or a year from now, it's not because you're a bad decision maker. It's not because you didn't make a good decision. It's because you didn't have the data available to know that the decision you were making was going to be problematic. So it happens all the time that we make decisions and then new data comes in. If we had known that, right, in hindsight, but we didn't know that. Also, keep in mind that when we make a decision, if it doesn't work out, typically we can change our path, we can change direction. That is why, by the way, suicide and homicide are not problem solving. They're escape, because there is no turning back. Once you die, there is no other alternative. Once you kill somebody else and cross that line, there is no coming back from that. And that's why everything else in life that we do, there is always another path or a modification of our path that we can take. So it's safe to make decisions. And that's a lot of therapy, is having the courage to make a decision, whatever it is. We're going to talk about the structure of therapy. Therapy has a beginning, maybe multiple middles, and an end. The beginning of therapy always starts with some kind of mood check. David Burns, for one, has done a lot of research. And when you ask therapists, how good of a job do you think you do at knowing how your client is doing or feeling when they show up into your office? How good do you think you are at predicting how they feel when they're sitting in front of you? Pretty good? Not so good? How many think you can pretty much guess how they're feeling? Yep, just looking. So, just looking at them, how well do you think you can predict how they're feeling?
It depends on your relationship with the client. If you just start.
Yeah. So a number of you think that you can do a pretty good job. And some of you say, I have no clue? No?
Sometimes, but usually I think I'm pretty good.
Yeah.
Every once in a while I'll do.
Yeah. So it's interesting. Research has shown that we're actually absolutely ineffective. Yeah. We think that we can tell, but we can. And the reality is that somebody can come in all groomed and put together, little smile on their face, and be absolutely miserable because they want approval. They want to, listen, I'm not denying that sometimes when somebody is profusely crying or they're very agitated, that you can tell they're in distress. But research says that you can't tell. It feels like you can tell. Research says we really can't tell. But we can get a more reliable, valid sense of mood by doing what? By asking them on a Likert scale. Not just how you doing today, because what do people say when you say how you doing today? I'm fine. How many people asked you? I laugh all the time when people ask me how you doing. What are you going to say? Terrible? You say I'm doing fine. If you really want to know how they're doing, you need to do some kind of formal mood check. Even asking one question on a Likert scale, on a scale of 0 to 10, 0 to 100, how are you doing today, overall mood, is a more reliable source of information than simply saying, how are you doing, or trying to decide by looking at them how they're doing. More questions, more reliable. That's why mood inventories are more reliable and valid sources of mood assessment. So David Burns, for one, makes his mood scales, which are very short, available on the internet for free to be able to use to evaluate mood assessment. The Beck scales are the most reliable self-report measures of mood on the market. And there are Beck scales for depression, anxiety, hopelessness, suicidal ideation, and there are adolescent scales as well. But those scales must be purchased. If you're doing a research trial, you can get dispensation. You don't have to pay for them, but you do have to purchase those scales. There are other readily available scales, the Zung. There are other mood inventories available. But having a mood inventory is a more objective indice of mood. This is evidence-based treatment. We're looking for progress. A mood inventory is an objective way to say, is change happening? So when a client says, how am I doing, am I getting any better? Well, that's not for us to say. That's for them. Well, what did you come in here to work on? Have you made any progress? Let's look at your mood inventories. Wow, let's look at the graph if we plot all your points. It's pretty dramatic, the shape you're in now, than when you first came into this office. So realistically, ideally, you might want to give a mood inventory every single time you see somebody. Realistically, that may just not be what you're going to do. In my private practice, I give a battery of mood inventories the first time I see somebody. I get a baseline. And then week by week, I typically get a overall mood rating of how they're doing. But it depends. If I'm working on acute depression or anxiety or hopelessness or anger, then I specifically address that mood specifically. So I might say, overall, how you doing this week? 0 to 10. How you doing today? Because today may not be representative of the week. And on the mood inventories, it's based on a week, not on that day. And then I might say this week, how's your depression been? Has it been really high? Has it been low? Let's get a number on a scale of 0 to 10. How's your anxiety been this week? 0 to 10. Is the anxiety score coming down, but the depression score staying high? If we're focusing on anger, how's the anger been this week? Has it been getting the best of you, or has it been under control? So we get some kind of check-in on mood that we can be assessing. It's a really important signal. A person whose overall mood has been a 6, and they come in and it plummeted to a 2 or a 0, obviously that's going to be a talking point. Wow, what's going on? Similarly, if it rises up high, how come there's such a big mood improvement? Did something happen that we need to be talking about? The advantages of some of the mood inventories, especially the Beck inventories, there's items on there that address hopelessness and suicidality. So instead of asking every single week, is there been any kind of concerns with suicidality, you have an instrument in front of you where you can take a peek to see if there's been any change in suicidal ideation or any change in hopelessness, because an increase of hopelessness is risk for suicide. So that data can be very helpful. Also, depressed patients. Depressed patients don't go from being severely depressed to not depressed. They go from severe to less severe to moderate to less moderate to mild to less mild to not depressed. That's why a mood inventory shows progress is being made, even though they're still clinically depressed. And then so I will give a formal mood inventory at the first time. I'll do these other kinds of check-ins. And then intermittently, I will redistribute those batteries of questionnaires. So, maybe around week 8 in treatment, as we move towards symptom reduction, which might be 12 or 15. And then maybe many months later, when we're just checking in, or if there's been a reoccurrence of mood symptoms, I might say, hey, let's get a check at that BDI and see if we're getting an ugly number again, and check in that regard. There was a question in the front.
It was just about the concept of, how much can you really trust your intuition or your gut instinct? Because the biggest example is when you have someone who suicides.
Yeah.
And we almost always, well, I shouldn't say that, so often we look at it and we're like, what?
Yeah.
I can't believe that.
Yeah.
It's because we can't tell.
Because we can't tell. Absolutely. We can't tell. We think we can tell. We can't tell. So we check in on mood. I do a med check on every client, and I'm not a prescribing doc. A med check simply means, are there meds in the equation? You need to know, are the meds in the equation? Are they causing you any problems? Yeah, there's meds, but I'm not compliant. If they're not compliant, you need to know they're not compliant. If they're giving them all kinds of side effects, if they're scared to take them. So this is just a check-in. This is not a conversation about it. It's a check-in. It's a check-in on the homework. Now, so do you remember what we assigned for homework? Did you do some homework? Is there anything you did this week to put the principles we talked about last week into practice? It's a check-in. If medication is an issue, and you need to be talking about it, then it becomes an agenda item. So the check-in may be all that you need to do. Yep, still on the same meds, no changes, all good. I don't think they're doing anything, but I'm taking them, right? On the other hand, if they say, you know, my psychiatrist really wants me to try this new med and thinks it would really be good for me, but I'm really afraid to take it, then you might say, would you want to talk a little bit about that fear today in session? Yes, that would be really helpful. Okay, now it becomes an agenda item. Homework, I didn't do it. Oh, well, maybe we can spend a little time today talking about what maybe got in the way of doing it, or whether maybe it didn't even make sense. No wonder you didn't do it. Or maybe it did make sense and we got to figure out what got in the way. Okay, we'll put homework now on the agenda. But maybe just a couple-minute check-in on homework is all you need for that particular homework assignment. Yep, it went just as we planned. It was really helpful. You know, we're good to go. So now also, we're not putting out brush fires. It's not like every session is independent. All the sessions are meant to be linked, which means that you want to bring all the material from previous sessions. You know, we've been working on this. Do we want to continue working on this? Was there anything I said last week that was powerful or had an impact on you? Was there anything that we said last week that didn't quite jive or wasn't working for you? This is your chance. And then we set the agenda. The agenda is a couple of items, not a monster list. We're going to talk more about what that agenda looks like. And then we get down to work. Now, we might have a separate conversation about homework, or we might talk about homework in the context of one of the other items that we are talking about. Now, notice, ideally in an agenda is not a topic, it's a problem. A topic is, I want to talk about my boyfriend. Well, you know, we could spend the next 3 months talking about the boyfriend. A problem-focused agenda is what regarding your boyfriend do we need to be talking about? Well, I'm not sure that this relationship makes sense. Okay, now we have some direction for our conversation. Or my needs are really getting squashed in this relationship and it's really starting to bother me. Now we have a direction for what we're talking about. And then as we talk about each item, we make sure that we do the work, which means we focus on the key cognitions and behaviors. We summarize the work as we do it. We get some feedback and we assign homework relevant to what we talked about. So for each agenda item, we do all of that work. It's not like you finish a session and then you assign homework. You talk about a topic, you talk about what you learned from talking about that topic, and then you figure out what you're going to do that week to put what you learned into practice. And then the end of the session is the overall summary and a review of what the game plan is. Now, right from the get-go, we want to orient clients to the structure that this is how we're going to work. I'm going to check in on your mood. We're going to decide ahead of time what problems we want to focus on. We're going to focus on them. We're hopefully going to get to a conclusion that is going to likely reduce your stress or give you a tool that you haven't had for you to try. And hopefully there's going to be something you're going to do between sessions that's going to help you continue to feel better. And then, and also that they recognize that you're going to be a big part of that structure, that we're going to do all of this together as a team. But there are times when you don't rigidly adhere. Nothing is rigid in CBT. Everything is flexible in CBT, and it is tailored to the individual. So somebody comes in talking about homicide or suicide, forget all the rest of this, and you're addressing, that relevant need. Or somebody walks in and some really, important event has just happened. You might not worry about anything else and be focusing on that. But even if a really important event just happened, you might say, I know this really big deal is something we need to be talking about, but is there anything else? Because there might be something even more important than the one that they first brought up. Bibliotherapy can be very beneficial in socializing people to the model, but I would never give bibliotherapy in lieu of what you're giving to them. Bibliotherapy is meant to reiterate and enhance and refer to. It's not meant to replace what we do in session. So then they can use bibliotherapy to remind themselves of the material that you're talking about. Also, we have to tell people that they are going to be encouraged to be part of this process. And ideally, it would be really awesome if you could take notes and be willing to. There are a lot of people that don't. It doesn't mean that you can't do therapy. You know, I don't do writing. Okay, you don't say, okay, well then we're not going to be able to work together. We're going to talk about the alternative things that we can do when people are not receptive to writing. There are a lot of clients that maybe you've been seeing, and you want to deliver a more formal version of CBT. So therapy might look a little different than it's been. It's not like one day you show up and you just start delivering more formal CBT. You got to warn them. You know, I know we've been doing things in a little bit of an unstructured way, and I'd like to impose some structure into what we're doing. We're going to do more problem-focused treatment so that we can really get down to work and really try to make some changes for you. And as a result, we're going to figure out at the very start of the session what problem or problems we want to focus on and see if we can't stay on task. You know, it may be that if you've had a client that typically talks for a long period of time and really just wants you to listen, that you might say, I know I've done a lot of listening in here, but because we're really trying to be problem focused, I want to warn you that I might be more directive of where the conversation is going than I've typically been. And I want to ask your permission right now to interrupt you and know that I'm not trying to be disrespectful, but I'm really trying to guide us towards what would be the most helpful course of treatment for your well-being. And that, you know, you're going to play an active role in this. So we do move from being solely a supportive role to being able to provide more specific intervention. Again, the check-in is an opportunity, as just to reiterate over and over again, it's the only way to determine clients' mood state, but it is also an opportunity to build relationship, observe mental status things, and obviously a check-in, hey, anything go on this week that we need to be talking about? It is an opportunity to find out if there's any important things that we need to be talking about. And then we get to setting the specific agenda. Again, a short list of topics that ideally are problem-focused, but that's not always possible. You know, I'm really upset with what's going on in my family. We don't really know what the problem is, and we may not know what the problem is until we have a 10-minute discussion about it, because they might not even know what the problem is. So know that, again, ideally, we've defined the problem before we start talking about it, but I would say there's plenty of times where we know the topic, we don't really know what the problem is until we get to it. Now, being collaborative doesn't mean that you ask your client, you know, what should we talk about today? Because most clients, especially early on in therapy, say, I don't know, what should we be talking about? That the burden is always on us to do the work when they can't. Now, engaging them in that process says, you know, here's what we could do. What do you think? It means getting their buy-in. Or here's the things that we said, here's the problems and the goals that we said we're working on. And you told me the other day that the most important problem was this. Is this still what we want to be talking about? Or has another problem come up that's even more important? So it's getting them to be part of that process. And hopefully both of you are going to be contributing. It's not like the therapist just decides the agenda, or the client. It's not like the client solely determines the agenda. I'm in charge of the treatment. I'm guiding the work that we're going to do. So if we're going to continue to address your anxiety, then I'm going to be the one shaping what's the next step. So again, we're partners in deciding. And the reality is that, you know, the more items on the agenda, it's less likely that you're going to get to them. So that's why prioritizing the agenda says, if we can only get to a few of these, which ones do we want to make sure we get to? But if there's 4 or 5 items on the agenda, and the client says, please, I need to get to each of these, well, then it's on us to pace the therapy session to make sure that we can get to every one of those items. It might mean that we're not going to have the breadth of conversation that we would like to have, but if we're adhering to their wishes, we're going to do that. Now, sometimes we set a really nice agenda, and as we start talking, there's something that wasn't even on our agenda that seems to be a really important thing for us to be talking about. That's fine. But say it. Don't just quietly start working on this other thing. Say, look, you and I thought that today we were going to be focusing on these 3 things, and here we are, we're talking about this instead. But it seems to me this is really important and something you really want to talk about. Should we put everything else on hold and make this the focus of our conversation today? Okay, that's good agenda setting. You collaboratively decided to throw out what you originally agreed to. There's no problem with that. But if you ignore what you previously agreed to, how do you know that they wouldn't rather be talking about that? How do you know that you might not be spending all this time talking about exactly what they didn't want to talk about? You've got to be above board. You've got to put it right out there. And again, just because something comes up at check-in doesn't mean it's the most pressing issue. And we're going to watch a videotape tomorrow where Dr. Beck's daughter, Judy, interviews a client where exactly that's what happens. So I guess we could do a 2-minute little agenda setting kind of demonstration here so you get a sense of how quickly you can move to an agenda. So I need someone to just be a client. Again, do I have someone that's willing to be their client? Great. Okay. So your name? Brenda. Hi, Brenda. Hi. So, just checking in today to see how you're doing. Remember that mood scale from 0 to 10. 0, you're in bad shape, and 10, you're looking really good. Where's your mood been this week?
About a 5.
About a 5. And did anything happen this week that you think we need to make sure we're talking about?
Well, I have a job interview, and I'm really anxious about that.
So is that something you'd like us to focus on today?
I'm really worried about whether or not I can go back to work.
So your concerns about going back to work, and now that you've had this interview, it may really be right there in front of us.
Exactly.
Yeah. And I know last week that we had talked a little bit about some things you might do to prepare yourself for that interview. Were you able to do any of those things?
Yeah, I did visualize the interview going very well and did some positive self-talk to myself, and I did make it through the first interview. But now the second interview is going to be in a group format.
But that's awesome. So the tools that we talked about actually were helpful.
They were.
And you use them. Way to go. Way to be your own cognitive behavioral therapist. That's awesome. So let's see if we can bring those same tools to this group interview that's coming up. So it sounds like that makes sense to be on our agenda as well. Okay. Is there anything else you think we need to add to the equation?
My mother might be coming to live with me, but I think we should deal with the job interview first.
Okay. All right. So we'll put the mom might be coming as lingering in the background, fueling a little bit more fire, but we're gonna focus on the job interview, and particularly what happens, the concern about even if I get the job, will I be able to do it? So what's more pressing right now, that we start with the job interview, or what happens if I get the job?
Probably what if I get the job, because that's going to kind of probably color how I feel and think when I go into the interview.
Great. Let's start right there. Okay? So notice how quickly, it wasn't a whole extended conversation, right down to business. Now, I would say that this in-session summaries are one of the most important things that we do in therapy, because it's what keeps us honest. It says, what is this client gaining from this conversation? Are we just here shooting the breeze? Are we just providing support, or are we actually getting work done? That's what the summary tells us. So, a summary is a summary of content. It's not a summary of process. What did we talk about today? Well, we talked about my dad and my brother. Does that tell us anything? Content means, what about talking about your brother did we learn? Was it helpful to talk about your brother? What was helpful? You know, I love it when you ask for feedback and a client says, this was really helpful. But what was helpful about it? Well, it was just really nice talking to somebody. In fact, you're the only one I've ever told this stuff to. Well, that speaks to a really good relationship going on, right? That's lots of good interpersonal effectiveness, but that doesn't say we actually accomplished any work. And if the only thing you got from this was that you had somebody to talk to, that suggests to me that you didn't get very much from this conversation. So we're really looking to see, what knowledge did you gain from this conversation that gave you an alternative perspective, or reduced your distress, or gave you a skill that you didn't already had, or gave you a new perspective on things? So we asked the client directly. We first, and you'll have to excuse that, and a lot of my slides say patient, that even though I make an effort to say client, that I do use those words. Don't forget that I taught in a hospital system for 20-some years where it was patients, not clients. I work in a family practice office where the lingo is patient and not client. And at the Beck Institute, by the way, because Beck was a psychiatrist, certainly at the Center for Cognitive Therapy, we were part of the Department of Psychiatry of the Hospital of the University of Pennsylvania. We had patients sign in, not clients sign in. So don't have any buttons pushed because of that example. So we first asked the client for the summary. What did you gain from this conversation? What's the most important thing you learned from this conversation? What's the take-home message? How are you thinking about differently? And ideally, they tell us. And we go, wow, you took away more than I even thought that we were talking about in this session. That's awesome. And you know what? That is so important. How about if we write down what you just said so you could rehearse that over this week? Or how about if I make a recording of what you just said so that you could listen to what you said? I recorded it on my phone. I'll send it to you as a text, and you can listen to it yourself all week, reminding yourself of these conclusions. Okay? But often the client doesn't give us the conclusion that we're looking for. They either say, I don't really know, or they say something that maybe had to do with one little 2-minute conversation we had, not the other 30 minutes. So instead, the second path is that we could try guiding them to a summary. Remember, we talked about your dad. And remember, we talked about the fact that dad does what? What are the kinds of things dad does? Right, dad provides you a home, and dad is all about making sure you have, good food to eat, and that you have, that you always have a new dress for whatever event you have to go to. And what do we decide? Dad does that because why? Because he thinks that's what good dads do, right? And when dad does that, is it because he cares about you or he doesn't care about you? Yeah, it's because he cares about you. Is it his way of showing you that he loves you? I guess it is his way of showing me that he loves you. And remember, why were we talking about dad? Because dad doesn't deliver love to you in the way that you would like to be loved, right? So what do we conclude? What did we conclude? And maybe she's able to say, well, even though dad doesn't give me love in the way that I would like to receive it, in the way that he knows how, I guess he's given me some love. Okay, so we guided her to be able to say it. Option 3, failing to get that answer, we might have to tell them. What I'm hoping that you were going to gain from this conversation, or what I think is the most important takeaway from everything we've been saying, is, so notice the burden always falls back on us. You know, we try to get it from the client, we try to guide it from the client, and when we can't get it, the burden is on us to deliver. So you better know what you have gained from that conversation with the client. And if you're not sure, then think out loud. You know, do the summary out loud and you'll get there. Now, summary can be skill acquisition. So what did we learn today? We learned that just because you think it doesn't make it true. Or we learned that if you can learn to evaluate your own thinking, you might have a way to help yourself feel better. So what do you exactly need to do to evaluate your own thinking? Well, you told me every time I notice a strong feeling, I should take note of it and ask myself, what am I thinking? And then maybe jot down what I did as a response. So that skill building is the review. Sure.
What if you as the therapist feel that you went down the wrong path too soon?
Well, I would say, first of all, you don't know until you ask. So I would say, you know, I suspect that I may have pushed you further today than you were ready to go. What do you think about that? I would say any hypothesis you have, as long as you don't impose it on the person, you present it as a hypothesis, that's reasonable. Or you might take a less sort of a softer sense and say, you know, I know we talked about some really hard stuff today, and I know it was really difficult for you. How you doing? Are you okay with it? Are you leaving here intact? Right, you can check in. And then, because the second part of summarizing is getting that feedback. Yes, feedback is not just about the learning, even though I say that's the more important points. You know, what are you walking away with? What are the immersive points? But also feedback is, did I rub you the wrong way? How you feeling? Was this good for you? You know, kind of a thing. So you really want that feedback. And I think in that feedback, although they may have learned something, they may have said, this was a terrible experience, or this was a horrifying experience, or this was painfully unpleasant.
So one of the things we heard earlier, maybe this morning, the term argumentative. And I'm wondering if that can backfire at times. I mean, sometimes it'll feel right because you get the feedback immediately. And other times you might feel like you stepped too far.
Again, you know, that's their automatic thoughts coming from your own head. I'm going to step too far. I'm going to make the person uncomfortable. I'm going to push them to a place they weren't ready to go. And, you know, that's saying that you have power over other people. I don't know that you're that powerful. So if they cooperated and if they participated, recognize that they made that choice. Now, you might have been encouraging them, but they made that choice. And you're encouraging them because from your professional perspective, talking about what you're talking about and doing the work that you're doing is because you believe that's in their best interest. Look, sometimes we overwhelm people. We give them more homework that is reasonable, or we ask them to do something that was too hard on the hierarchy. I think it's valid to apologize and say, you know what, you're right. I think I did ask you to do something that you weren't quite prepared to handle just yet. And, you know, that's why I really need you to step up and tell me when I've pushed too hard or I'm off track. That's why we're a team. And I'm really sorry that I did that. You know, in hindsight, I think that I really get why that probably was an unreasonable assignment. So when we review the homework, which, by the way, what is the point of giving homework if we don't review the homework? We have to ask, what was learned? How could it have been done differently? What's the next logical step? Does it make sense to be doing this? Now, we also have to know that why do we give homework? Well, you know, pragmatically, Clearly it makes sense. If you're going to build a skill, you got to practice it. You're never going to get good at anything if you don't use it. It's not going to be able to help you if you don't use it. It extends the therapy so that we don't have to see each other 24 hours a day, 7 days a week. And clearly there is now empirical science substantiating the validity of homework. Rob DeRubis has done studies at Penn where the better the quality of homework, the better the prognosis. Andy Butler's research that shows us just assigning homework is correlated with better prognosis. Robin Jarrett's research out of Texas, the importance of doing homework. So we know that the data says that clients that get better do their homework. The reality is not that you can't get better without doing homework, but you're probably going to get better quicker and stay better longer if you participate in your own care. Now, what happens though? Well, first of all, I should say before we get in trouble, what's going to maximize the homework happening? One is that it's collaboratively. Collaboratively doesn't mean what do you think you should be doing, which you could. If they're really autonomous people, they like power. What do you think it makes sense for you to do this week? Ask them, they'll have an opinion. More dependent people will do whatever you tell them to do. But regardless, you want to make sure that there is a very clear rationale. That's what collaboration means, that you have come up with reasons why it makes sense for you to be doing what you've asked them to do. And then you make sure that they know how to do it, which is why typically we do the homework in session together before we ask them to do it outside of session, so they completely understand what they're being asked to do, or we imagine it in imagery, or we do a role play, or we do an exercise to be prepared to do that homework outside of session. And then most importantly, we ask them, how likely are you to do it? I'll try. I'll try means it's not happening, 50-50. No. When you send them out to do something, you want them to say, I'm going to do it. I plan to do it. If I don't plan to do it, then change the homework assignment. Well, let's figure out something that you can plan on doing. Because if they're not planning to do it when they leave your office, they're certainly not going to plan to do it when they're outside of your office. Even when they plan to do it, it doesn't mean it's going to happen. So we have to make sure. And then when they come back in and they haven't done it, what are you going to do? Well, you're going to first time around ask, well, what prevented you from doing it? And maybe a very legitimate practical obstacle happened. It's understandable you didn't do your homework. My goodness, every minute of your day till the very last second was encompassed with excessive responsibility. Who knows? On the other hand, maybe I didn't do it because I'm hopeless and I thought it wasn't going to work. Well, I'm going to have to address the hopelessness before I'm going to get you to cooperate in your homework, which means we're going to have to do more of the work in session before you're ready to do it out of session. Maybe it's homework that I would like you to do, but you haven't bought in. So every week they come in, they haven't done it. Are you going to spend every session talking about why they haven't done it? No, again, you're going to change the homework to one that they're actually going to participate in and be willing to do. If it is a homework that is essential to their recovery, then you're going to have to talk about how avoidance is doing a disservice to them and the pluses and minuses of avoidance so that you can get buy-in for them to participate in the homework that you say is going to be essential to their recovery. Homework, by the way, is the most flexible concept. In CBT, what's homework? Anything. It can be brushing your teeth. It can be something as much as getting dressed, or it could be something as complicated as filling out a complex thought record, documenting all of your thoughts and all of your reframes.
One of the simplest homeworks that I give, which could be very powerful, is just asking people to notice how many times something positive happens.
Exactly, paying attention, because depressed patients ignore the positive. So a homework assignment that says, hey, pay attention to the positive can be therapeutic in itself. Yep. So Judy Beck uses a form that I present this just as an optional thing. It is another way to get clients engaged and participating in the process because it cues them in as to what their responsibility as a participant in this process is. They can fill it out at home before they come to therapy. They can fill it out in the waiting room, or they could fill it out right in front of you. And I think this is particularly helpful for the disengaged client that you really want them participating. So, what do I want to work on today? How have I been feeling this week compared to other weeks? What happened this week that my therapist should know about? What did we cover during the last session? Is there anything that bothered me? Is there anything I'm reluctant to tell my therapist? What did I do for homework? So again, it just cues them up with some questions. You don't have to ask these specific questions. You could ask some of these questions, but it just gets them engaged in the process. I'm going to talk a little bit right now about the cognitive therapy rating scale. The cognitive therapy rating scale is the instrument that is the gold standard in assessing fidelity and proficiency to the model. So it is both a competency scale and a fidelity scale, meaning it is the tool that we use to determine whether or not you are proficient in the delivery of CBT. The AMA, in their psychiatric residency training programs, mandates that all psychiatrists be proficient in evidence-based treatment. They use this scale to determine proficiency. At the Academy of Cognitive Therapy, it is the scale that we use to determine proficiency. In outcome trials, when we randomly select sessions in an outcome trial, we're looking for fidelity to the model. And so that we are looking to see that the CBT arm is actually delivering CBT. So the cognitive therapy rating scale also can be used as a training tool because essentially it says this is what you are looking to deliver to make this a solid CBT session. And in my opinion, if all of us as supervisors of ourselves understand where we're not delivering, where we're falling short, where we're doing a good job, then you are going to be able to grow your skill even if you don't have a supervisor watching over you, because this scale is going to be your supervisor. This scale is going to be your roadmap for am I doing what I need to be doing? And that's why I would like to grow all of your proficiency in understanding this scale and using this scale so that you can evaluate your own work to decide if you're actually delivering CBT. Some of you in the room have suggested that you would like to apply to the Academy for certification as a CBT provider. We will be asking you to submit an audio, not a video, an audio sample of one of your cases. This scale was not designed to be used on an intake, nor a first session where you're developing a problem list. It was intended to evaluate intervention. So that is why typically it's sessions 2 forward. It is not intended to be used on a termination session or on a booster session. So it is intended to be used to evaluate therapeutic intervention. And by the way, at the Academy, we can accept work samples in other languages other than English. In fact, we have many different raters that can rate samples in Cantonese and Mandarin and Farsi and Spanish and Korean and Japanese and all sorts of dialects, Portuguese. So we have many raters that represent many different languages. And if you have a session with a client that you would like to submit and we don't have a rater that speaks that language, we can rate your work sample as a translated transcript. And that way you can bring to the table any language that you are conversing in with your clients.
Could you give a few examples of the items that are asked?
Yep, we're gonna go in detail of the cognitive therapy rating scale. So there's psychometrics on this scale. They're not perfect. It's a good scale. It's not a perfect scale. The bar on this scale has been set at 40. So it is an 11-item scale: agenda, feedback, understanding, interpersonal effectiveness, collaboration, pacing, guided discovery, key cognition, strategy for change, application of technique, and homework. 11 items. On every item, you can get a score anywhere from 0 to 6. So 0, 1, 2, 3, 4, 5, 6. A perfect score would be a 66. I have never seen a 66. I have never observed a session that would score a 66, and that's because some of these items may be challenging to rate and may not be readily available to be able to take place in a session. So let's talk more about that. Now, I'm going to go through the scale, and I'm going to talk about some of the anchor points. If you really want a comprehensive understanding of this scale, I would encourage you to read the Cognitive Therapy Rating Scale Manual. If you go to the Academy website, academyofct.org, and right now on the main page, on the drop-down menu, it says for professionals. You can go to the drop-down menu, and there will be an example of the Cognitive Therapy Rating Scale, and there will be the Cognitive Therapy Rating Scale Manual. By the way, in many languages other than English. So you have to scroll down through the Swedish version and the Turkish version until you get to the English version of this scale. Those of you that are invested in being certified by the Academy, it would be in your best interest to take a look at this Cognitive Therapy Rating Scale Manual and eventually read it in its entirety. Tonight, I would encourage all of you to take a peek of this and maybe at least take a look at 1 or 2 items like agenda setting or feedback. And because we're going to be rating work samples together over the next couple of days. So as you become more proficient in recognizing whether or not CBT is taking place in the samples we're looking at, you're going to be more proficient at looking at your own work. So the first item on the Cognitive Therapy Rating Scale is agenda setting. And what this says is, did we figure out what we were going to be talking about, or did we have a vague, unstructured conversation? A 4 on any of these items is the baseline for acceptable, solid, good therapy. A 44 is somebody that can come work in my office and see all of my clients. A 44 is somebody that we would put in any CBT trial. A 44 is somebody that is delivering competent, solid, good CBT. But again, the bar is set at 40. And the bar is set at 40, which means that you can flunk one item and still get a passing score, because the scale is designed that every item is independent of every other item. So you don't want to be biased. Each item is rated separately, and the bar on every item is the bar of 4. Also, the scale was designed to rate a session in its entirety. There's actually some data that you can take out a section of the scale and grade it, and it will correlate with the overall score. But the way the scale was designed, that you listen to it from start to finish, and then you score the items. Because the items, it is not an adherence scale. It is a proficiency scale, which means that just because it shows up doesn't mean it's good enough. So because it is a proficiency scale, it says that it needs to be prevalent. So for the most part, whatever the items are we're looking at, we see them throughout the session, not just that they show up, right? Adherence would be it showed up, check, you get it. This is it showed up and it was sustained throughout the whole session. So not we were agenda focused for 10 minutes. We were agenda focused throughout the entire conversation. Now, a 6, or even a 5 would be that we were agenda focused, we prioritized, it was collaboratively set, and we actually did the work on what we said we're going to work on. And it rarely gets to a point where we're able to do that. Often we don't exactly follow the agenda, or it takes us a while to get there, or we lose a little bit of sight of it. Again, therapeutic judgment rules, regardless of what you're trying to deliver. If you have a suicidal client, your therapeutic judgment rules. There are times when you need to be flexible. For instance, I was working with a 17-year-old young woman who had very few friends, if any. Her friends were people on the internet, personally, that probably were a little bit problematic and maybe not really appropriate people for her to be conversing with on the internet. And she was a cutter. And she was slashed up from head to toe. Her parents were divorced, and both of them said, if you keep cutting, we don't want you. The reality is neither of them wanted responsibility for her. So they were like actually hoping that she would cut because it was a good excuse. Neither of them had to live with her because she was a little bit challenging to live with. So she comes into my office. So she's isolated and separated and connecting with all kinds of strangers on the internet. And I'm a little bit concerned about this. And what do you think my goal for her? My goal is for her to actually connect with real human beings in her real life and to have resources outside of her family which really aren't a resource to her. So she comes in to see me one day and she says, oh, I heard this great song on the radio and I have it right here on my phone. Can I play it for you? Okay, so what do you think I say? Yes, sure, great. We haven't set an agenda. We haven't checked on our mood. Forget all of that. Play the song. So she plays the song, and genuinely, I like it. You know, I feel it. I say, oh my goodness, I feel this song. I like this song. And then I get up and I like any excuse to dance. And I'm like, okay, ooh, are you feeling this? Come on. And the two of us are up, we're dancing. And we're like, yeah, that was fun. We sit back down. And I say, oh, that was so much fun. Was that fun for you? She's like, yeah, that was really fun. Did you like sharing your music with another person? Did you like dancing with another person? You know, and then we're talking, did you like talking about it with another person? What do you think? Maybe it's time that we bring some real people into your life? How about if we talk today about just that? Right? So, hey, you know, this took like 15 minutes of our session we spent grooving to music. And yet it opened the door. And then we checked on our mood and we put this on our agenda and we got to work. So be flexible. Yep.
You keep saying check on the mood, check on the mood. Is that like every time they come in you have to use the assessment tool or you just ask?
Either. So either you can check on the mood with a formal inventory, like the Beck inventory, the Zung, the Hamilton, whatever, the Burns, whatever inventory, or I'm okay with on a Likert scale, checking in on a specific mood. Again, it can be overall mood, or it could be depression, anxiety, hopelessness, whatever you're assessing. So remember that although the anchors are 0, 2, 4, and 6, you can score 1, 3, and 5. You cannot get half points. You can't be a 3.5. Because it is a proficiency scale and not adherence, if it's a 5.9, that's a 5, right? 3.6. That's a 3. You don't round up. If you haven't met the criteria, you haven't met the criteria. You may be a 3 plus. You're approaching CBT. You clearly understand the principles. You're putting them into practice, but you haven't hit the bar of the 4. So if you're not there, you're not there. We're very rigid about that 4 mark. You got me there. So feedback, again, it's called feedback. I added that summary in parentheses because to remind you that we're checking in to see if they're understanding what's going on. We're doing those capsule summaries that say, what are they gaining from this conversation? And we're asking for feedback. Be careful with feedback. Often a client gives you feedback unsolicited. This was really helpful. Thank you so much. Wow. And then you don't say after someone said, you know, this was really helpful, do you have any feedback for me? Because they just gave you the feedback. So be careful. This is not like a rote thing that you do, like a robotic computer. You know, this is a conversation between two people. You got to be paying attention. Understanding. Understanding says that we understand you through the lens of the cognitive model. So I have asked questions that allow me to collect your situation-specific thoughts, your assumptions, your belief, and your compensatory strategies. Now, it may be in a given session that this hasn't come out. It just wasn't appropriate, or there wasn't an opportunity, or they were avoidant. So you may not have a good understanding of that particular client, not because you don't have the skill, but because the opportunity didn't fully present itself. So that's why, it's hard to get a perfect score, because variables keep messing you up. But for the most part, this says, I'm taking notes. I'm verbatim saying what they're saying. I'm not paraphrasing. I'm not saying what they said different than what they said it. And especially if the client says, that's not what I said, that's not quite right, that's poor understanding. Because we want to get it exactly right. And it's good understanding when the client says that's not quite right, and you say, well, help me get it exactly right. Right? That's good understanding. But if you ignore them when they say that's not quite right, then that's poor understanding. Interpersonal effectiveness is not a very reliable item, especially now that we use an audio instead of a videotape. We miss out on all those nonverbal signals. It's a little hard to grade this without seeing, are they making eye contact? Is the person fidgeting around? Are they not paying attention? We don't know. So we tend to give the benefit of the doubt. But it's clearly easy to see the extremes. The client says, you are the only person in the planet I ever told this to. To me, that's a 6 on interpersonal effectiveness. Wow, they told you your deepest secret? That's a 6. When the client...
I do have a question about that, because I had a client do that, and then he revealed something, I'm not going to say, but he said, he says that's the only thing I've never told anyone this before. Sometime when he did that, when he thought about it when he left last night, it also could it be a form of manipulation to see if I'm really going to hold on to it, and it never really, you know what I mean?
Right. Well, it could be an experiment on their part. It could be a good sign of interpersonal effectiveness, or it could be that I'm testing you. I want to tell you the most outlandish, crazy thing and see if you fire me as a client, or see if you judge me, or see if you're going to think about me differently. So, that's possible. We can't assume that, but anything's possible. And if we hypothesize that something's going on and we have reason to think so, again, share it with the client. Check it out. Now, on the other hand, when the person is fighting with the therapist and, there seems to be a battle going on, like we talked about, then that would clearly be a sign of poor interpersonal effectiveness. If you're not showing accurate empathy, the client is hopelessly depressed and you're like giggling during the session, that would be bizarre. On the other hand, you might tell a joke, even if a person is horribly depressed. Supervisee asked me once, can I tell a joke? And I said, well, do you normally tell jokes? He's like, no. I'm like, well, then don't tell a joke, because that's not genuine and true to who you are. But if you see the humor in things, then you might be able to get away with it. It depends on the client. My most severely depressed client I ever worked with never lost her sense of humor. She was telling me jokes. She was 1 week out of a major suicide attempt, and she's telling me jokes. That's just how she operated. Now, I don't know how to tell jokes, so I don't even really understand jokes. So I couldn't give her a joke back. I probably didn't even laugh when I was supposed to laugh. But if I had known how to tell a joke, I have a father that can tell a joke. He thinks of jokes from like 50 years ago. No matter what you talk about, he can give you a relevant joke. And if I had that skill, she would have appreciated it. And I would have done that with her. And we would have had a little giggle together, even when she was in really bad shape. On the other hand, collaboration. Collaboration, by the way, says that we found our way to focusing on a problem that we both agreed was important. So good collaboration is, I didn't want to talk about my sobriety, but my therapist convinced me that it made sense for me to talk about my sobriety, and we wound up working on it. That's good collaboration. On the other hand, forcing a client to talk about their sobriety, even though they don't want to, before you got that buy-in, is poor collaboration, even though you're working on an appropriate problem. So collaboration also means that it is a team process, that throughout the session, you're checking in with them. Does this make sense? Is this what you want to do? Are we on the right track? Pacing. Pacing isn't we don't do 10 really good minutes of therapy and the rest of the time we're just sort of checking in. That's poor pacing. Poor pacing is when the client talks for 40 minutes and then you start to intervene. So you might say that we use the time effectively. We get to the work, we get to the agenda we said we're going to get to, and we spend enough time getting to a conclusion. We spend enough time that we can talk about the work that they're going to do between sessions. And we don't just send them out the door, oh, I forgot to give you homework. What do you think you could do this week, right? That's a poor pacing issue. Now, recognize that the pacing of the session is also going to have to be tailored for the individual. So the depressed client that's moving in slow motion, the pacing of therapy is going to have to be slower. An anxious client, the pacing of the session can be faster. You can get more done. You can move at a quicker pace. So it's appropriate to pace the session appropriately for the individual. Guided discovery, the most important principle in CBT. We, again, collect data and make meaning of it. Now, we use guided discovery at the front end and throughout the session, meaning that when we're collecting the conceptualization, it's guided discovery that helps us elicit all of this data. We're asking questions to elicit this information. We also use guided discovery, which we're going to focus a lot on tomorrow, on being able to do cognitive restructuring. It helps people consider alternative viewpoints. It doesn't tell people alternative viewpoints. And then we focus on the thoughts and the behaviors that are driving the distress. The key cognitions at a 4 level we're talking about what's distressing you. We're talking about the automatic thoughts that I will be alone for the rest of my life and no one wants me. And at a 6, we've also talked about your assumptions that if I don't get them, they'll get me, or the most wonderful woman in the world not wanting me, meaning that I'm unloved. And we talk about that underlying belief that says that I'm unloved. And is it really true that if this woman doesn't want me, does it really mean that I'm unloved? So we work at all of those levels. We have a strategy for change that has promise, that makes sense. That's, by the way, a cognitive behavioral strategy. That it, according to the data, it's a reasonable thing to do. For instance, in an obsessive-compulsive client with an OCD disorder, are you going to spend an entire session evaluating the validity of their intrusive obsessive thoughts? Definitely not. That would be contraindicated. You're going to teach them how to obsess more. So it is a matter of using the appropriate thing. In PTSD, are you going to encourage them to avoid the trauma narrative? Right? That would be contraindicated. So a strategy for change is, it makes sense, the literature supports it, and we actually do the strategy. That's it. So a 4, we have the strategy. A 6, we do the strategy that we say that we're going to do. And then we apply the skills in a reasonable way. We do a reasonable role play or a cost-benefit analysis or examine a thought. By the way, we might be examining the least important thought, but we do it expertly. We can get a 6, even though we're talking about all the wrong stuff. And then we have homework. Ideally, to get a 6, you talked about previous homework, let alone the new homework that we're going to do. So if there wasn't previous homework, technically you can't get that high of a score. Now, someone asked me during the break, do we call it homework? For the record, there are lots of us that try to find other language other than homework. What could we do this week to put these principles into practice? Or what could we do this week that might help you be able to cope more effectively? But, the reality is, no matter how you look at it, it is homework. So I think that, often people have very negative connotations. There are some people, I have a client that says, I love homework. That's the one thing I'm good at. Bring it on. So again, you have to sort of judge your client. If that word makes somebody cringe, then don't use that word. If it doesn't bother them, then feel free to use that word. Now, we're going to start to talk about applying the basic principles and talk about depression. So we're going to talk about the cognitive model of depression, we're going to link it to the conceptualization, and then we're going to start building basic skills of behavioral activation and cognitive restructuring that go beyond just the depressed client, but we're going to talk specifically how we do also use those particular skills with the depressed client per se. So the problem in thinking in depression, negative bias. Once a person is depressed, they grow a negative view of themselves, the world, and the future is what we call the negative triad of depression. A negatively biased view of oneself, one's world, and one's future. And a result of that view, what happens? We get a paralysis of will. I'm too tired. We feel depressed, our mood sinks. As we become more depressed, we tend to become more hopeless. The more hopeless we become, the more suicidal we become, because we believe there's no hope. There is no direct correlation between depression and suicidality. The variable that predicts suicidality is hopelessness. However, the reality is, as depression increases, hopelessness increases, your risk for suicidality increases. But you can be mildly depressed and acutely hopeless and actively suicidal. You can be severely depressed, not hopeless, and not suicidal at all.
I came across something once that indicated the Beck hopelessness scale was about the strongest predictor of successful suicides.
Yes, so the optimistic pessimism scale. Dr. Beck found that if anybody if they had a clinically significant score on that scale, that they were able to predict that those individuals, and if they got that score at any point during therapy, doesn't matter beginning, middle, end, doesn't matter. If they had a high hopelessness score at any point during the course of therapy, it was correlated with a suicide attempt. So hopelessness is very dangerous. Hopelessness is psychological frailty. And then what happens? We have a negative view of the world we start avoiding. Well, first of all, we stop going to work. We stop taking care of things. That fuels our negative view of ourselves. We can't do anything. We stop answering calls. We start accepting invitations. And so what happens? We think nobody cares. Well, how can they care? We don't let them in our life. So let's take that school teacher. Remember those early experiences of having a parent that told her that she wasn't good enough, and those siblings that did everything, and she basically said, I'm incompetent. And then she faces a critical situation, which activate automatic thoughts. The critical situation is she gets a good but not perfect review by her supervisor. Her classroom parent calls to complain about her, and her physical illness persists, and she thinks, I can't do anything right. Negative view of herself. I'll probably get fired. I'll probably never get better. Negative view of the future. No one can help me. No one understands me, which is very dangerous because I also believe I'm helpless. There I am, horribly, clinically depressed. So let's go back to our video from earlier today and watch Dr. Beck deal with the issue of depression in the client that we've been observing so far.
Gray outside, nobody's calling you, you're all alone. What are you going to be thinking then?
There's a real good chance I'll be depressed. Very good chance.
And you're going to be thinking thoughts like, I'm all alone, I'm always going to be alone, and nobody wants me.
Yes.
And what are you going to do about it then?
I've got to call somebody.
Okay, one thing is you can...
Notice how he constantly reiterates his exact thoughts and is preparing to deal with them outside of session. You might say often homework is subtle. We don't say this is what you're doing for homework, but that's what he's doing. He's giving him homework. He's giving him a tool to use when he's on his own and these thoughts are getting the best of him.
Call somebody up.
Yes.
And what will that, if you call somebody up and that person responds positively, what will that tell you?
It tells me that somebody cares for me.
That's right. Somebody cares for you. In other words, your belief is wrong. And has that happened, that sometimes you had this belief that nobody cares for you, you called somebody up and you got some positive feedback?
Yes.
So you've already demonstrated to yourself the belief is wrong.
Yes.
At times. But one demonstration doesn't do it. One swallow doesn't make a spring, right? You have to keep demonstrating it to yourself.
Yeah.
So the next time when you're home alone, Saturday afternoon, and you get this belief, you can test it out by calling up somebody. But suppose that person isn't home. What happens? You just go back lying in bed and...
Then I'm very hurt. Yes,
Yeah.
that's happened. I'm hurt. I'll try calling somebody else. And yes, this has happened. I'll call 3 or 4 people. None of them are home. They're all out. They're doing something. They're having a good time.
Yeah.
And I'm sitting at home by myself.
Yeah. And so you feel hurt, and what do you think? What thought makes you feel hurt?
I think that that person doesn't care because they're not home and they didn't call me that day.
That's right. First of all, they don't care because if they really cared, they'd be home waiting for your phone call.
Yes.
Right?
Yes.
And secondly, if they really, really cared, they would be on that phone calling you.
Yes.
Now, is there any other reason that they might not call you besides your explanation that they don't care? Is there an alternative explanation why a person might not call you?
They're busy with their life. And they, some of the people that I have communicated with over the last year or so feel that you can only support someone for so long, and then they have to do it on their own.
Or they have to take more initiative. But okay, now let's see, this may be helpful to you because your big problem is these gray Saturday afternoons when you're alone. So could we do a little bit of a role play, and let's imagine that I'm you, it's Saturday afternoon, and I'm kind of lounging in the bed and I'm having these thoughts, and then you tell me what my thoughts should be, or see if they're incorrect and how you might correct them, okay? Now here I am, home all alone. I don't know, nobody has called me all day. That's awful. That means nobody cares for me. How are you going to answer that?
People do care for you. You have lots of friends.
I do? Who are some of my friends? I can't think of any right now.
Don?
Oh?
Jim? The other Jim? Dennis? Steve? All the guys you play golf with.
So it's only Don, Jim, Dennis, Steve. That's not so many. Is that all?
No, we got 2 other guys that we play golf with regularly.
Yeah, what's their name?
Steve. They give you Steve, and there's another Dennis in there too. I know two Dennises, and I know 2 Dons, and I know 2 Jims.
Well, if they really cared for me, how come they aren't calling?
That's what I ask myself too.
You're supposed to.
Yes, I know.
So we'll go over that again. If they're not calling, is there any other explanation why they might not call?
They're busy with their own lives.
Right. Now, is that reasonable, that they're busy, they have lives of their own, and that if you want to become part of the lives, you have to take the initiative? Is that right?
That's what you should do, yes. You should take the initiative.
Okay. But I still don't know what to do. I'm lying right here and feel nobody loves me, nobody's ever going to love me, and maybe I'll go live in a cave and eat worms.
Why don't you put on a pair of jeans and a shirt, brush your teeth and comb your hair and take a shower and go down to El Torito?
What you're saying is that there are ways in which you could really counteract this negative thinking that you do. And you just showed an example of this right now. Now, do you think that it's possible, when this occasion comes up again, and it's bound to come up again, that you can reason with yourself just the way you've been reasoning with me?
Yes.
Okay, so that's part of what we call cognitive therapy, which is trying to modify people's erroneous views. What turns out is that the views that you have of yourself are erroneous. You do have a lot of friends. I thought from the way you were talking you didn't have a friend in the world. Now, I guess if we polled various people, we'd probably find that you have as many male.
Do you notice that Dr. Beck is constantly telling him his strategy? That's what we mean by cognitive behavioral therapy. That's what we do. You had an erroneous view. We're helping you to see a more accurate view. That's what you need to do yourself. So do you notice even in one session, he's training him for what he can do forever forward?
Friends is anybody. And you have good times, you play golf with them, and so on. Now, the other part of your problem, though, that seems to bother you is that at the present time, you don't have a woman in your life.
Yes.
And evidently, having a woman in your life is very important. To you, having a woman means what?
Having like a steady girlfriend, someone I don't have to call up and ask him out every week.
And when you have this woman in your life, what do you think it's going to do to you?
It will give me someone to hold and caress, which will make me feel better, because I want to express my love now.
Am I correct in saying that you seem to believe that having a woman, the way you describe that, means that you're going to be happy?
I think that is an initial step for me to be happy.
Yeah. So having a woman means happiness, and not having a woman means unhappiness. That seems to be a formula you operate on.
Yes.
Well, let's examine this and see if the history shows that. Now, when's the last time you had a woman in your life? During your marriage, I suppose.
My marriage, which was, Connie and I broke up, it had to be a year ago, about approximately a year ago. And since that time, when we first broke up or separated, I had an awful lot of dates. Lots of dates. Most of them were 1 or 2 dates. And I couldn't find a woman that I found attractive or I felt was socially on my same level.
Yeah. So you had a difficult transitional period. Now, how about before you split up with Connie? Well, just like the week before, the month before, were you feeling real happy then?
No, we were going through counseling that time, and about the last year of our marriage, year and a half, we were both pretty unhappy.
So at least we do know for at least a year and a half you had a woman in your life and you were unhappy. So having a woman in your life doesn't necessarily equal happiness. Now, let's go back in time and see, there were many years before you were married, and were there periods of time before you were married when you did not have a woman in your life?
Yes.
And how did you feel then?
I felt I was lonesome then.
Did you feel depressed then?
Yes. Yes.
And were there ever any periods when you were neither lonesome nor depressed prior to marriage?
Yes. Yes, they were.
So having a woman in your life isn't an absolute necessity in terms of being happy. We're not knocking it, right? We're just saying it's possible to be happy without having a woman in your life.
I can be a whole person myself.
Right.
Without a woman.
And being a whole person is really what you have to do. You can't be really dependent on somebody else to make you into a whole person. Let's think about that for a minute.
I understand what you're saying, and I feel I'm on the right track now, for the most part. I feel good about myself. I can be a good person. I am a good person without a woman, but I miss them.
Missing them is part of human nature, is to miss something that you want. But missing them isn't quite the same thing as feeling that they're so essential to your survival that you can't exist without being depressed in the absence of a woman. Now, what you just seem to tell me is you can be a whole person without having a woman. In fact, you might get there faster without the woman because you can learn to stand on your own feet.
Yes.
Right.
Yes.
So if one of your objectives is to be a whole person, to be independent, to be strong, to be mature, and so on, you might be able to get that without having to make a quick commitment to a woman.
I went, after I had all these series of dates, which I just didn't care for over a period of 6 months, and finally I just quit asking women out. I just wasn't interested in them anymore because I couldn't find what I was looking for. All of 1 month there, just went, so some period of time, all of a sudden I did feel good about myself. I felt good about myself, and I was satisfied sitting home. I wasn't depressed. I didn't have a lot of anxiety. I didn't feel the need to go out and grab the first chick off the street corner or something like that. I did feel good about myself for about a period of a month, maybe 2 months. And this was right before the holidays, which I was kind of proud about myself because I was devastated by the fact of going through the holidays without a female friend. I just didn't want to spend. So I did have a period of about 30 to 60 days there where I just really didn't need anybody at all. But now the last 30 days, the old depression feelings, the anxiety, the loneliness that nobody wants me is starting to creep back into me again.
So you're able to overcome that belief that you need a woman in order to exist in a happy way. You really had overcome it temporarily.
Yes.
But you no longer believed it, and indeed you were happy. Now, reasonably happy.
Yes.
Now, if you have the notion that in order to be happy I have to have a woman, what kind of a position does that put you in?
It makes me dependent on a woman.
Right, and it means that if you don't have a woman, that the formula is going to have its day, and you're going to be depressed.
Mm-hmm.
But if you could change the formula around to, it would be desirable and nice and enriching to have a woman, but I can be happy without a woman, then what does that do to you?
It makes me a complete person. And when I do meet the woman, eventually, someday, she will respect me more.
Right. And so you'll be more independent, in a sense, and you'll be in a more mature level. Now, it may be the case, though, that something's happened in the past month that made you slip, because sometimes that happens. Was there anything that's occurred during the past month that may have slid you back into this negative thinking?
No, I just miss the touch.
Uh-huh.
I want to touch their skin.
There wasn't anything? Was there any other relationship that you have?
I'm just going to fast forward it a little because we're running out of time.
And?
I didn't think you wanted all the names right
now. No. But this is just to instruct yourself.
Yes.
You've got to name names to yourself then, and what else do you have to say to yourself?
That people do like me. People do care about me. They don't want me to commit suicide.
Mm-hmm.
I have something to offer to society.
He says when he's home.
Okay. And so what you have to do is counteract the negative thinking.
And sometimes he thinks about suicide. And so they're talking about how he can combat that.
With reality, because none of the things you just told me are untrue. They're all true. About you have something to contribute. Now, the final thing you might just want to consider is that although Connie did take many things out of your life that were present before, she did not take the most essential thing away from you. She did not take you away from you.
Yes. A year from now, or 2 years from now, I don't know when the time will be, after this is all over, and I've got both feet back on the ground again, this will be a tremendously good experience for me.
Mm-hmm. I think it'll be a big spirit towards your maturation.
Yes.
Well, we've covered a lot of territory today. Do you have any questions on any of the things that we touched on?
No. I can see myself, convincing myself that when I'm so depressed, because I know what it's like to be depressed, and you're sitting there telling yourself, well, gee whiz, I'm really a good person, and gee, I have all these friends and everything, and I kind of have doubts about that.
Yeah, you mean how it's going to work?
How it's going to work, because every time I say something, gee whiz, you've got 14 guys you can call and shoot the bull with, but then I'll hit it back with something negative.
Yeah,
well,
and this is what I was trying to do. So I can't answer all of your negative things in such a short period of time, but I can teach you how to do it.
Yes.
And what you have to do is get a paper and pencil, probably even before this depressing Saturday comes on. You ought to put down some of these rebuttal statements that we've had just now, so you can take them out. And then when you get the counter rebuttals that'll come up, but if they really like me, why didn't they call, and so on, then you have to be prepared to use the same skill that you showed here today in answering your rebuttals. So work on that and see how it progresses. Well, I'd still be interested in one thing before we finish for today. How did you feel about what we covered today?
I feel very good about it, because I really have not been trying to combat the situation when I get depressed. I just kind of lay around the house, watch TV, have a beer, Coke, kind of lay around, wait till I get sleepy, and then go to bed.
Yeah.
And hopefully when I wake up the next morning, I'll feel better.
Sure. Well, how do you feel now? At the beginning of the interview, you said you were feeling very queasy and anxious.
Yes.
Which may have been related to the interview itself, but you also did look rather sad. How do you feel right now?
I feel good about myself, and I feel that we could continue this conversation for another hour if we wanted to.
Great. Good. Well, thank you for coming in to see me.
All right,
it's been
thank
a pleasure.
you. Okay.
Well.
Okay.
Yep. Okay.
So my question is, just watching that scene and looking at the way the setup, the stage,
Yes.
Does it have to be that to show seriousness, or can it be in a more relaxed environment? Is there a reason? Because it seemed like...
Yeah, no, it's a very formal interview. Don't let that bias you, and I'm going to show you another very different sample tomorrow. I'm showing you this, not that this is a typical demonstration. I'm showing you because Dr. Beck demonstrated the principles that we've been talking about today in an eloquent fashion in a very formal way. But guess what? This client was very formal. This client came in wearing a suit, sitting upright, and I think Dr. Beck was just showing accurate empathy. He was very formal in return. Dr. Beck is more relaxed when the client is more relaxed, more formal when the client is more formal. And we know that in our practices, that, my adolescent clients want me to dress more casual. My corporate clients would rather me dress more, professional. So it's really a matter of that accurate empathy that's trying to be demonstrated. And in fact, although you might say there wasn't a lot of emotion going on there, but, would you say that the two of those interpersonally connected? I would say yes. I could spend the rest of the day with you. He took an anxious person that was really uncomfortable about being there and made him feel like he could spend the rest of the day with him. That's interpersonal effectiveness. Now, if we look at the items on that cognitive therapy rating scale, did he find his way to an agenda? Well, they said, okay, we're going to talk about depression, but they didn't say, do you also want to work on that anxiety? What's that anxiety connected to? Is there anything else? They zoomed right on in the depression and got to work on that. So that's a 4. Feedback. All throughout the session, he got feedback from the client. Do you think you could do this? What do you think about this? Was this helpful? They did those capsule summaries. Here's what we did. Right? Didn't they reiterate it? This was probably one of the most attractive demonstrations of doing summaries and getting feedback. Did Dr. Beck understand this client? Absolutely, comprehensively. Were they collaborative? Did they define a problem? Did they work on it? They did. They defined the problem and they worked on it, and they worked on it the whole time. What kind of score do you want to give them? However, when the client brought up suicidality, which I sort of fast forwarded. They did that in fast forward. So you might say that they maybe didn't give that the full attention that maybe it warranted. And that was a pacing issue, if you ask me. So we might want to mark them down a little bit there, and we might actually want to give them a little bit of a negative score on pacing for a couple of reasons. One is that suicidal ideation came up. Here's the reframe you can give, but he didn't say, are you actually have any means? Do you have any intent? Like, they really did gloss over that, and I'd say that was a pacing issue. Did he address the key cognitions and behaviors that were driving the distress? But he didn't really work at the deeper level, at the assumption. He didn't work up at that assumptional level or on his core beliefs, did he? He never, I'd say that he stuck right at the situation specific, and maybe appropriately. This is a one and done. They're not doing belief work in a one and done session. Why do I have collaboration twice? What am I missing?
Twice.
Yes, I have collaboration twice, but I'm missing, it's not like me to miss something. I am missing, I'm missing guided discovery. How could I be missing the most important thing? Okay, so did he use guided discovery? Yes, he used guided discovery, but I would say he did a little bit of shorthand. Did he make as compelling of a case as he could? He certainly used guided discovery to understand the client. He used guided discovery to do thought restructuring. For the most part, absolutely. It was a little bit paced a little bit quickly, so I'd give him a 5 there. Did he have a strategy? And did he share the strategy with the client? Absolutely. Did he show the skills in an expert fashion? Absolutely. And did he give him some homework? Yeah, but a 4. They didn't really flesh that out, but for the most part. So if we add that up, let's just add that up. 48, 49, 50, 51, 50, 51, 52, 53, 4, 55. 55?
We only have 1 3. The rest 4s or 6s, so we pass.
So 55? What'd you get? 55? Yep. So a 40 was passing. We're well beyond. And you know what? When we score at a 40, we're good CBT. But when we score at a 50, we're even more attractive CBT. And we're scoring at a 6, we're at the highest level of excellence. When we're at a 55, we're at the highest level of excellence. So, but it's not a perfect session. It's a really attractive session, but not attractive, not perfect. And the scale itself has about a 3-point error, so that 55 could have been a 58. So it's not a perfect instrument. There was a question. Yeah.
Where I struggle often is the difference between automatic thought and core beliefs. So what would you say was a core belief?
So the core belief is I'm an unlovable jerk. The automatic thoughts are I'll never find anyone, I'll always be alone. Yeah. Yep.
I struggled with when he gave the hint that he hadn't brushed his teeth, or he hadn't whatever, all of that sort of day-to-day. I struggled with him, with Dr. Beck not having that as, a simple
thing that he could have said, would have been an advantage to making that happen. Sure.
And just besides
Yeah.
the key to call or to say, why didn't they call? I just felt like some concrete thing to get him out of the house. Basically, I wanted him out of the house.
Would be reasonable to help him get mobilized, but they didn't really work on behaviorally activating him, but they could have. I think that would be a reasonable thing. Again, just because Dr. Beck chose one strategy doesn't mean it's the only strategy. It doesn't mean you couldn't enhance that strategy. Now, so that's why I encourage you to look at that cognitive therapy rating scale manual tonight, because we're going to look at the work samples through this lens so that you can look at your own work through this lens. And, sometimes what people find is, I'm doing CBT. I gave myself a low score. How many want to give yourself a little higher score at the end of the day than you gave yourself this morning? Yeah, I've got some hands going up. So that's often what happens. It validates that actually I am using this model, maybe not as formally as Leslie's talking about, but certainly I'm applying these principles, and maybe I'm doing more CBT than I'm giving myself credit for. And if there's something that you were going to take away from today's training that you think was particularly valuable for you, is there anything particular that you're taking away from today's training? Yep. Absolutely. Yep.
You asked the question?
Yep.
So for me, I would say agenda really stood out for me, because sometimes, when you're in session and your client comes in and you're so zealous to give the right services, they kind of dictate what's going on. And with an agenda, it's good to have, set goals.
Exactly.
If you have a goal, you really don't achieve it.
Exactly.
So for me, that has stood out.
Absolutely. Having a problem-focused agenda, a plan, addressing the work that we say we're going to address so that we walk out of here accomplishing something. I love it. That is exactly what I was hoping you were going to say. Anybody else? Yep.
In addition to that, a summary.
Yep.
That seems like something I would like to focus on.
Yep. Because summary guarantees that they're taking something away from this conversation.
The automatic thought is really hit it hard when I first saw it, and all the way through. It seems to be the driver of everybody's.
Yep, the automatic thoughts drive the situation-specific distress, and evaluating them and reframing them produces symptomatic relief.
I have a question. Did anybody else see the discrepancy between the client's affect and his words?
Yeah.
He seemed
Yeah, but part of that reining in and maintaining control, and I think Dr. Beck chose not to go down that path because it's a one-and-done conversation and maybe didn't want to open up. And I think that you're picking up on something that down the road absolutely would need to be addressed. But you are exactly picking up on exactly what I was doing. You notice the structure of CBT is the structure of even our training today. What do? We checked in on a mood check. How confident were you feeling on yourself? We talked about my goals and your goals for what we're going to be doing in this training. We did the work. We summarized the work. We got some feedback, and you even have some homework. So notice that we're incorporating those principles into what we're doing. We are going to try and start at 8 o'clock sharp tomorrow, depending on traffic. So let's do our best to try to get here first thing in the morning.